of the Moroccan Society of Pediatrics that we to organize this fourth Kawarabi meeting in Rabat, Morocco. So for those who were able to be present in person here, my warm welcomes. And for those who are online, please stay with us. We have a fantastic program and very relevant topics. So stay with us and participate and stay tuned. And shukran jazilan. And now I will ask our president of the Kawarabi, which is Ustad Najib Dahdah, to come and he will tell you about the pillars of the Kawarabi. Thank you very much.
Bonjour, marhaba, good morning. Oh, tout à la fois. Bon, tout d'abord, j'aimerais dire bonjour à nos collègues marocains de nous avoir accueillis grandement et d'avoir facilité ce congrès et la mission de Kawarabi. I would like to thank our Moroccan colleagues who made it easy and simple for us, because this is a hard task to be included in this major congress, to include Kawarabi. So my name is Najib Dahdah. I'm from Lebanon originally, and I am a Canadian. I work at St. Justine Hospital, University of Montreal. Along with my colleagues, Nadine Schweiter and Ashraf Harashi in the United States, we thought that it is very useful, and even more than useful, it's a mission that we had to do to join the Arab nations under one umbrella, the Kawasaki Disease Arab Initiative. The Kawarabi is meant to enhance, improve, and optimize healthcare, diagnosis, treatment, and follow-up of Kawasaki disease patients in Arab nations. We were successful, lucky and successful, because everyone joined arms and hands whenever we asked them to join in. We are now 14 nations, 14 Arab nations, more than 20 institutions on the Kawarabi. We're working together. We have quite a few publications and more to come. We have retrospective and undergoing prospective study collection of data from multiple institutions. We hope also that more than one institutions from Morocco join in to be part of Kawarabi to enhance the science. Encore une fois, merci Dr Hassan Afilal pour l'organisation et de nous avoir accueillis. Merci Cheikh Kenza aussi d'avoir joué un rôle plus qu'important dans ce congrès. J'aimerais aussi très particulièrement remercier Dr Nadine Schweiter, qui avec Kenza, ils ont travaillé très intensément pour la réussite avec les moindres détails. La reconnaissance, recognition is on behalf of Kawarabi for the sake of improving, enhancing outcome of Kawasaki disease patients in our nations. Bienvenue.
Kenza, je te laisse diriger tout. Voilà. I'm sorry, I have to go to another session in neonatology. Thank you so much for being here.
First of all, I will present our eminent pediatric cardiologist, who is Ustad Ashraf Harashi, who is with us and who is working in Washington, D.C. He's one of those who write the American Heart Association guidelines, the last update. So it is an honor to have you with us, Ashraf. Marhaban. And
Thank you so much. Assalamu alaikum, and thank you for hosting us. It's a big honor إن نكون هنا في المغرب. بلد عظيمة وبلد جميلة وبصراحة انبسطنا كثير بالشتاء امبارح. فالحمد لله والحمد لله know this is our first time to be as Kawarabi in Rabat. We're looking forward to come to more often and be here and be engaged and help establish a Kawasaki disease registry within Morocco and beyond.
So we'll start now, and I will ask Dr. Nadia Mebrouk to come to present her series of Kawasaki disease from Rabat. And just few words before starting, please, Nadia. Nadia is assistant professor in the pediatric nephrology, rheumatology, and cardiology in Rabat. And now she will present the large experience of Kawasaki disease of her center. Thank you. You have the floor, Nadia.
Merci beaucoup. Donc, bonjour à toutes et à tous. Tout d'abord, je tiens à remercier chaleureusement les organisateurs de ce congrès, ainsi que tous les participants. Je souhaite adresser un immense remerciement à Madame la professeure Shkirat, Madame la professeure Bouiyed, ainsi que notre maître professeur Bintahila pour leur support durant la préparation de cette étude. My presentation will be in French, but all my slides will be in English. Voici le plan que nous allons suivre, une brève introduction, les objectifs de notre travail, les matériels et méthodes utilisés, les résultats obtenus, une discussion, puis une conclusion avec les perspectives. Un petit rappel, je ne vous apprends rien, la maladie de Kawasaki représente la vascularité systémique pédiatrique par excellence et touche principalement les artères de moyen calibre, avec une prédilection marquée pour les artères coronaires, et survient surtout chez les enfants entre 6 mois et 5 ans. Les objectifs de notre travail sont, d'une part, de rapporter les caractéristiques démographiques, cliniques, biologiques et thérapeutiques des patients atteints de la maladie de Kawasaki traités à l'hôpital d'enfants de Rabat, soit HER, et d'autre part, de déterminer la prévalence de l'atteinte cardiaque dans cette population. Et donc, pour répondre à ces objectifs-là, nous avons mené une étude rétrospective au sein de l'hôpital d'enfants de Rabat, couvrant une période de 23 ans, de 2002 à 2024. Les critères d'inclusion et de non-inclusion de l'étude sont basés sur les recommandations de l'American Heart Association, les diagnostics différentiels de la maladie de Kawasaki tels que certaines infections, le PIMS et l'arthrite juvénile idiopathique dans sa forme systémique ont été exclus. Les données ont été recueillies à partir des registres d'échocardiographies du service P4, saisies sur Excel, puis analysées par la suite. Quant aux données épidémiologiques, ce graphe-là montre l'évolution du nombre de cas de maladie de Kawasaki entre 2002 et 2024 à l'HER, avec un total de 464 cas. On observe une augmentation progressive du nombre de cas, de 7 cas en 2002 à 33 en 2017. Cette augmentation est suivie d'un premier recul en 2018 et 2019, puis nous avons observé un retour au niveau normal du nombre de cas en 2020, et cela même en ayant exclu les cas de PIMS. Ensuite, il y a un autre recul entre 2021 et 2023. L'évolution observée au cours de ces 3 dernières années suit une tendance similaire à celle rapportée en 2024 à Casablanca par l'équipe du professeur Bouiyed. Finalement, on a noté une légère reprise en 2024 par rapport à 2023. Alors, cette dynamique dans les résultats souligne l'importance d'un suivi épidémiologique continu pour mieux comprendre les facteurs influençant l'incidence de cette pathologie pédiatrique. Dans notre étude, la maladie de Kawasaki touche majoritairement les enfants de moins de 5 ans, avec un pic d'incidence entre 1 et 2 ans. Les nourrissons de moins de 6 mois représentent 4% des cas et 21% des cas concernent des enfants de plus de 5 ans. On a une prépondérance masculine avec un sexe ratio de 1,6, ce qui rejoint ce qui est décrit dans la littérature. Quant à la répartition saisonnière des cas, les données montrent une légère prépondérance des cas durant les mois d'hiver. Quant aux manifestations cliniques, tous nos patients présentaient une fièvre prolongée. Les manifestations bucco-cutanées étaient notées dans 80% des cas, la conjonctivite observée dans 67% des cas, l'atteinte des extrémités présente dans 69% de nos patients, et c'est un signe majeur du diagnostic de la maladie de Kawasaki. Les adénopathies cervicales étaient présentes dans moins de la moitié des cas et constituent le signe clinique le moins fréquent. Dans notre étude, 67% des cas correspondaient à la forme complète classique, tandis que 33% des cas présentaient une forme incomplète, qui est plus difficile à diagnostiquer. Ce dernier peut entraîner un retard de traitement par immunoglobuline et augmente ainsi le risque de complications cardiaques. Les autres manifestations, bien qu'accessoires, jouent un rôle clé et crucial dans l'identification des formes incomplètes. Ainsi, dans notre étude, la desquamation périnéale est retrouvée chez plus de la moitié des patients, soit 51% des cas. C'est un signe fréquemment observé en phase aiguë. Sa reconnaissance peut toutefois aider à orienter rapidement le diagnostic. Les autres atteintes systémiques, digestives, articulaires, neurologiques, pulmonaires sont moins fréquentes, mais connues dans les formes les plus sévères ou atypiques. Par exemple, l'atteinte digestive a été notée chez 17% des cas de nos patients, l'irritabilité notée chez 6% des cas, surtout chez les nourrissons, et c'est un signe très crucial. Nos résultats biologiques confirment un profil inflammatoire marqué avec une VS et une CRP très élevées dans la grande majorité des cas. Les anomalies hématologiques les plus fréquentes incluaient la leucocytose, l'anémie et la thrombocytose. La thrombopénie a été observée chez 2% des cas et doit alerter sur un possible risque coronarien. Quant à l'évaluation cardiaque, à noter que les échocardiographies étaient jusqu'au départ à la retraite de notre maître professeur Mitsahila, réalisées par lui-même, ou sous sa supervision. Ils sont désormais effectués par nos soins. Alors, des anévrismes coronaires ont été retrouvés dans 26% des cas, majoritairement de petite taille, les formes modérées dans 4,3% des cas et géantes dans 0,9% des cas, soit 4 patients durant notre étude. Dilatation sans anévrisme a été notée dans 3,4% des cas, l'épaississement des coronaires dans 5,% des cas, la myocardite 1,%, les valvulopathies suivant des régurgitations mitrales dans 10,2% des cas, le plus souvent d'intensité légère à modérée. Les péricardites ont été notés dans 8,3% des cas. Les patients présentant une atteinte coronarienne étaient majoritairement de sexe masculin, soit 79% des cas, avec une prédominance totale dans les cas d'anévrisme géant. L'âge médian était de 28 mois. Près de la moitié des cas ont reçu un traitement par immunoglobuline après le 10e jour et tous les patients résistants aux immunoglobulines ont développé une atteinte coronarienne. Sur le plan biologique, une thrombocytose était présente dans 95% des cas, une leucocytose dans 87%, une neutrophilie dans 79%, une lymphopénie dans 62,5% et une CRP élevée dans 100% des cas. Quant aux volets thérapeutiques, 87% des patients ont reçu une dose standard d'immunoglobuline à raison de 2 grammes par kilo sur 12 heures. 3% des patients ont reçu une seconde dose d'immunoglobuline, ce qui correspond à des cas de non-réponse initiale. 1% des patients n'ont pas reçu d'immunoglobuline en raison de leur non-disponibilité à l'hôpital et de leur coût élevé. 12% des patients ont été vus après 10 jours d'évolution, mais avec une échocardiographie normale, malheureusement. L'ensemble des patients a reçu de l'acide acétylsalicylique à dose anti-inflammatoire, suivi d'un relais à dose anti-agrégante en phase subaiguë. Chez les patients présentant des critères de sévérité, des bolus de solumédrol ont été administrés en complément. Enfin, les anévrismes géants ont justifié une anticoagulation curative initiée par l'héparine de poids moléculaire, puis mise en place d'un traitement antiplaquettaire oral associant acide acétylsalicylique et des pyridamines dans notre expérience. L'évolution clinique à court terme a été rapidement favorable dans la majorité des cas, avec une disparition de la fièvre en moins de 24 heures après l'administration des immunoglobulines. À l'exception des patients ayant nécessité une seconde dose, sur le plan biologique, une décroissance progressive du syndrome inflammatoire a été notée accompagnée d'une thrombocytose transitoire. À moyen et à long terme, l'évolution a été favorable pour tous les patients, avec une régression progressive jusqu'à la disparition des dilatations coronaires ainsi que de petits et moyens anévrismes, en moyenne un délai de 9 mois. Le suivi cardiologique a été prolongé, dans certains cas allant de 1 à 13 ans. Aucun cas de complication thrombotique n'a été observé. Les électrocardiogrammes de contrôle étaient normaux. Quant aux patients avec anévrisme géant, les 3 premiers patients diagnostiqués respectivement en 2006 et en 2010 pour les 2 autres ont présenté une évolution favorable de leurs anévrismes, restés stables tout au long de leur suivi avec des électrocardiogrammes de contrôle normaux. Ils ont ensuite été adressés en consultation de cardiologie adulte à l'âge de 16 ans. Quant au 4e patient, actuellement âgé de 2 ans et demi, son suivi est toujours en cours. Nos résultats sont comparés à ceux d'études récentes. Les données de notre étude sont globalement cohérentes avec celles rapportées dans d'autres études. En particulier, une étude canadienne en 2023 et l'étude de l'équipe du professeur Madame Bouhiad à Casablanca menée en 2024. Plus précisément, l'âge moyen au diagnostic, la répartition entre formes complètes et incomplètes sont similaires. Concernant les complications cardiaques, on a pratiquement le même taux global d'atteinte coronaire. En conclusion, la reconnaissance des formes incomplètes, atypiques, qui posent problème de la maladie de Kawasaki est cruciale pour une prise en charge optimale. Cela donc nécessite une meilleure coordination multidisciplinaire, la standardisation du protocole de collecte des données, ainsi que la création d'un centre de référence et d'un registre national pour améliorer le suivi et la qualité des soins est souhaitable. Et je vous remercie pour votre attention.
That was a brilliant presentation. I love your slides. I was really impressed with it. We have time for one question. Does anyone have any questions in the audience? When I was looking at your slides, okay, go ahead, Najib.
Yeah, I hope there will be more questions even after this session. But basically, I'm really impressed with the number of cases that were collected over these years with the detailed information. Congratulations.
Thank you very much.
We certainly need to have you in Kawarabi, so
Thank
this
you.
is a given.
It will be a great pleasure for me.
Yes.
Thank you very much.
So thank you very much for this excellent presentation and collection.
Thank you.
Thank you so much. Our next speaker is going to be on Zoom, online. Dr. Manal Urbi from Algeria will be talking about Kawasaki disease series in Algeria. Nadine, sorry to do this, but do you want me to move on with the third presenter who's in the room? No, no. Do you know how to start to get the presentation here? Need help? Yeah, I can. You have her presentation?
Yes, EKRAN.
Yes. Our next speaker is Dr. Hala Agha, who comes to us from Egypt, and she will be talking about the Egyptian experience in the management of Kawasaki disease. Dr. Hala Agha hosted us a couple of years ago in Cairo and established the new program EKRAN, so she will be also discussing EKRAN with us.
Okay.
Welcome, Dr. Hala.
Version anglais ou français? Anglais. C'est VO.
Where is it working?
Les flèches pour votre lien.
Ici.
Non? Je peux augmenter cette partie?
No, I don't. Yes, please, here. Okay. Bonjour. Good morning, ladies and gentlemen. It is my pleasure here to be the first time in Rabat. Thank you for all organizing committee, especially Dr. Kenza and Dr. Nadine, who facilitated everything. I will try to present very shortly about Egyptian experience in management of Kawasaki disease, EKRAN. This is my disclosure. I haven't financial issue. During my presentation, I will highlight on the burden of KD and to present the background of EKRAN and its relation to Kawarabi, and to summarize the important activity during EKRAN conference in October, Cairo. It's not working. All of us know the burden of Kawasaki disease and the relation to the life of children and even to the adult, and the burden on the heart and the coronary. If the coronary is affected, it leads to coronary aneurysm, possibility of thrombosis and stenosis, and may lead to myocardial infarction, sudden death. So it is very serious disease, and we should deal rapidly to avoid this complication. If we deal properly, it leads to a decrease the incidence of coronary aneurysm from 25 to around 5%. So it is very serious disease and not just simple vasculitis. What is the problem and the challenge when you are diagnosing Kawasaki disease? The problem is we are depending on the clinical evaluation, and the most problematic problem in this patient is the sequential, and not just the simultaneous appearance of all the symptomatology at the same time. So the best who is dealing with this patient, lastly, can diagnose properly, but the first doctor can be impressed just a fever and rash. The children usually presenting with atypical or incomplete Kawasaki never present with complete form. This is the main problem and the challenge when you are diagnosing Kawasaki disease. All of us know that our dream to diagnose in children below 18 years properly by a frontliner doctor, by a proper approach, and not over or underdiagnose this very serious disease. But you know all that numerous cases are managed by different protocol, and even the case definition are different from one doctor to another doctor, and improperly dealt by pediatrician and pediatric cardiology, and all are talking by different language. This is one of the main problems. So Professor Dada has very clear vision how to improve diagnosis and care and the outcome of children and adults with Kawasaki in Arab nation. And this is the idea of Kawarabi, which is the first Kawasaki disease Arab initiative. He had clear objective of Kawarabi to foster research and multi-center collaboration between academic institutes in Arab area to improve accurate diagnosis and promote cardiovascular surveillance and management of the patient with coronary artery complication throughout from the onset till the adult life, and maintain a registry. It's very important to maintain a registry to know our status to deal with this very serious disease. What about Egypt? In Egypt, we have very good health care service in Egypt, center of training, either university hospital, Ministry of Health hospital, armed force military hospital, and very well educated and trained university hospital staff and other. And the trainer coming from even from Arab area, besides our Egyptian fellows. We have certificate, MD, master, and recently we have Egyptian Board of Pediatric and Pediatric Cardiology. Despite all this healthcare, we have only 13 Egyptian PubMed publications related to KD as a case series and case report. I participated in 2 publications, 2017 with my colleague, Dr. Hala Hamza. What about acute Kawasaki disease? On our hospital, Abu Rish Hospital is one of the biggest tertiary centers, and I registered 2 incomplete cases of Kawasaki disease. My dear colleague Sharif did a publication about Kawasaki disease in adult and misdiagnosed as myocardial infarction, and we have in Egypt evidence-based consensus about Kawasaki disease. In my 2 cases of the cases series, we have 64 KD patients within 4 years. All received intravenous immunoglobulin, but after 10 days. So it is somewhat, there is a delay. That is why we have around 50% of this patient has a coronary complication and 23% has a giant coronary aneurysm. And we found that the platelets count thrombocytosis is very related to this coronary abnormality. What about incomplete Kawasaki disease in Egypt? I published this 4-year-old female presented with prolonged fever for 1 month and misdiagnosed as chickenpox. She had non-purulent conjunctivitis and periannular annular desquamation and giant aneurysm of both coronary artery. She responded well after the 2nd dose of intravenous immunoglobulin as it's delayed presentation. This is the main problem of Kawasaki. Huge giant aneurysm during the first presentation, and after 5 years, multi-slice CT show multiple stenosis of these 2 big coronary artery, despite the patient is totally asymptomatic. She is now around 16 years. Another patient with incomplete Kawasaki presented with hepatitis, 3 years old, presenting with just hepatitis, but it is incomplete Kawasaki. He had presence of 2 clinical findings, desquamation of the tip of the finger and bilateral bulbar conjunctival injection. By lab, we have hypoalbuminemia, elevated ALT, and thrombocytosis. Returning back to our Egyptian status, what is the incidence of KD in Egypt? We don't know. Did we have epidemiological study? No. Did we have a multi-center collaborative research with different Egyptian academic universities? No. That is why I found and discussed with my dear Professor Dada, what about EKRAN? As an acronym, Egypt Kawasaki Disease Research and Advocacy Networking. We launched EKRAN on 27 October 2023 as a trial of bridging the gap to collect our data. So EKRAN is a program. It is an Egyptian program aiming at raising awareness of disease, encouraging and dissemination of research on Kawasaki disease, and providing support and assistance of the patient and their family. So our mission, it is not a competitor of Kawarabi, is a pairing EKRAN. EKRAN يعني قرين لها. Kawarabi is the new sister initiative aiming to implement Kawarabi mission in Egypt, and objective to activate and to strengthen the communication between those interested in Kawasaki disease, whether general practitioner or specialist, and to advocate patient and their family. We have activities, holding training courses and workshops, and encouraging dissemination of research, holding seminar, informing the community about KD. And thank you, Professor Harahish. First, he is reported Kawasaki on 65, then intravenous immunoglobulin on 80, and IKD in 2013, and Kawarabi on 2020, and lastly on October 2023 for EKRAN. This is a summary about our activity in Egypt. The video is working. The video is working? I hope so. Click. Please help me. I think it's not. I think it's not working, just an image. It is a video clip. So you can go outside and... The video clip is outside.
No.
Just an image?
Yeah, just an image.
Nadine, it's just an image.
So.
So? No, so it is an image? Okay. So, no, it is...
Let's have a question and then maybe hopefully
Yes, so to wrap up, KD spectrum is present in Egypt. Awareness is very important, and early intravenous administration and other medication, collaborative multi-center research study through Egyptian network of KD is mandatory to know our status. Thank you.
Thank you, Dr. Hala. This is very impressive. I want to ask you, since EKRAN was established, have you noticed a rise in the number of patients? Have you seen patients being diagnosed in peripheral areas that didn't happen in the past? The awareness is leading to more patients referral.
Yes, very important question. Thank you, Ashraf. Yes, of course, any patient now, my colleagues and even senior doctor are consulting me about this patient. This is the task of Kawarabi and EKRAN. A proper approach, even all of us know what is the case definition, but how to manage and how to deal properly by proper management. Yes, and my second presentation, I will highlight on this issue, how we can improve the diagnosis, how we can manage properly our KD patient. Thank you, Ashraf. The video is not working.
Thank you, Dr. Hala, again. Do we have our colleagues from Algeria online? Are they going? Yes. Okay. Can we please have Dr. Manal Gurbi talking to us about Kawasaki disease in Algeria?
Capitale d'Alger. Comme vous le savez, la maladie de Kawasaki est une vascularite systémique essentiellement pédiatrique qui a été décrite pour la première fois par le pédiatre japonais Tomisaku Kawasaki en 1961 à Tokyo. Ce n'est qu'en 1967 que le premier papier est apparu. C'est la principale cause de cardiopathie acquise dans les pays développés. L'âge de prédilection se situe entre 6 mois et 5 ans et le pronostic est surtout lié à l'atteinte coronarienne. Qu'en est-il en Algérie? Dans notre service, il y a eu déjà 2 publications. La première publication, c'était une étude prospective menée dans notre service par le professeur Baudief entre 2005 et 2008, qui avait inclus 64 malades et tous les services de la wilaya d'Alger avaient participé à l'époque et l'incidence était de 3,8 sur 100 000 enfants âgés de moins de 5 ans. La deuxième publication, c'était une expérience toujours dans notre service sur 10 ans, entre 2005 et 2014, qui avait inclus 135 patients. Il y a eu aussi une autre étude, c'était une autre étude publiée par professeur Bekkar, qui avait intéressé surtout les hôpitaux de l'Ouest algérien, qui avait inclus 62 patients. Notre étude, c'est une étude rétrospective monocentrique et descriptive menée sur une durée de 20 ans, entre janvier 2005 et février 2025. Les objectifs de notre étude étaient d'identifier les caractéristiques cliniques et épidémiologiques de la maladie, d'étudier la fréquence, le type et l'évolution des complications cardiaques et de préciser les modalités thérapeutiques. Donc, pour nos résultats, 279 malades étaient inclus durant ces 20 ans. Nous avons exclu les 57 cas de PIMS hospitalisés durant la pandémie COVID-19 entre 2020 et 2022. Et les critères de diagnostic à l'admission utilisés sont ceux de l'Académie américaine de cardiologie de 2004 pour les enfants hospitalisés avant l'année 2017 et ceux de 2017 revisités pour les enfants hospitalisés après l'année 2017. Les critères déjà connus, c'est une fièvre au-delà de 5 jours, associée à 4 sur 5 critères, les principaux critères. Pour les résultats, donc l'approche épidémiologique, pour la répartition des cas selon l'âge, là on remarque que plus de 85% de nos malades sont âgés de plus de 12 mois et moins de 5 ans. Et près de 15% sont âgés de moins de 12 mois et plus de 5 ans. L'âge moyen au diagnostic est de 30 mois, avec des extrêmes allant de 8 mois à 12 ans. Si on compare nos résultats à d'autres séries mondiales, telles que la série taïwanaise sur une durée de 10 ans, entre 2004 et 2014, qui avait inclus plus de 1000 malades, l'âge moyen était de 32 mois, avec la distribution selon l'âge était pratiquement identique à celle de notre série. Le sexe ratio était de 1,7, donc 64% de nos malades, c'était des garçons, 36% des filles. Nous avons eu 3 cas de récurrence, un cas familial et la mortalité était nulle dans notre série. Pour les aspects cliniques, le délai moyen au diagnostic était de 6,88 jours avec des extrêmes allant de 3 jours à 31 jours. Mais là, on remarque qu'en la première décennie entre 2005 et 2014, seulement un tiers de nos malades étaient admis avant le 10e jour de la fièvre. Alors que ces 10 dernières années, entre 2015 et 2024, près de 87% de nos malades étaient hospitalisés avant le 10e jour de la fièvre. Ceci est expliqué par une meilleure connaissance de la maladie par les généralistes et les pédiatres. Donc, la maladie est de plus en plus diagnostiquée précocement. Si on compare notre résultat par rapport à la série taïwanaise, le délai moyen au diagnostic chez eux était aussi de 7 jours, donc ce qui rejoint nos chiffres. Pour les critères cliniques diagnostiques, les signes cliniques, si on les compare avec les autres séries mondiales, pratiquement on a les mêmes résultats. Sauf que les adénopathies cervicales, on remarque qu'elles sont moins fréquentes dans notre série. Elles ont représenté que seulement 47,5%. Même si on la compare avec la série algérienne de l'Ouest algérien publiée par professeur Bouka, il a trouvé aussi seulement 49% des malades qui avaient des adénopathies cervicales. Mais on remarque l'éruption périnéale, elle était présente chez 65% de nos malades, alors qu'elle ne fait pas partie des critères diagnostiques. Nous avons eu aussi 2 formes psoriasiformes et 3 de nos malades avaient réactivé leur cicatrice BCG. Qu'en est-il des complications cardiaques? Pour l'atteinte de tinique, on remarque que la myocardite est rare dans notre série. Donc, on l'a retrouvé dans 2,15% des cas seulement, même la péricardite. Si on la compare à d'autres séries japonaises, elle était présente chez 1/3% de leurs malades, alors qu'elle était fréquente dans notre série des PIMS, des malades qui étaient hospitalisés durant la pandémie COVID-19. Donc, la myocardite était présente chez 23% de nos malades, alors qu'elle est recherchée systématiquement à la phase aiguë chez tous nos malades. L'atteinte coronaire n'a concerné que 16,48% de nos malades. C'était essentiellement une dilatation coronarienne, présente chez 8,9%. 4,6% c'était des anévrismes de petite et de taille modérée. Malheureusement, les anévrismes géants étaient à concerner donc 8 patients avec un pourcentage de 2,88% si on le compare avec d'autres séries où chez eux, ils avoisinent les 0,26%. Ceci peut-être est expliqué car notre service quand même reste un service de recrutement et que les malades sont arrivés probablement tard. Ça va être plus détaillé par ma collègue Madame Hamadouche. L'atteinte coronaire était appréciée par les critères de la Société japonaise de cardiologie les premières années, mais actuellement, on est en train d'utiliser les Z-scores de l'Académie américaine de cardiologie. Pour les aspects thérapeutiques, un tiers de nos patients avaient reçu de l'aspirine seule. Il faut savoir que ceux qui ont reçu l'aspirine seule, ce sont des malades qui sont arrivés en retard. Donc, après la phase fébrile, ils étaient apérétiques. Et 76% de nos malades avaient reçu association immunoglobuline et aspirine. Mais on remarque là que la première décennie, entre 2005 et 2014, seulement 63 de nos malades avaient reçu les immunoglobulines, alors que ces 10 dernières années, entre 2015 et 2024, près de 90% de nos malades ont reçu le traitement standard, c'est-à-dire 2 grammes par kilo d'immunoglobulines. Si on compare notre taux d'utilisation des immunoglobulines dans notre service qui avoisine les 90% par rapport aux autres pays développés, là, quand même, ça reste un taux très satisfaisant. Même si on le compare par rapport au monde arabe, il y a eu une publication déjà publiée par le Kawarabi. Si on le compare aux grandes villes, donc notre taux reste quand même assez satisfaisant. Il y a eu quand même 16 patients qui étaient réfractaires au traitement. Ils ont reçu les corticoïdes dans 6,5% des cas. Un cas a reçu le méthotrexate et le dernier malade a reçu l'IL1 type Anakinra après échec aux 2 cures d'immunoglobuline et les bolus de corticoïdes. Pour conclure, je dirais que la prévalence de la maladie de Kawasaki est certainement plus importante que ne le reflète notre série, mais beaucoup de progrès ont été réalisés. Elle constitue actuellement un nouveau risque cardiaque chez l'enfant algérien. Le délai diagnostique s'est amélioré ces 10 dernières années. Elle est devenue exceptionnellement grave depuis qu'elle est traitée de manière précoce et efficace par les immunoglobulines. Et au plan thérapeutique, le taux d'utilisation des immunoglobulines reste satisfaisant comparé à celui des pays où la maladie est prévalente. Et je vous remercie.
Dr. Manal, thank you so much for this great presentation. The audience, we have 30 people in the room and we can hear you and see you clearly. It was really great. One question came from Dr. Asso from Sulaimaniya, Iraq, and his question to you is...
Zoom qui nous permet de suivre sans rien payer, quoi. Il y a une inscription, des choses comme ça, mais moi, je suis étudiant. Zoom, là, va te dire de suivre en ligne.
Please, can you mute your microphone, please? Because we are hearing you. Thank you.
Okay, sorry for that. So for Dr. Asso's question, how come there were no mortalities in your series in Algeria? What would you contribute that to?
Manel, Dr Asso d'Irak pose la question, est-ce que vraiment vous n'avez eu aucun taux de mortalité 0%? Il est un petit peu surpris de ce taux de mortalité sur une grande série comme la vôtre.
Aucun décès.
Dr Asso, she confirmed that there is no death. Any questions? Okay.
Yeah, thank you very much. Merci, Manal. So I do have this comment. It's really important. We just saw 3 series of 3 countries talking about Kawasaki disease. It's very important. If we don't ask a question, we don't have an answer. So ask and there shall be answers. In other words, I think this is impactful from Kawarabi being present, asking what's going on in your city, in your country, in your institution. And we just saw how important was the Rabat series, going from many years and the incidence was up and treatment was better. Same thing for what we heard from Algeria. So thank you very much. Merci Manal.
Merci à vous.
Thank you. So now we'll move to next talk, which is the talk of Professor Nassera Hamadouche. She's chief of the neonates, and she has a consultation of cardiology and of Kawasaki disease. She's from Algeria, from Hospital Jilali bin Khanshir. Please, Dr. Nassera, you can start your presentation.
1 minute. 1 minute, please.
Okay, okay. We're waiting for you. Maybe if there is some questions about the previous presentation, we can, yes? Please.
Bonjour, chers collègues. Donc, je vais essayer de vous présenter 8 cas d'anévrisme.
I have a question to Dr. Hala. Should I ask or? Okay, no problem. I can ask later.
Maintenant, c'est bon.
Docteur Nassera, vous êtes prête? On peut commencer?
Oui, oui.
Allez-y. Merci.
Ok. Donc, bonjour, chers collègues. Donc, je vais vous présenter 8 cas d'anévrisme géant qui sont suivis au niveau de notre service. Donc, les anévrismes géants dans la maladie de Kawasaki sont des complications qui sont rares, mais potentiellement mortelles. Alors, un anévrisme géant coronarien a un diamètre qui dépasse les 8 mm et survient avec une incidence entre 0,25 et 2%. Ils peuvent être responsables d'infarctus du myocarde et de décès dans 1 à 5% des cas. Et ceci est secondaire, soit une thrombose, calcification ou bien essentiellement un développement de sténose. Donc, nous avons mené une étude rétrospective sur dossier d'enfants hospitalisés et suivis au niveau de notre service à l'hôpital de Bertraya d'Alger entre janvier 2005 et janvier 2025, dont l'objectif était de déterminer la part des anévrismes géants chez les enfants hospitalisés et dont les caractéristiques et donner également les caractéristiques de ces malades. Nous avons colligé 279 enfants qui ont présenté une maladie de Kawasaki ces 20 dernières années. Et des anévrismes géants des artères coronaires sont retrouvés chez 8 enfants, soit avec une fréquence de 2,26%. Concernant les données épidémiologiques, alors tous les enfants avaient moins de 5 ans, dont le tiers avait moins de 12 mois. L'âge moyen était de 22,8 mois, avec les extrêmes de 5 mois à 5 ans. Il y avait une prédominance masculine nette, il y avait 7 garçons pour une seule fille. On avait également eu un cas de recrudescence et de récurrence, et on n'a pas eu de décès. Pour ce qui concerne les données cliniques, alors les données, il y a un délai moyen au diagnostic est de 21 jours avec des extrêmes de 8 jours à 60 jours. On a constaté également qu'il y a un retard d'administration des immunoglobulines pour tous les malades qui ont reçu les immunoglobulines, puisque 2 n'avaient pas reçu d'immunoglobulines. On les a reçus après, pour le premier à 2 ans et le deuxième malade 4 ans après sa maladie de Kawasaki. Tous les malades avaient des formes complètes de la maladie. Sur le plan thérapeutique, 6 malades ont reçu des immunoglobulines. Parmi ces 6 malades, 2 étaient réfractaires et on était obligé de passer au bolus de corticoïdes. 2 patients n'avaient pas reçu de traitement, comme j'avais dit tout à l'heure. On les a reçus tardivement, 2 ans après, 4 ans après la maladie. Et la maladie était découverte d'une manière fortuite. Sur le plan évolutif, un malade a présenté un syndrome coronarien aigu. 4 patients ont présenté des thromboses avec calcification et 3 patients sont déjà au stade de sténose. On n'a pas eu de décès. Alors, je vais commencer par le premier cas clinique. Alors, c'est un enfant âgé de 4 ans qui avait déjà des anévrismes géants, il était déjà sous warfarine. Et à l'âge de 6 ans, il a présenté des douleurs thoraciques. Au niveau de l'ECG, on a noté qu'il y avait un sous-décalage du segment ST et les troponines étaient très élevées. On a hospitalisé l'enfant en 2013, donc il s'agissait d'un syndrome coronarien aigu. Au niveau de la coronarographie, donc on a noté une occlusion complète de l'artère coronaire droite avec une sténose au niveau de l'interventriculaire antérieur. L'anévrisme géant était de 14 mm et il s'étendait sur 16 mm. L'enfant a bénéficié d'une chirurgie de revascularisation, il a bénéficié d'un double pontage coronarien. Pour ce qui concerne le deuxième cas clinique, c'est un nourrisson de 18 mois qui a présenté une fièvre prolongée de 2 mois et le diagnostic a ensuite été fait, c'était également une forme complète de maladie de Kawasaki. Le CG était normal, il avait un triple anévrisme coronarien au niveau de l'IVA de 13 mm, de la circonflexe de 11 mm et au niveau de la coronaire droite de 14 mm. La coronaire droite était déjà thrombosée. Par ailleurs, il avait un épanchement péricardique de grande abondance et il avait déjà une cardiomyopathie ischémique avec des fonctions ventriculaires gauche qui étaient altérées et il avait une insuffisance mitrale grade 3 par dilatation. La coronarographie qui a été faite 3 mois après a confirmé la dilatation anévrismale et les anévrismes géants. La scintigraphie myocardique à la percentile a été également faite, qui a retrouvé une ischémie d'effort inférolatérale. L'angioscanner cardiaque, donc après 11 ans d'évolution, donc en 2025, a retrouvé une IVA proximale avec un anévrisme calcifié de 10 mm, une circonflexe avec un anévrisme calcifié également de 9 mm, et au niveau de la coronaire droite, il y a un anévrisme de 6 mm avec une infiltration calcifiée et athéromateuse qui était très sévère de 37 mm à cheval sur le segment 1 et le segment 2, responsable d'une sténose sévère au niveau du segment 1. Pour le troisième cas, c'est un enfant également de sexe masculin qui avait 5 mois, qui a fait une fièvre prolongée et le diagnostic n'a été fait qu'après 20 jours de fièvre. L'échographie a confirmé 2 anévrismes géants, à savoir au niveau de l'IVA de 12 mm, au niveau de la coronaire droite de 9 mm. Le cathétérisme coronarien a retrouvé une occlusion totale de la coronaire droite au niveau du segment 2 et qui a été reprise par de la circulation par le réseau gauche. Le cathétérisme coronarien qui a été fait à l'âge de 6 ans a retrouvé une double occlusion coronarienne droite au niveau du segment 2 et au niveau de l'IVA également au niveau du segment 2 avec des collatérales. Récemment, après 9 ans d'évolution, a retrouvé au niveau de l'IVA une lésion occlusive qui s'étend sur 7 mm. La circonflexe a été retrouvée normale au niveau de l'angioscan et un double anévrisme calcifié au niveau de la coronaire droite, à savoir un anévrisme de 5,5 mm et 11 mm également, c'est un autre anévrisme au niveau de la partie du segment S2. Pour ce qui concerne le quatrième cas, c'est également un nourrisson de 16 mois de sexe masculin qui a présenté une forme complète et une fièvre de 20 jours. Donc, comme vous remarquez, il y a régulièrement un retard au diagnostic à la phase aiguë. Et c'est le cas, comme j'avais dit tout à l'heure, pour tous nos malades. L'échographie avait retrouvé un triple, donc de 3 anévrismes, dont 8 au niveau de la circonflexe et 10 mm au niveau de la coronaire droite. Pour le 5e cas, c'est un enfant de 5 ans de sexe masculin qui a présenté une fièvre jusqu'au 11e jour où le diagnostic de maladie de Kawasaki dans sa forme complexe a été fait. Donc, une première cure d'immunoglobuline, l'enfant était toujours fébrile, il a également reçu une deuxième cure et on était obligé d'arriver au bolus de corticoïdes. Donc, pour ce malade, donc, il est resté un enfant assez longtemps fébrile, donc il a augmenté les mesures de ses anévrismes. Et une année après, il a présenté il y a eu une récurrence de la maladie de Kawasaki dans sa forme complète, et ceci après une semaine d'une varicelle. Les anévrismes avaient doublé de volume, passant pour la coronaire droite à 22 mm et l'IVA à 25 mm. Donc là, c'est la coronarographie. Une autre coronarographie qui a été faite après 9 ans, donc en 2023, a retrouvé une occlusion totale du tronc commun gauche avec une coronaire droite de 23 mm. Pour le sixième cas, c'est un enfant également, c'est un nourrisson de 9 mois qui a présenté également une maladie de Kawasaki dans sa forme complète. L'échographie a retrouvé 2 anévrismes géants au niveau de l'IVA de 12 mm, au niveau de la coronaire droite de 9 mm. Il a reçu les immunoglobulines au 10e jour, donc il y a régulièrement un retard. Et cet enfant, donc je note que cet enfant était suivi dans une autre ville, c'était pas au niveau de la wilaya d'Alger, au niveau de la capitale. Il a été suivi pendant 6 ans, il n'était pas sous anticoagulation. Il n'a pas présenté de thrombose. Donc ça, ce sont les images du Koroscan qui a été fait en 2024. Et une échographie récente de 2025 qui retrouve les anévrismes de la coronaire droite de 11 mm et du tronc coronarien gauche de 5 mm. Pour le 7e cas, donc l'avant-dernier cas, donc c'est un enfant également de sexe masculin de 23 mois qui porteur d'un syndrome de Noonan avec une cardiomyopathie hypertrophique. Donc la découverte de la maladie de Kawasaki a été faite d'une manière fortuite. C'est un enfant qui a subi un bilan préopératoire. Donc, il a eu un scanner thoracique et on a retrouvé les anévrismes géants. Et dans ses antécédents, quand on a fait l'interrogatoire, il y a notion d'hospitalisation à l'âge de 12 mois pour une fièvre persistante. Donc, ça, c'est l'angioscan qui retrouve une coronaire droite à 14,4 mm, une IVA à 7,8 mm et une circonflexe à 5,9 mm. Par ailleurs, il y a le tronc de l'artère pulmonaire et les artères pulmonaires.
Please, Dr. Hamadouche, you have only 1 minute, please.
Ok. Donc, le dernier cas, c'est une fille qui a présenté également des anévrismes géants. Donc, en commentaire, ce qu'on peut dire, c'est que les anévrismes géants ont été rapportés comme survenant avec une incidence de 0,2 sur le plan théorique. Notre fréquence élevée de 2,86 est probablement liée en partie à un biais de recrutement, puisque ces enfants ont été envoyés de l'intérieur du pays. Les facteurs de risque connus pour le développement d'anévrismes géants ont été retrouvés également chez nos malades, à savoir le prédominance du sexe et les nourrissons. Donc, dans notre série, il y a la découverte fortuite de deux enfants, voilà, donc un à 2 ans, un à 4 ans après. Donc, les thromboses survenues chez nos malades pourraient s'expliquer en partie par un problème de gestion et de difficulté de surveillance de l'INR. Voilà. Donc, 3 de nos patients sont au stade d'indication de revascularisation coronaire. Donc, on peut dire que l'intervention chirurgicale, à savoir le pontage orthocoronarien, doit être envisagée même en cas d'atteinte d'un seul vaisseau, en particulier chez les jeunes patients. Ça, c'est sur le plan théorique dans une étude de Tsuda. Donc, pour conclure, on peut dire qu'on a un souci au niveau d'autres pays pour le suivi de nos malades pour rechercher une ischémie myocardique, à savoir pour faire une scintigraphie. Donc, on a des soucis pour la faire chez les enfants et également pour l'intervention chirurgicale. Donc, il n'y a aucun centre chez nous chirurgical qui peut faire l'intervention chirurgicale. Je vous remercie.
Thank you, Dr. Nassera Hamadouche, for this great presentation about G and coronary aneurysm in Kawasaki disease. Maybe there is some questions. Yes.
Thank you, Nassera. Very illustrative and elegant presentation. I think.
Thank you.
Okay. All right. Yes. I think it is very interesting to show our status here in Arab area, whatever, from Algeria, Morocco, and Egypt. We are different. Really, we are different. We know that Kawasaki is exposure virus or bacteria on genetically predisposed patient and immunological response. So we are genetically different. Her series totally different from our series and different from Morocco and different from other area without mortality. We have mortality in Egypt complicating giant aneurysm. So I think it is time now to work on genetic basis. What is your comment about genetic basis?
We don't have also mortality in our series, even with the G and coronary aneurysms. Yes. So in the Rabat in Casablanca is the same.
Without mortality.
Yes, without mortality.
Yes.
Juste en Tunisie, j'ai déjà présenté la série au sein du Kawarabi, 295 cas. Il y avait un seul décès de 4 mois qui avait des anévrismes multiples. Il avait 11 anévrismes, il est décédé, un seul décès sur les 295 cas tunisiens.
Bonjour, merci beaucoup. Je me pose la question de la mortalité qu'on a quand même, je pense, même en Europe, un peu sous-estimée. Je crois qu'il faut faire quand même attention qu'il y a des patients que vous ne voyez pas, qui vont en réanimation, par exemple, et qui peut-être sont étiquetés choc septique, etc., ou mort subite. Je sais aussi que selon les cultures, on accepte plus ou moins le principe de faire comme on appelle une anatomopathologie. Et donc, ça aussi sont des facteurs parfois qui peuvent être limitants pour connaître la cause, effectivement, de ces décès aigus. On sait que et ça est d'autant plus renforcé que la mortalité, elle est souvent relativement précoce. Quand les patients meurent d'un incident cardiaque, la maladie de Kawasaki, c'est très souvent au tout début. Donc ces patients qui peut-être qui n'arrivent pas jusqu'à chez vous ou qui ont été vus en réanimation. Donc je pense qu'il faut faire attention quand on dit il n'y en a pas. Je pense qu'il faut les chercher et faire ces études un peu aussi avec les réanimateurs. D'abord pour qu'ils y pensent, parce que c'est très difficile le diagnostic, il y a très peu de symptômes, vous le savez, hein, quand plus les enfants sont petits et moins il y a de symptômes, on n'a pas grand chose à se mettre sous la dent. Donc si on n'y pense pas, on ne va pas faire le diagnostic et on va dire il est mort d'un choc septique. So I don't know if I need to translate, but so I will. You can do it, maybe.
Donc, si je peux me permettre de répondre, s'il vous plaît.
Oui, bien sûr, allez-y.
Oui, c'est-à-dire au niveau de notre série de 279 patients qui sont suivis, on n'a pas eu de décès. Après, probablement, comme dans le monde entier, il y a probablement des morts subites de malades qui ne sont pas suivis et qui ne sont pas diagnostiqués. Donc, notre réponse, c'était pour ce qui concerne notre série. C'est-à-dire, on n'a pas eu de décès. Voilà. Voilà. Peut-être, il y a l'incidence qui est faible à notre niveau parce que le diagnostic n'est probablement pas fait pour tous les malades. Donc, si on voit parmi les 8 cas que j'avais présentés, 7 cas sont venus d'autres villes, pas de la capitale. Et le diagnostic a été fait tardivement parce qu'ils ne connaissent pas la pathologie. Donc, le diagnostic a été fait rétrospectivement pour la majorité des malades. Et pour 2 malades, après 2 ans et l'autre après 4 ans. Donc, il y a beaucoup. La pathologie n'est pas encore très bien connue à notre niveau. Voilà.
Merci, شكرا جزيلا. بالنسبة للسؤال الأستاذة من مصر. السلام عليكم. هناك عمل دولي شاركنا فيه نحن في قسم الأمراض التعفنية في المستشفى العربية تفهمين؟
Oui, نعم. نعم.
Yes. We are in a collaborative study and about MIS-C, multi-inflammatory syndrome, and the group found a predisposition to this situation in some patients, and the 2 genes are known. They are implicated in the inflammatory response. So we think that also in Kawasaki there will be a predisposition like that, and so this point must be evaluated also in the Kawasaki children, I think, because the problem is probably more wide than we thought, and this is Kawasaki as MIS-C are post-infectious inflammatory syndromes. Thank you.
Yes, شكرا.
My second presentation tomorrow, inshallah.
Inshallah.
I will present what about Kawasaki and MIS-C before and after COVID. It's totally different. We gathered a lot of patients, 246, before COVID, then during and after COVID. They are totally different, and I will show this presentation. So it is era now not to document only KD or Kawasaki or MIS-C, but compare before our era. and it is totally different. Yes, by clinical presentation, by the lab, by echo. So we should study before and after, and I think it's time to study genetically in Kawasaki and Messi. Thank you.
Yes, please. It's enough?
Okay. Thank you guys so much. This was really great. We will have more time to have more questions later. Dr. Dahtah would like to give a compliment to Dr. Samir Laj from Algeria for helping establish the registries that you guys have seen so far. So thank you, Dr. Laj, for all of your help. We will move to the second session. This session is supposed to be a challenging cases discussion. We will have each presenter give a 4-minute presentation, and then we will have an open discussion. May I ask everybody online to please mute unless you are a presenter, a speaker. And for our IT, can you mute everyone online? Our first speaker is from here, Dr. Sara Al-Siddiqi. Dr. Sara Al-Siddiqi will be discussing a challenging case from Morocco.
Please, can you mute? Because we hear you. Thank you.
Oh, hello everyone, I'm Dr. Sara Al-Siddiqi, senior resident at the El Harouchi University Hospital of Casablanca. I'll be presenting to you one of the challenging cases of our department. It's a 15-year-old boy with high-grade fever lasting for 12 days, associated with diarrhea, abdominal pain, and unilateral cervical lymphadenopathy. Yes. Okay. The patient self-medicated with the Infliximab. Then the persistent symptom drove the patient for his first consultation. Ceftriaxone and metronidazole were prescribed. The evolution was marked by the onset of a skin rash with conjunctivitis, cracked red bleeding, and paling lips. Afterward, the patient attended his second consultation due to the persistence of all the symptoms. Then urine test found leukocyturia and hematuria. In August 24, the patient was admitted to a private clinic for 6 days, where pardon, j'ai un problème avec le. Ça marche? Okay, donc in August 24, the patient was admitted to a private clinic for 6 days, where a Kawasaki disease was diagnosed. He was treated with aspirin, and at first there was no cardiac damage at the first cardiac ultrasound, but we found an hydrocholecyst on the abdominal ultrasound. Then, with the persistent fever and inflammatory state, the patient was transferred to our facility. The clinical exam showed an impaired general state, a high-grade fever with bilateral conjunctivitis, fissured and erythematous lips, edema and desquamation of the skin at the palms and soles, and erythema of the perineal region without lymphadenopathy, in addition to elevated CRP and erythrocyte sedimentation rates. The lab test showed an anemia, hyperleukocytosis, neutrophilia, and thrombocytosis. However, all the infection assessment was negative. The cardiac involvement on the 27th day of fever was described as a severe aneurysm of all coronary arteries with a normal ejection fraction of the left ventriculi and no coronary thrombosis. As a treatment, the patient received an IVIG combined with aspirin with positive outcome. Apyrexia was obtained 5 days after the IV treatment, negative inflammatory test after 7 days of IV treatment. In the last cardiac ultrasound, there was a persistence of aneurysmal dilatation of all coronary arteries. Finally, our take-home message: this clinical case highlights the diagnosis dilemma in case of atypical manifestation and late referral. Aspirin alone is not the gold standard treatment for Kawasaki disease, and IVIG must be started in the first 10 days. Thank you for your attention.
Thank you so much for this great presentation, and congratulations for your platform presentation. First, couple of questions. Today you will see one of my colleagues, Dr. Yara, will be talking about an algorithm. So for example, if the child received IVIG and the fever persists after 36 hours, that's when we start talking about other therapies. I'm wondering, why did we wait? The fever took 5 days to disappear after IVIG.
Okay.
I can answer. Tu peux répondre? Because this patient was referred to our facility after 10 days. He was in another hospital. Yes, he was treated in another hospital in another city, and then he was referred to us after 10 days of fever. And in the first hospitalization, he was diagnosed Kawasaki disease, but he received only aspirin, as we did before.
So let's ask Dr. Dahdah. So, you know, this is a child who comes after 10 days of illness. There is some sort of inflammation. So if you were called, would you advocate for IVIG at the time of aspirin?
Yeah, thank you, Ashraf. This is a very live question, very important question. It happens everywhere in all the countries, so nobody should be ashamed we missed the diagnosis. It will happen one day or another. So the main thing is 10 days, within 10 days is very effective, efficient treatment. After 10 days, it's very important not to miss it. So even though the activity of IVIG after 10 days of fever is less, it is still much better than no IVIG. That's for one. Second, there is a small series, from a large series in Japan, there is small sub-series where patients were discharged after 10 days because they did not have any severe problems, and they had recurrence of fever and inflammation. And these kids, it's almost 90% of aneurysms if they are not treated afterwards. So patients who come to you after 10 days of fever, especially if they have dilatation or small aneurysm, especially if they have active inflammation with high CRP, please do not miss it. Give the treatment and potentially give an adjuvant treatment, which is secondary treatment with the IVIG. It could be corticosteroids, it could be Infliximab or other medication. Do not miss treating patients who come late.
Thank you so much. We will have one more question.
شكرا جزيلا. في بعض الأحيان كما هو الآن في المغرب أو في بعض الدول يصعب الحصول على الإيمونوغلوبولين، وبالتالي الخبراء يجب أن يقترحوا دواء على الأقل يخفف من الالتهاب، خاصة أن منشور لكوكرين سنتين أو 3 سنوات قبل يؤكد على أنه يمكن استعمال الأسبرين أو أحسن كورتيكويد في هذه الحالات. ما رأيكم في هذه الوضعية التي يصعب فيها الحصول على الإيمونوغلوبولين لسبب أو آخر، ثمن أو غير متوفر أو الإشكالية ديال عرض الطلب على المستوى الدولي؟ شكرا.
Excellent question. So the question was, in areas where we don't have access to IVIG, experts should come up with an alternative. I work with Dr. Adri Trimalti from San Diego, and she tried to do a randomized controlled study in low-resourced area with aspirin and other therapies, and her study was rejected as considered not being a standard of care. Now we have from different Arab countries, different, I want to say, good investigators like Dr. Asif from Sulaimaniya, who during the war had suffered from not being able to give IVIG. So we're still looking, Dr. Asif, you hear us, we're still looking for your manuscript on the use of steroids alone in this patient population. Thank you so much. Congratulations again on your presentation. Thank you for being here.
Being not so young in Kawasaki disease myself, I would have to say 2 things. First, aspirin alone is certainly not an option because this is where we see 30% of aneurysms. So aspirin alone is like giving no treatment. Second, corticosteroids. In the early Japanese series, corticosteroids alone may be helpful in reducing inflammation. The problem is those patients who had giant aneurysms in Japan when only corticosteroids were the option, these patients were those who had rupture of the aneurysm and hemorrhage and sudden death because of the coronary arteries ruptures, and therefore there's no perfusion to the heart. So my second point, therefore, is if only corticosteroids is an option, please watch for the aneurysms. They may be at risk of rupture. Now, the third option is to look at inflammation, IL-1, IL-6, IL-8, the interleukin inflammation, and apparently, and I'm not promoting this, but apparently treatment with Anakinra or with Infliximab may be more helpful than only corticosteroids, but I'm not the expert on that, and there is no accurate data for that.
Okay, excellent. Next speaker.
Please, next speaker is also challenging case from Tunisia. So please, Khouloud, come with us. It will be presented by Dr. Khouloud Ben Mansour from Tunis General Hospital. Thank you.
No. No. No.
Can we have IT help us out? Yes. So how do I do that to them? Oh, very nice.
No, it's acute liver failure.
Do the other one.
Maybe we can ask some questions. I had questions for Dr. Nasira. I don't know if she is connected, still connected. No. Yes, Sima has a question for Seda Hala.
Okay, so my question was about the case you presented, the atypical case with hepatitis. It just reminded me with a case that I recently saw. So I'd like to clarify more. Did the patient had cholestatic jaundice or was it indirect hyperbilirubinemia? And after management, how long did the elevation in the liver enzymes persisted? It's because I was faced with a case in which Kawasaki was considered, and the patient had cholestatic jaundice and very high inflammatory markers, in addition to high liver enzymes and some synthetic dysfunction. We initially considered infectious causes. The fever lasted like for 5 days with some KD features. The echo was normal, no high drops of the gallbladder, normal CT. I ended up giving IVIG and steroids, which helped settle the fever immediately. And later on, the inflammatory markers were fine, but still the patient is having high liver enzymes. So I was wondering, is it really Kawasaki disease atypical case or something else?
Thank you, Sima. Very nice interpretation of my case. This case was seen by expert hepatologists. As I mentioned, the main problem of KD is the sequential appearance, and not all cases are similar, and the first presentation could be misleading. This patient came, he is 3 years, and came just for hepatitis and referred by another pediatrician. When I am looking for this patient, he is ill. Yes, he is ill and has desquamation of limb and perianal desquamation by the hand. So he's presented more than 10 days after his hepatitis, and he's indirect and not cholestatic. Then I did my job, look for the heart, it's okay, no coronary involvement, and then looking for the CBC. There is hypoalbuminemia and thrombocytosis. I think the reading is around 1 million, and elevated ALT and AST. So it is incomplete. I measured by 2 indices from clinical and 3 from laboratory finding. So it is atypical. How to manage? I give intravenous immunoglobulin even after 10 days as the patient is feverish and ill, and the acute phase reactant is elevated. So I give intravenous immunoglobulin, marvelous response, and the liver function improved, I think, after 1 week. And general condition improved without coronary involvement. And I followed this patient. Usually I follow for 8 weeks, then maximum for 2 years if the patient has no coronary involvement. Thank you, Sima.
Sima, I have a comment for your patient.
Thank you.
Maybe it is Kawasaki disease complicated by MAS, macrophage activating syndrome. And maybe if you give him, I don't know if you gave him boluses of steroids. If you try that and you have good response, maybe it is MAS.
Thank you so much.
So, please, we will listen to Dr. Khouloud now. Please, give your talk. Thank you.
Yeah, okay. First of all, thank you for the invitation. I'm Khouloud Ben Mansour, a pediatric resident in Children's Hospital of Tunisia. Our case today is about a 15-month-old female infant with no significant medical history who presented to the hospital with a complaint of fever for 7 days. Initially, she had nasal congestion and red lips, and she was diagnosed with otitis media and started on oral amoxicillin. By day 7 of fever, she developed a rash, edema of the hands and feet, feeding refusal, irritability, excessive crying, and jaundice. The physical examination shows a high fever degree, jaundice. The patient was lethargic and sleepy. She was respiratorily and hemodynamically stable. And we found macular and papillary exanthema, particularly in the trunk and proximal extremities, edema with induration of the hands and feet, and cherry red lips, swelling and fissuring of the lips, without other signs. So concerning the laboratory findings, we have objectivied an increased erythrocyte sedimentation rate at 190 millimeter at the first hour, and increased CRP at 71 milligram per liter, leukocytosis, while the platelet count was normal, and an anemia. We also found a cytolysis 10 times normal with a low prothrombin time at 29%, and the macrophage activation syndrome balance sheet was negative. So at this stage, the diagnosis of partial Kawasaki disease was suspected. However, our patient presented an acute liver failure, which etiologies are either drug toxicity or ingestion, infectious causes, autoimmune hepatitis, or metabolic causes. So that, concerning the etiological assessment, viral serologies were negative, the protein electrophoresis shows no hypergamma globulin peak, the immune assessment were negative, the paracetamol blood level was normal, and the toxicologic secretin was negative. The abdominal ultrasound shows an homogeneous enlarged liver and spleen with meals-free intraperitoneal fluids. So that our patient received a symptomatic treatment, namely vitamin K, lactulose to prevent hepatic encephalopathy, a continuous glucose infusion at 10 milligram per kilogram per minute was necessary to maintain euglycemia in this patient. He was put on antibiotics, and we discussed a liver transplantation. As we said, since the symptoms, signs, and laboratory findings consistent with Kawasaki disease, she received 2 grams per kilogram of intravenous immunoglobulin as a single infusion, and we obtained an improvement of the general state and apyrexia 24 hours after IVIG. So by day 8 of evolution, she developed a perineal desquamation. And the evolution was 2 cardiac ultrasounds was practiced at day 17 of evolution, and on the 6th week, both were normal. She developed a desquamation of extremities by day 14 of evolution, and she was put on oral aspirin at a dose of 5 milligrams per kilogram per day after normalization of the biological assessment. And she was successfully treating. As we can see here, we obtained normalization of biological assessments by the 15th day of evolution, as we have a prothrombin time at 16%. Thank you for your attention.
Okay, this is now open for questions. If there is any online, feel free. So as you reflect back on this case and you did your literature search, how common is this? How common is it for children to present?
Yeah, well, in the literature, we only found only 1 case with fulminant hepatic acute liver failure as an unusual presentation of the Kawasaki disease. It's in India. I just showed. I don't know if, and it was related to Kawasaki disease as they found features of vasculitis at the biopsy of in the hepatic biopsy. It's the only case that with acute liver failure. There's hepatitis, cholestasis, but with acute liver failure, it's the only 1 case we found. Well, in Tunisia, we just practice it from living donor, and no living donor was found for the patient.
Okay, well, thank you so much. This was great. Congratulations.
Thank you.
And then our last speaker will be virtual, Dr. Amr Fathallah, and he will be sharing with us a challenging case from Egypt. Yes, oh, here's here. Dr. Amr, can you talk?
Can you start, please? My voice is clear?
Yeah, now we hear you.
Yeah, okay. Bonjour, good morning. I am Dr. Amr Fathallah, lecturer of pediatric cardiology. Today I will present my case presentation from Egypt. Our case is 10 years old boy referred to us as a suspecting case of Kawasaki disease based on fever, skin rash, and regarding fever, the duration was prolonged for 6 weeks, high-grade fever, not responding to antibiotics, and with no focus. Regarding rash duration, it was about 3 weeks, small, painless red papules involving trunk and groin region. Regarding healing duration, it was about 2 weeks, associated with painful and dry hands. There was no significant associated symptoms like red eye, lymphadenopathy, or gangrene and arthritis, and there was a significant family history of hypertrophic cardiomyopathy, recurrent cerebral stroke, and maternal chronic kidney disease. Basic labs were all normal except for proteinuria in their analysis. Echocardiography showed dilated hypertrophic left ventricle with normal chronics and normal cardiac enzymes. To sum up our case, it is a 10 years old boy referred suspecting of Kawasaki disease. Further assessment showed proteinuria, significant family history, and cardiomyopathy. These symptoms reflect a systemic inherited disease, but what about the prolonged fever? Cause of prolonged fever may be infection or non-infection causes. Investigating our case for infectious diseases, all laboratory and imaging were negative for infection. Regarding non-infection causes, investigations done for excluding inflammatory, autoimmune, endocrine, and malignant causes were negative. And regarding anhydrous and Fabry disease, activity of alpha-galactosidase enzyme was very low, raising the suspicion of Fabry disease. So what is Fabry disease? Fabry disease is an X-linked lysosomal storage disease. due to deficiency of alpha-galactosidase enzyme, start in childhood with progressive symptoms and have a characteristic penetrance and expressivity. Female carriers can have some of the disease manifestations. Early symptoms involving sweet glands causing anhydrosis and hyperthermia, dermal cells causing angiokeratoma, and peripheral nerves causing acroparesthesia. And this photos from published case for the Fabry characteristic angiokeratoma. Regarding late symptoms involving heart and kidney and brain causing cardiomyopathy and proteinuria and recurrent stroke. Fabry is a treatable disease by replacement enzyme therapy approved by FDA. Back to our case, Kawasaki versus Fabry disease. Fever can be explained by anhydrosis, and peeling can be explained by acroparesthesia, and rash can be explained by angiokeratoma. So, re-analysis of our case based on the anhydrosis and acroparesthesia and angiokeratoma, and on view of the low alpha-galactosidase enzyme activity, Fabry disease was highly suspecting and confirmed by the genetic studies. Suspecting Kawasaki disease unmasked a rare disease which was hidden for decades in many family members. And aim of our presentation is to raise the awareness about the Fabry disease, which symptom can be easily misdiagnosed with Kawasaki. Thank you.
Presentation, we'll open it up for questions. You know, as you start talking about the case and you mentioned family history of hypertrophic cardiomyopathy, I was reflecting, you know, it's really rare for us to see KD in underlying congenital heart disease or underlying cardiomyopathies. And, you know, sometimes it's so conflicting, like you do the echo and you see this echo brightness or echo dilation of the coronaries, but is it related to their congenital condition or is it related to this acute KD? Now, time will tell you if the coronary improves, then you know for sure this was an inflammation. But if it continues to be there and you have now unmasked an underlying disease, how do you decide, is this a true complication from KD versus hereditary? So I'm just thinking, I don't know if Dr. Hala want to talk about it.
This is Amr case and not mine. This is the Amr case and not mine. But it could be an association. But he interpret the finding by the clinical anhydrosis and the clinical finding for this patient. It could be an association. Let's to revise. One of my patients came and just bronchiolitis, severe bronchiolitis, wheezes. Heroic dosage of steroid was given, okay? And by accident, I do an echo for this patient. I discover coronary aneurysm and thrombosis inside. By this, just I am looking why this patient are resistant and wheezer, okay? This patient, I refer and do my job by lab, and I discover this patient has an incomplete Kawasaki. I give him IV, IG, and Infliximab, okay? Returning back after 3 days, I discover that this patient has significant hypertrophy of interventricular septum. What is your interpretation, Ashraf? If this patient is receiving a heroic dosage of steroid for a long time and returning back by this hypertrophy, is it hypertrophic cardiomyopathy or complicating something?
So, I mean, we see this with the newborns who receive steroids for their lung disease, and it's like thickness.
Yes.
Is a complication from the steroid.
Yes, this patient like that. Excessive hypertrophy of interventricular septum, secondary to heroic dose of steroid. It is not uncommon in our country to receive a dosage, a high dose, Solicortef every 3 milligram per kg every 6 hours. So hypertrophy can be induced by steroid and just hypertrophic cardiomyopathy.
This hypertrophy and steroids reminds me of premature babies. The great preemie babies under corticosteroids, they do develop hypertrophy. It's not clear whether this is due to hypertension or just the cardiomyopathy, but it resolves rather quickly, right?
It is not very uncommon, and we are misdiagnosed as hypertrophic cardiomyopathy.
Yes. Dr. Amr, thank you again for the great presentation, and thank you for the message to all of us not to be missing underlying diseases. Okay, with this, we will end this session. Our next session is going to start...
Sorry, Ashraf, we have a last question.
I'm sorry.
Merci beaucoup. Dans le même sens, mais pas dans les myocardiopathies hypertrophiques. Je parle surtout des cardiomyopathies dilatées. Quand, par exemple, on commence le traitement de la Kawasaki et quelques semaines après, on voit que la myocardiopathie dilatée n'a pas beaucoup changé. Je pense qu'il est légitime également, dans le même sens, d'aller chercher est-ce que cette maladie de Kawasaki n'a pas seulement décompensé une myocardiopathie dilatée d'origine métabolique ou génétique. Je donne quelques exemples, par exemple le déficit en carnitine ou autre myocardiopathie. Parce que rester sur la complication de la Kawasaki, de la maladie de Kawasaki, va négliger un petit peu le pronostic à long terme avec des traitements spécifiques tels que la carnitine ou autre chose.
Merci encore pour cette question. I will, if you don't mind, in English, so other people understand. So the question is the dilated cardiomyopathy or low function of the heart in Kawasaki disease, especially if it's sustained, if it's persistent. Are we underestimating these issues or not? So first, coming from Canada, I'm surprised with this notion of dilated cardiomyopathy in Kawasaki disease, because in most series, at least, we see some dilatation and some dysfunction in a small proportion of patients, so low contractility, but typically they improve very well with IVIG. If they sustain some dysfunction, it will take few days, not few weeks. And we have described this, it goes in correlation with NT-proBNP. When the NT-proBNP is high, the function is low, but everything improves. What is interesting is that those who have dilated or low function, they improve in proportion, which means they still have low limit function after 3 months after. So it's a very important point you're pointing out to. Now, the true dilated cardiomyopathy in Kawasaki disease, it could be also a genetic or social group of patients. We have great example from Dr. Asofaik in Iraq, where he witnesses many cases of Kawasaki disease with severe dysfunction without ischemia. We're not talking infarct and ischemia. So maybe in his region there is a subclass of patients or families in their neighborhoods who have this genetic susceptibility for dilated cardiomyopathy or severe dysfunction as opposed to other areas.
Thank you, Dr. Najib. So we'll have to end this session. We have 10 minutes coffee break, please. Thank you.
The mics are not.
Oui, allô? Ah.
Très bien.
Merci d'être là. On s'assoit, s'il vous plaît. On garde le silence comme des anges.
Okay. Okay. So we are here for our second session. I have with me Dr. Hofer, who's a pediatric rheumato-immunologist from Switzerland. And myself, Dr. Nadine Schweiter. I'm a pediatric cardiologist in New York, and I'm part of Kawarabi. And you all know Dr. Dahtah, but Dr. Dahtah is the father of Kawarabi, and he's a pediatric cardiologist at St. Justine. So we're going to start with our first two speakers, Dr. Harahshi and Dr. Yara Abu Salah, who will be discussing the new Kawarabi-Kawasaki disease algorithm that some of you have participated in the writing of, and it's a guide for general pediatricians. Please, you can start.
Good morning, everyone. Hello, all. It's a pleasure to be here today. I'm Yara Abu Salah. I'm a graduate of 2024 from the University of Jordan. I've been working on this project with a lot of doctors in Kawarabi, including my team, to write a guideline for all primary care physicians, whether it's general pediatricians, cardiologists, and even GPs, to diagnose Kawasaki disease promptly and prevent complications. So these are all of the contributing authors, different pediatricians from different countries that have participated in reviewing the guidelines and the literature that we have collected over the past couple of months. So starting off with the facilitation of diagnosis for the primary care doctors. As a quick review, Kawasaki disease is an acute self-limited febrile illness. It affects children of all ages, primarily those under 5 years old, and primary care physicians must recognize the signs and initiate timely management. So this guide by the Kawasaki Disease Arab Initiative, short Kawarabi, provides a practical approach to the diagnosis and management of KD in the Arab countries and regional neighboring countries for frontline healthcare providers. So the objectives of this guideline was to provide a practical and comprehensive resource for the MENA region and even the world as a guide to seek expert consultation for complex or high-risk patients. It is composed in English, and we are working to translate it in Arabic and French, which will cover the MENA Arab countries from the medical educational perspective. Now, why is early diagnosis important? KD is a leading cause of acquired heart disease in children, and the delayed diagnosis leads to cardiac complications in up to 25% of untreated cases. The rate of coronary artery involvement decreases to less than 5% in children treated within the first 10 days of the illness. And if the diagnosis is often missed due to incomplete presentations that we will be talking about. Now, the classical clinical criteria for Kawasaki disease involves a fever lasting for more than 5 days, plus 4 out of these 5 features, which is bilateral non-exudative conjunctivitis, oral involvement, lymphadenopathy, it is usually unilateral, and a maculopapular rash, hand and foot edema. Okay. Now, as for recognizing incomplete Kawasaki disease, incomplete Kawasaki disease lacks the full clinical criteria. It is more common in infants under 1 year of age, and it must be considered to do lab work, and that will include elevated CRP or ESR, an elevated white blood cell count, anemia, thrombocytosis. We can also find hypoalbuminemia and elevated liver enzymes. Now, as we do an echocardiography, we might also detect coronary involvement. Okay, so no single laboratory test does confirm KD, but they do provide a supportive evidence. As I've mentioned, CRP and ESR with a high white blood cell count, especially in neutrophilia. Thrombocytosis is especially prevalent in the second week after fever onset, and it does peak in the third week. Low serum albumin, which does correlate with a more severe and prolonged course of an acute illness. Elevated liver enzymes, ALT, AST, and GGT. On urine analysis, we could also find urinary white blood cells. Now, on echocardiography in Kawasaki disease, it is essential to detect the coronary artery abnormalities. The findings that we do find usually are a coronary artery lesions such as aneurysms, whether it's small, medium, or giant, myocardial systolic and diastolic dysfunction, mitral regurgitation, or pericardial effusion. It is advised at a minimum an echocardiography is obtained during the acute admission in 1 to 2 weeks and 4 to 6 weeks following the disease onset of Kawasaki disease. So we also mentioned in our guidelines the role of NT-proBNP in KD diagnosis. NT-proBNP is a biomarker of cardiac stress. Its levels vary with age in healthy children, with physiologically higher levels in infancy. NT-proBNP of a level of more than 200 supports the KD diagnosis. The Z-scores of NT-proBNP, or upper limits for age, are preferred methods for implementation. It is recommended to use an online calculator to have the accurate number for NT-proBNP Z-scores. And higher levels of NT-proBNP are associated with coronary artery involvement and IVIG resistance. Now, as the era of COVID-19 has ended, we have seen an impact of COVID-19 on KD diagnosis. KD incidence has declined during the COVID-19 pandemics. However, a higher proportion of incomplete KD cases have been reported. So, throughout the COVID-19 era, patients with complete Kawasaki disease had more pronounced skin manifestations. KD patients had higher level transaminases and albumin levels, significant IVIG resistance, but there have been no changes in coronary artery lesions or refractory KD rates compared to pre-pandemic data. As of the neurological manifestations seen in Kawasaki disease, extreme irritability is a hallmark symptom, cerebral vasculitis, aseptic meningitis in about 5% of cases. Patients could present with headaches, seizures, or bulging fontanelles, facial palsy and ataxia, which are rare symptoms but are also have been reported. Sensory neural hearing loss is quite common neurological manifestations in about 36% of cases presenting with neurological manifestations. It is, however, often transient and in those of an age under 5 years of age. And IVIG usage have been shown to improve these neurological symptoms. Other symptoms that we do see are pulmonary and GI symptoms. We could see bronchopneumonia, pleural effusion, pulmonary artery dilatation, and transient pulmonary hypertension. For GI symptoms, we also see patients presenting with vomiting, diarrhea, abdominal pain, and severe cases could actually like acute appendicitis and pancreatitis. Now, another entity associated with Kawasaki disease is the risk of macrophage activating syndrome. Macrophage activating syndrome is a severe inflammatory response seen in about 1 to 2% of Kawasaki disease cases. It presents with extremely high ferritin level, more than 684, along with 2 other lab abnormalities: thrombocytopenia, platelet count less than 180,000, hypofibrinogenemia, increased aspartate aminotransferase, and of triglycerides more than 160. The presence of macrophage activating syndrome does increase the level of coronary complications and mortality. Now, these are some of the recommendations that we have included to when to admit patients that present with Kawasaki disease shock syndrome to the CCU. This is a quick comparison between KDSS and multisystemic inflammatory syndrome. So this table shows the different epidemiological data between both of them. They are very, very similar entities. Both of them have different diagnostic criteria, but they have been found that the age of the patients differ. The gender is actually quite more common, both of them in males, with a higher presence of KDSS in male patients. They do show laboratory differences and echocardiographic differences. Even clinically, clinical length of hospitalization does differ between both of them. Okay, so these terms are quite missed between in Kawasaki disease. People do don't really know the difference between them, or they're often misrepresented. So we really wanted to focus on the different terminology that is used in Kawasaki disease, one of which is incomplete KD. These patients usually present with 4 or more days of fever and at least 2 or 3 of the classic diagnostic criteria, which is also supported by different laboratory and echocardiographic data. On the other side, we do have atypical KD, which is organ system involvement outside of the typical KD presentation. Now, as of the atypical presentation of KD, it is more prevalent in males with a 1.85 to 1 ratio, and in many of the cases, the patients were 6 months old or younger. Some KD cases lack the typical symptoms but involve other organ systems. Atypical cases have higher coronary artery aneurysm risks due to the delayed recognition. Now, atypical KD shows different multi-system symptomatic findings. As of the neurological symptoms, aseptic meningitis and sensory neural hearing loss are potential complications, though often they are under-investigated. Musculoskeletal symptoms such as arthritis, arthralgia, and myositis are common, even though myositis is underreported in younger children who cannot express their pain. As of the pulmonary symptoms, as we've mentioned before, bronchopneumonia, pleural effusion, and pneumothorax are seen. For GI symptoms, we do see vomiting, diarrhea, and abdominal pain. Now, these are rare and uncommon presentations of atypical Kawasaki disease, one of which is a cervical lymphadenopathy and retropharyngeal abscesses. The retropharyngeal abscesses are rare, requiring surgical drainage if antibiotics fail. These may later develop typical KD features requiring IVIG. As we've mentioned, KD symptoms do happen sequentially, so they could present with a retropharyngeal abscess, then go on and present other classical KD symptoms. Another entity that is often messed up with the atypical Kawasaki disease is the hemophagocytic lymphohistiocytosis. The like symptoms or the similar symptoms between both, such as prolonged fever, high ferritin, and multi-organ involvement, they do overlap with KD, making the diagnosis challenging. So differentiating both of these entities is crucial to avoid misdiagnosis and worsening of the disease. So, how do we diagnose KD in the presence of other infections? 38% of KD cases have co-infections, whether it's viral or bacterial, and the presence of other infections doesn't necessarily rule out the diagnosis of Kawasaki disease. Patients with concomitant infections are actually more likely to have prolonged fever courses after the initial IVIG treatment, and they do require a second dose. So it's about 33% versus an 18%. The prevalence of coronary artery lesions is comparable in children with KD, with or without concomitant infections. Okay. So what are when delayed recognition does occur, what are the complications we often see? Delayed diagnosis risks and increases the risk of coronary artery aneurysms. The incomplete Kawasaki disease and atypical Kawasaki disease presentations with the fewer diagnostic criteria may not raise suspicion early, leading to a delayed treatment. An early diagnosis is recommended to prevent the cardiac complications, so that's why an echo is a key in the diagnosis of Kawasaki disease. Now, this is an algorithm we have worked on with the different doctors. It is based it was like taken from the American Heart Association, the Japanese Heart Association guidelines, and even some of our guidelines that we have taken from different research that we have found to make this one clear image as an algorithm for doctors to follow. So what is the diagnostic algorithm for Kawasaki disease? We start off with a child presenting with a high-grade fever of 4 to 5 days duration, and now you're suspecting Kawasaki disease. What do you do next? Do you evaluate the classical clinical features of Kawasaki disease, such as a skin rash, even the BCG site reactivity site, conjunctivitis, lips and oral cavity changes, palms and soles changes, and cervical lymphadenopathy? If you do have 4 out of 5 of these clinical features, you move on to the next step, which is Kawasaki disease diagnosis. If you do not, you would suspect other features. If you find only less than 4 of these features, you would look and evaluate the supportive laboratory events, such as the CRP of more than 3, or an ESR of more than 40, and 3 or more of the following: a white blood cell count of more than 15,000, anemia that is for each age, platelets count of more than 450,000 after the 7th day of fever, an albumin level of less than 3, an elevated ALT level, and the urine white blood cell count of more 10 white blood cells per high power field. Now, if these features are not found, you would assess for a coronary artery lesion, a coronary artery lesion with a Z-score of more than 2.5, and or an elevated NT-proBNP, a Z-score of more than 2, or the upper limit of age. And after these are established, you do establish a KD diagnosis. If still you did not find any of these findings, and it's still not confirmed, you do repeat the clinical and laboratory findings, and if the duration of fever is still more than 6 days, you do seek a Kawasaki disease expert consultation. If the fever has resolved with no more clinical Kawasaki disease concern, then you exit the algorithm, and it's not a diagnosis of Kawasaki disease. Now, a quick point we want to mention that the relapsing fever after the self-resolution may increase the risk of coronary artery lesions. And after that, we do reconsider the diagnosis and treatment. As of the treatment algorithm for Kawasaki disease, when Kawasaki disease diagnosis is established, we have to differentiate between low-risk and high-risk patients. So who are the high-risk patients? High-risk patients are those infants of less than 12 months of age, those with a baseline Z-score of the left anterior descending artery or right coronary artery of more than 2, a high inflammatory marker level of CRP of more than 13, if they are of age and race descent, clinical features of shock, we do consider CCU admission, if the Kobayashi score is more than 5, or a Sun score of more than 3, and elevations in NT-proBNP levels, a more than 1.093 is predictive of IVIG resistance, and more than 1,300 is predictive of coronary artery lesions. As for the low-risk patients, if they do not meet these criteria, we do go on and give IVIG 2 grams per kilogram and aspirin. If they do meet the criteria of a high-risk patients, plus the IVIG 2 grams per kilogram and aspirin, they are also recommended to be given steroids or biological therapy. If IVIG resistance is seen in low-risk and high-risk patients, we do intensify the therapy, and we repeat the IVIG dose. So this is just a summary of all of the diagnosis and treatment in one big algorithm. Now, treatment options for Kawasaki disease. In this table, as you can see, we have the name of the drug, the starting dose, the maintenance dose, the frequency of repeating the dose, the duration that is recommended for the treatment, and the most important side effect for each treatment. IVIG, as we have mentioned, aspirin is another treatment options, glucocorticoids, Infliximab, and cyclosporin. Now, when IVIG-resistant patients do happen, these cases do happen quite often with a lot of cardiologists. what are the management options that we have for them? So Infliximab is another treatment option, glucocorticoids, giving the IVIG for a second time, etanercept, cyclosporines, and Anakinra. Okay. Thank you all.
Can I just make a comment before we move on? Thank you so much. Can we go to the second slide? So I just want to compliment Kawarabi and the meeting this year. I feel like in order for us to thrive and move forward, we have to have the new generations with us. So on this slide here, if we can show it again, I just want to highlight the number of students that we have. Today, I was really excited to see 2 students come up to the podium and present. So that's really exciting. So we have Yara. She is currently in Jordan practicing along with Tala. Dr. Bilal Yassin is at Howard University in Washington, D.C. And Dr. Banik Risat is currently in United Arab Emirates. The 4 of them started with us working on this project when they were students, and now they have graduated as interns, and hopefully in the future will be leaders in Kawarabi. Thank you. By the way, the tables, the graphs are under embargo. This is going to go for a peer review publications. So please don't share it outside widely, please. Wait till it's published.
Thank you so much for this great presentation and for summarizing this work. I wanted to see if anyone has any questions, either the people in the audience and also the people who have joined us on live. You can post your questions on the WhatsApp Kawarabi group and we will ask them.
So we have a question from Dr. Hala Agha. Basically, this is very important for primary care, for everyone, but for that matter, we wanted this algorithm to be clear and simple, not going up and down, jumping up and down what to do, going from top to bottom like waterfall, comme une chute d'eau, c'est facile à suivre.
Thank you, Yara. Thank you, Ashraf, and all great team. May I add and comment, if the patient is feverish and severely ill, it could be the clue for Kawasaki. And the other point, if we have classic Kawasaki or incomplete Kawasaki, we proceed for intravenous immunoglobulin without echo. If we have complete or incomplete Kawasaki, it's not mandatory to have an echo to diagnose. Echo will help us if we have coronary. But if we haven't coronary, this patient is incomplete or atypical or incomplete type. Is it right?
Yes, absolutely correct. So if you are dealing with a child in front of your eyes and they meet the complete criteria, you're going to treat with IVIG before you call for the echo. Same thing if you applied the incomplete KD criteria, it's better to get the IVIG first. As a matter of fact, I tell my trainees that we're looking at echocardiogram measurements that are millimeters in size. An error of 1 or 2 millimeters will move us from normal to abnormal.
Yes.
The children are fussy when they have KD, and you can see the fussiness goes away as you give the IVIG. So it's better for us cardiologists to have a calm child to get you a better number. So if you meet the criteria, go ahead and treat, and then call me after you treat. In other words, let me sleep that night.
The issue of co-infection is very important. One of our patients is treated as a streptococcal pneumonia and complicated by pneumococcal and pneumothorax. It is classic bacterial infection. And I'm come and have a look for this patient. The fever is persistent. He did an echo. Amazing, there is coronary involvement. So streptococcal infection or bacterial infection could be the etiology of Kawasaki disease and not excluding Kawasaki disease. Okay?
Yes, exactly. So, as mentioned here, easily 1/3 of patients with Kawasaki disease, either they have concurrent, which means at the same time an infection could be pulmonary, non-pulmonary, bacterial, viral, it doesn't matter. So at least easily 1/3 have this kind of infection with Kawasaki disease. Another proportion had probably viral infection or bacterial infection days or few weeks prior to the incidence of Kawasaki disease. So that's for sure, we need to remember this. Do not exclude Kawasaki disease from differential diagnosis because you have otitis or pneumonia. And in other words, also, do not say this pneumonia is leading to Kawasaki disease. It doesn't matter. What we need is how to treat the pneumonia itself and how to treat Kawasaki inflammation itself. The second point on echo, I will repeat with numbers just to remember. Only 25% of KD patients have coronary artery involvement dilatation, and only 25%. And therefore, it is not unusual to have normal echo in Kawasaki disease patients. So do not wait for the echo. Treat first and get the echo whenever you can, as soon as possible afterwards.
Thank you.
Thank you very much for this. Oh, sorry.
Yes, I have a question, please. Thank you first for your beautiful talk, very summarized. My remark is maybe to just the measurement of the coronaries to your talk, because you have it's easy to say +2 Z-score, but it's very important to put the measurement of each coronary artery, LAD, the RCA, etc. Second remark is you haven't talked about the giant aneurysm, which we have to associate the anticoagulant plus the AAC. Maybe it's very important to add it to your talk and to your presentation.
Thank you for your...
And my third remark, in Morocco, it seems to me that we have a lot of Kawasaki disease. I don't know if it's the case in the other Arab countries, but in Morocco, we see coronary Kawasaki disease very frequently, and also coronary involvement. I was just wondering if we have some predisposition also, rather than beside the Asiatic people.
Thank you for your kind feedback. As of for the first remark about the Z scores for different the different measurements, we actually do have a table included in our review, but we just haven't put it here in the slides. But it's already mentioned in the review that we are working on.
Okay, and you had two other questions. One of them was about giant aneurysm. So when we reached page number 84 in the writing of this guidelines, I told Najib enough is enough. So I think the next phase is we need to write another guidance more focused towards the subspecialist on how to manage the complications of Kawasaki disease, the long-term management, etc. This one is focused on primary pediatrician, making the diagnosis. I say primary pediatrician, I mean anyone who's dealing with the child outside the cardiologist's office or the rheumatology office. We want to make sure that they are ready for those patients. 84 pages, I think, is more than enough for now. Please go ahead.
Thank you very much for this presentation, and also for this great work, because it's very important. As pediatric rheumatologists, we know it's important to diagnose very early to be very efficient with our treatment. And I have seen your algorithm. It's very complete and very helpful. And I have a question about the start of the algorithm, because finally you are speaking to general practitioners, general pediatrics, and so you need to go into this algorithm. And you are writing patients with suspicion of KD. But what is for a general pediatrician a suspicion of KD? And additionally, a question about the fever, because as pediatric rheumatologists, we always, when we are called by the general pediatrician, we always ask if this is maybe a Still's disease starting. And the fever is very different, because in Still's disease, you have 1 or 2 peaks usually per day. And in Kawasaki, you have almost always fever, going very slowly down. So maybe this is something that you could maybe add in your algorithm. I don't know what is your opinion on this.
So as of these symptoms, we have actually written a lot about each system of Kawasaki disease and how each symptom does present in Kawasaki disease. We have actually written about different rashes that we could see, the fever course, and what other differential diagnoses we might think of when looking at these different symptoms. We haven't actually mentioned each symptom details in the algorithm just for simplicity reasons, but the details for each symptom and clinical features is written in the full review.
Excellent, yeah. We actually, it is for primary care, so every symptom is well detailed. So this is why we're working on how to diagnose and how to treat, and forget about that long-term problems. But your point is really excellent. In my practice, I always tell people, rheumatic fever. JRA, okay, rheumatic arthritis is different. It's low-grade fever, typically in the evening, 2 peaks a day, whereas Kawasaki disease is high fever, 39 or higher, and so forth, if I'm not wrong.
We have another question. Yeah, thank you. I have 2 questions, please. The first one, if corticosteroid could replace IVIG, because we have a big problem here in Morocco to have IG, particularly weekend or some days. So we have so if corticosteroid could replace IG. The second question, for atypical case, the last case I had, it was atypical Kawasaki, and because it was a weekend, I didn't get the IG, so I started aspirin, and she well improved after 2 days. We don't have fever. After 2 days, is it also important or still interesting to have IG, or it's okay if we don't have fever?
Najib, she was looking at you. I mean, she was looking at you for a good reason.
Okay, so first of all, Kawasaki disease, what is the natural history? Okay, back in the 60s, 70s, and 80s, what used to happen before corticosteroids, before IVIG? It's a self-resolving disease. There's inflammation for 7, 10, 12 days, it goes down. Then after a few days, 5, 7 days, fever goes up again, CRP and whatever, ESR goes up, and then goes down. So it does go up and down, and then it resolves continuously. But more relapses you have, the more likely you have aneurysms and then death due to aneurysms. This is the natural history of Kawasaki disease. Initially, in Japan, they started using aspirin and then corticosteroids. Steroids did help to control the fever and inflammation. It does help to reduce the fever, but doesn't mean it stops the cascade of inflammation that is involved in the vasculitis exactly well. Also, corticosteroids, it does not allow scarring of the coronary arteries, and therefore we call these giant aneurysm under steroids papyrus, like the very thin paper, like cigarette paper, very thin, and therefore there's high risk of rupture and bleeding of the coronary arteries, and therefore sudden death. This is the natural history. This is why I am an opponent of corticosteroids alone. I understand in some areas, in some spaces, we don't have IVIG, and this is a big issue. We have to deal with it. I think Kawarabi's mission is also to deal with this shortage or unavailability of IVIG. We are also running a study coming up very actively now on pharmacoeconomy, which will study what is the impact if we don't use IVIG, what is the impact if we have relapsing, what is the impact if we have complications from the economic standpoint. Because government, health authorities have budget, they have to deal with the budget, they have to know where to put the money. So we have to confirm to, and we have here the specialist of pharmacoeconomy, we have to deal with this subject from the public domain and show governments that we need this medication because it does reduce morbidity, it does reduce mortality, it does improve health outcomes of our patients, of our kids, and our kids are the future. So we are working on all subjects in all areas. My second point, I'll ask Dr. Hofer to cover this. Would you prefer if you don't have IVIG, would you prefer any biological therapy? As a first intention.
Clearly, but the problem is that they are often expensive. This is a problem. But if it's available, I would first use biological therapy, because we have seen, and especially I think with Anakinra, that we can be very, very efficient, and it's very easy. And Anakinra is also not very expensive as a biological, so I would really favor this over steroid, especially after hearing your comment on the problem of the aneurysm. Then definitely.
Can I make another comment about IVIG? So part of Kawarabi's mission is advocacy. And one of the things that hopefully we can go home with here is that we need to convince our Ministry of Health, we need to convince insurance that A, they need to approve it, and they need to approve it fast and provide it to our children. I am working on a statement from the American Heart Association, and I'm working with Najib and a couple of others. Kate Webb from South Africa, she taught me how IVIG is also not available in many countries in Africa. As a matter of fact, she mentioned that in South Africa is one of the rare factories to make IVIG. The cost is 1/10 the cost of importing it from the States or Europe. So also, like, this issue is not just unique for our region, it's all over Africa, it's in South America. We're having problem reaching, giving IVIG on a timely fashion.
Sorry, I was going to ask a question from online. So Hanifa Al-Arabti from Libya asked if we addressed recurrent Kawasaki disease in the guidelines, and what did we say about that?
We actually did mention the recurrence of Kawasaki disease, and that it does increase the complications of coronary artery lesions. If we haven't actually mentioned it in the treatment algorithm, if recurrence does occur, I think if recurrence does occur, cardiologists should be checked in and put on the case.
Yeah, I mean, Yara refers to cardiology because that's my title, but it's any Kawasaki disease expert. So if it's your rheumatologist, then it's your rheumatologist who you're going to call. If it's your ID or immunology, like you're expert in Kawasaki disease, that's the person that you will call.
We had another question.
Yes, thank you very much for your nice talk. My question is about diagnosis of KD. Why we have to, or we need to stay for 5 days of fever to consider our diagnosis of KD? Notre mérite en tant que médecin, en tant que cardiopédiatre, en tant que pédiatre généraliste, surtout les pédiatres dans leur cabinet, c'est de diagnostiquer précocement la maladie de Kawasaki et de la traiter précocement. C'est le seul critère, si on a bien compris, qui permettra de diminuer la prévalence et l'incidence des anévrismes coronaires. Donc, quel est votre avis à un pédiatre ou un cardiopédiatre qui voit un enfant pour la première fois pendant le premier jour, le deuxième jour avec une fièvre? Comment est-ce qu'on peut approcher ce diagnostic précocement et la traiter précocement?
So your question is, why are we waiting for 5 days of fever to diagnose Kawasaki disease when it is such an important symptom, and we are trying to prevent coronary artery aneurysms by treating in a timely manner? And what I would say is, so one, I think it is a clinical diagnosis, and it is in children. So you want to make sure that, obviously a lot of common things being common, viruses and viral infections and bacterial infections are more common. So you want to make sure that, you might end up treating way more patients than needed. But the other thing to point is that within the new AHA statement, the new update, the statement did push for an earlier diagnosis, and experts, Kawasaki disease experts, can make the diagnosis within 4 days with incomplete and complete Kawasaki disease. Because it's a clinical diagnosis, that's where the experts come in, having the expertise to make that diagnosis. And so we're pushing Kawasaki disease experts to make that diagnosis earlier. Unfortunately, not everybody is a Kawasaki disease expert, so you might want to consult with your Kawasaki disease experts before day 5.
If I may make a comment as a rheumatologist, this is a typical problem we have in inflammatory diseases, that we need to be very early because we have a window of opportunity to treat, but the disease is not starting at scratch with all the symptoms. It's completing with the time. And so if we diagnose too early, we make wrong diagnosis and we overtreat. If we make the diagnosis too late, then we undertreat and we have consequences. So we need really the competences to make the diagnosis. And I think this point was very important, to have the pediatrician who knows what is Kawasaki. And this is really the point for the diagnosis. I'm sure if you have a patient with 4 days of fever and you have a clear picture, and as a specialist you can say, this is a Kawasaki, then no problem to treat it. But that's not so frequent. Usually you need some time for that. I don't know if we have still some time for one question, because I'm happy to have a lot of Kawasaki specialists here with me as pediatric rheumatologist, and I have a little bit of scratchy question. It's about aspirin, because when I learned pediatric rheumatology, I learned to use it in Still's disease, but you need to give it every 4 hours if you want to have really the anti-inflammatory effect. And so you have to wake up the patient middle of the night to give aspirin. So that's the reason why we don't use it anymore. And this, I think it's one of the only disease in the world, Kawasaki, where we use this high dose of or intermediate dose of aspirin. And you were saying, and I totally agree with you, that alone it's useless because it's not treating. So why do we continue to use higher dose of aspirin? Because that could also bring some bleedings or problems. Because it's not working, why not directly using antiplatelets doses?
So, I mean, that's a great question. Hopefully next year, when Kenza invites us again to Marrakesh, we will be able to give you a definite answer. As we speak, there is a trial looking at the different doses of aspirin. It's still not yet published. It's supposed to be. Say that. Oh, pardon me. Me quiet.
Yeah.
Okay, embargo me. Bye.
I think the answer to this question is, why are we still using high or moderate dose? Because otherwise we feel guilty, because we've been using for 40 years or so. But all retrospective studies, because there are institutions where they don't use high dose or moderate dose at all in Canada and the US. And we did this, we published it in non-inferiority study. It says clearly there is no difference if you use only antiplatelet aspirin versus moderate dose aspirin. So I feel very comfortable not using aspirin as an anti-inflammatory and just complete use of antiplatelet.
And the current update took out high dose aspirin. It's only moderate dose until new studies that are randomized come out. So I think we can move on to our cases. Thank you. I want to give it to Dr.
Thank you very much. And I would like also to thank Kenza and all the organizing team to inviting me here for this meeting. It's very interesting, so it's fascinating. And Morocco also, it's a great country, so we have a great pleasure to be here in Rabat and in Morocco. So thank you very much. Now we will move on to the cases. And I agree also with you, we should never treat our guiltiness. This is very important because as physicians, and we see that with the age coming, that we are sometimes using drugs just because we are a little bit guilty and we want to go forward, and this is never good. So we have to be careful with this. This is advice of very old pediatricians. So now we can move on to the cases, and we will start with a case reporting a problem that is very frightening for us as pediatricians and pediatric rheumatologists and cardiologists, is macrophage activation syndrome. And here it's a case on macrophage and activation syndrome in Kawasaki. And this case will be presented by Dr. Ben Mansour from Tunisia. So again, a young pediatrician, so this is always a pleasure that you can present.
just want to remind everybody, if you prefer the slides in French, they're on the sides. The slides on the side are in French.
So the slides on the side are in French, if you prefer. And so now we will continue, please.
Okay, thank you again for the invitation. I'm Khouloud bin Mansour, a pediatrics resident at the Children's Hospital of Tunisia. So today our case is about a 5.5-year-old patient who was referred for further management of plangid fever and skin rash. He was born at term, atrophic, with good adaptation to extrauterine life, and neonatal period was uneventful. So the history of the present illness dates 6 days before admission, marked by the appearance of generalized skin rash sparing the scalp in a feverish context. The patient initially was put on oral amoxicillin by a private practice physician, and given the persistence of the symptoms, the patient was admitted to the pediatrics department. So the physical examination shows a temperature at 38.6 degrees Celsius. The patient was neurologically, hemodynamically, and respiratorily stable. We found a bilateral sub-centimeter cervical lymphadenopathy, mobile, non-tender, without signs of inflammation. He has a bilateral non-suppurative conjunctivitis. The hepatic span was normal at 4.5 centimeter, and we found a splenomegaly palpable 1 finger breadth below the costal margin. Generalized macular papillary plaques with intervals of normal skin, and the rash was located at the level of the trunk, upper and lower limbs, buttocks, soles of the feet and palms of the hand, and it was sometimes itchy. So concerning the biological assessment, we have objectived a biological inflammatory syndrome with an increased CRP at 260, a lymphopenia at 890, an increased erythrocyte sedimentation rate at 88 millimeter at the first hour. The rapid COVID-19 test was negative, and the viral serologies were negative. Also, the cardiac ultrasound shows a minimal pericardial effusion. So at this stage, the diagnoses were either a partial Kawasaki disease or a MIS-C. So the patient received a dose of polyvalent immunoglobulins at the dose of 2 grams per kilogram and acetylsalicylic acid at the dose of 15 milligrams per kilogram on the 9th day of progression. So the evolution was initially marked by the obtention of apyrexia during 48 hours, then worsening of clinical and biological status with multi-organ involvement, renal involvement with a functional renal failure and electrolyte disturbances, and acute liver failure with cytosis 10 times normal with a low prothrombin time at 34% with cholestasis, hematological involvement with pancytopenia and hypofibrinogenemia, and the physical examination shows the appearance of chelates in association with existing lesions. So that the diagnosis at this stage is the macrophage activation syndrome, since we have the clinical criteria, the fever and the splenomegaly, and the laboratory criteria, the hypertriglyceridemia, the hyperferritinemia, and the hemophagocytosis at the bone marrow aspirate. So the etiologies of the macrophage activation syndromes, the tumoral origin was eliminated as no neoplastic origin was found. The immune deficiency was eliminated as the immune assessment shows no abnormalities. The primary macrophage activation syndrome remains a probable etiology as the gene identification is still in progress, and the Still's disease was eliminated since the patient presents achylids and the fever occurrence with the rash was not typical of the disease. So we retained the Kawasaki disease in view of plangid fever, conjunctival hyperemia, skin rash, and the appearance of dilated right coronary with Z-score at 2.52 and aneurysm of the left main coronary with the Z-score at 2.65. So that the patient was put on broad-spectrum antibiotic therapy. He was transfused with blood, fresh frozen plasma, and platelets. We administered vitamin K, and we administered a second dose of polyvalent immunoglobulins at the dose of 2 grams per kilogram with 3 bolus of methylprednisolone, and we obtained the apyrexia 24 hours after methylprednisolone. So he was treated by prednisolone 2 milligrams per kilogram with tapering during 15 days. And we have obtained the normalization of the biological assessment 20 days after the initial presentation. Concerning the coronary abnormalities, So we obtained a normal Z-score at the 6th week of evolution at 1.4 at the right coronary and 1.8 at the left main coronary. So here, a review of literature showing that macrophage activation syndrome is really rare with Kawasaki disease. And thank you for your attention.
Thank you very much for presentation of this very challenging case and also showing us differential diagnosis. I agree that Still's disease is really one of the differential diagnoses, but the fact that you find aneurysm is really speaking against Still's disease. So this is certainly the good diagnosis what you proposed, and also outcome was very quickly good, if I understood. I don't know if there are any questions about this case or comments.
Yeah, I think the main comment, at least in the guides of the guideline for Kawarabi disease, is always refer or ask a specialist. Always go and ask rheumatologist, immunologist, or infectious disease specialist or cardiologist. Do not be stuck with yourself. Ask your colleagues and go beyond the boundaries of your own thinking. So consultation is very important. MAS for me is such a complex thing. We always ask immunology to get involved, because also treatment is not, it's not like a single shot. It's not like on, off, you treat, it works, you don't treat, it doesn't work. It's a complex thing. You have questions?
Thank you for the presentation. To ask you, why did you ask for the quick test COVID? It was better to ask for the serology because it's post-viral, not viral directly. You understand my question?
Yeah.
Fallait demander des IgM, par exemple.
Yeah, we did.
Anti-Covid, pas le test rapide, ça sert à rien.
Oui, j'ai compris la question. We did the serology and it was negative. I don't know if it was mentioned, but we did both.
Thank you. Thank you. A very nice presentation. Concerning the PCR, rapid antigen for COVID, IgM and IgG. In Egypt, usually in this era, always our results are negative, despite the patient has COVID. How I can document this patient has a COVID by anti-spike antibody, and I did serial test. Serial test, first reading how these anti-spike antibody are present in the baby or the infant. Then I read the second type or second reading and how it's rising or declining. I need the comment of data concerning anti-spike antibody for COVID-19.
Yes. So yeah, I have this comment too whenever it comes up, because if we want to consider that this is triggered by COVID, we have to consider or prove there is an active or recently active inflammation and exposure to COVID-19 virus. In other words, if you check only one IgG level, it doesn't go down, doesn't go up, it means this is probably a carrier of IgG from past, like 6 months ago or so. So it's always good to see whether this is an active, recently active COVID exposure or not, to make the link between the inflammation and what's going on now in Kawasaki. Same thing with rheumatic fever. We do ASO, anti-cetrizine O, to make sure that this is not just a carrier from 1-2 years back that the patient had exposure with the strep A. So I leave it up to the immunologists, rheumatologists to compose more about the subject. And just don't take one spot.
The difficulty is that you can have co-infection. And so it's always difficult to make the difference between infection and inflammatory disease, especially early. So if you have enough arguments for something inflammatory, then you need to treat it, or for something infectious, and you can treat for both, so long you don't know. And here, the main problem was this multi-organ failure, and so you have to treat it. And for this, with the very high ferritin and with decreased fibrinogen, mass was really high in the diagnosis. So you need to treat it, because otherwise the patient could die from mass. So you have really some inflammatory disease you need to treat right away, and then you think maybe there is something additional, and you see how the evolution is. This is very important in immunology, is to see the evolution, and your brain should also evolve with this. So you should always ask your question, if the things are not going in the good direction, why? Is this because my first diagnosis was wrong and I didn't see something? Or is it because it's not enough with this drug and I have to add something? But we should never add a new drug on steroids or on another drug to increase the treatment without asking always a question, was it right, my diagnosis, or not? Because we don't have, like, oncologists have just taken a biopsy and they see if they can say what it is. We don't have that. We are relying only on clinical. And this is really crucial for Kawasaki. And the only thing what we know, what we can see, is thanks to our cardiologist friends, because they can see something in the coronary. But we don't want that they see something there, because that means that maybe we did not do our job good enough. We need to do our job before our friends see something. And this is really the difficulty, because we have only a window of a few days to do it. So really go for a hypothesis, and then think again with the time, depending on evolution of the patient. Thank you very much. Yes, so we will move on to the second case. Thank you again. And here we are moving to a case, I think it will be presented on Zoom by Dr. Sulaiman from United Arab Emirates, and it's on high-risk Kawasaki disease.
Do we have Dr. Sulaiman on?
Yes, I'm available. Can you guys hear me?
Yes.
All right, good afternoon, everyone, and thank you, Kawarabi, for the invitation. My name is Dr. Milad Sulaiman, and I'm a fresh graduate. Today's presentation will be on how a misdiagnosed Kawasaki leads to a disaster. So moving on to our case, our patient is a 30-month-old baby boy who was admitted to Hospital 1 on January 2nd with a fever for 4 days and presented with cervical lymph node enlargement and congested throat. The lab showed a positive mycoplasma IgM, a highly elevated CRP, WBC, ALP, procalcitonin, and as well as a highly elevated D-dimer. The platelet count was not available for us. The patient was then diagnosed with atypical pneumonia, where he was treated with IV ceftriaxone azithromycin. The following day, the patient started to develop a rash on the trunk, back, and groin area and was immediately switched to piperacillin tazobactam. On the 4th day, which is the 7th day of the illness, the patient started to deteriorate and show hypotension, puffy eyelids, and cold extremities. He was then transferred to Hospital 2 PICU as a case of septic shock. On transfer, the patient had orbital swelling, peeling of lips, oral ulcers, and rash on the trunk, as well as elevated inflammatory markers and D-dimer. The labs in Hospital 2 showed a highly elevated CRP as well as WBCs. And in the PICU, the patient was started on IV fluids, norepinephrine, and antibiotics. He was given methylprednisolone and IVIG for generalized inflammation without the mention of Kawasaki. The second dose of IVIG was given as well in the PICU, but was given 5 days after the initial dose. The fever was still not responsive to treatment, and antibiotics were changed. Now, they did an echocardiograph, and it showed normal coronary arteries with a 4-chamber dilatation. Chest X-ray showed pleural effusion, and the chest CT confirmed the diagnosis. After 10 days of being in the PICU, he was discharged home, and on the day of discharge, he started to have fever. However, the mother was reassured and advised to continue on the antibiotics. The patient stayed around 6 days at home and presented to the ER at Hospital 3 with generalized fatigue and both hand and foot swelling, and was advised to go to a tertiary Hospital 4. Now, in the tertiary Hospital 4, the initial investigations showed an improved but still elevated inflammatory markers. And he was then started on antibiotics for 1 day. The infectious team were consulted and concluded a likelihood of generalized inflammation process rather than the infectious, and now Kawasaki was suspected. After Kawasaki was suspected, they did an echo, and the echo showed that all coronary arteries are massively dilated with aneurysmal formation, and disease scores, they range from 12.5 all the way to 35. And they did a CT scan and confirmed the diagnosis. Now, as you can see here, the picture on the right shows the right coronary artery with a dilatation of around 10 millimeters. And on the left, we have the left coronary artery also being very extensively dilated. Now here we have the CT scan, and as you can see, there's no obvious thrombi seen in the CT scan. And also, this is another video right here of the coronary CT where it shows the extensive dilatation of both the left coronary artery and the right coronary artery with aneurysmal fusiform formation. And if you can see, compared to the orifice. Now, the patient was started on a 5-day course of high-dose pulse IV steroids, triple antiplatelet therapy, propranolol, and 2 doses of IV Infliximab. Inflammatory markers were now downtrending, and after stabilization, the baby was discharged home, continuing the same treatment. Our take-home messages, we would like to emphasize what was previously said by our colleagues. Keep a high suspicion of Kawasaki, which may be atypical in patients with high fever and appear clinically ill. Kawasaki is a clinical diagnosis with no specific test to confirm it. And do not wait for the dilatation of coronary arteries on echocardiograph to diagnose Kawasaki disease, as it is a complication of the disease. Prompt treatment reduces the risk of coronary involvement, and subspecialty consultation such as infectious disease, cardiology, and rheumatology is recommended for proper diagnosis and timely treatment. And these are the references. And thank you for your time. And I would actually like to thank Dr. Salwa for being my mentor throughout this presentation. Thank you, Doctor.
Thank you very much for your nice and very interesting presentation. I think it's a really educational case that we could use in pediatric congresses to remain what is important for Kawasaki. So really, this is very important. There were a few atypical things which are important to mention. First, mycoplasma infection in a 2.5-year-old boy. This is really not typical. So, and also to go into septic shock after mycoplasma pneumonia is also not typical. So really, these are the points where, as pediatrician, we could have our attention raised and then think, oh, maybe this is wrong, I have to think about something else. So, and also what is important is when a child with such an important symptom will go home and then going home will have fever again. This fever should never be considered as something banal. We should really be very aware about this. So thank you very much for this interesting case. Are there questions?
En fait, c'est un petit commentaire, c'est pas une question. J'apprécie énormément ce dernier cas clinique. Ça illustre bien notre situation. Le problème qui se pose avec les patients qui se présentent avec anévrisme géant. Ce ne sont pas des patients qui se présentent à J5 de fièvre, non. C'est toujours des patients qui consultent à 1 mois. Et selon notre expérience, pour les 4 patients, c'était toujours 1 mois. Et ça m'étonnerait que les parents ne consultent pas pour une fièvre. La première des choses qui alerte les parents, c'est la fièvre. Et généralement, ils consultent la première fois, la deuxième, la troisième, la quatrième. Ils se retrouvent devant des escalades thérapeutiques. On traite une leucocéturie par des antibiotiques, des leucocéturies aseptiques. On traite les hémocultures positives pour un germe retrouvé dans les hémocultures par des antibiotiques et on fait monter l'escalade thérapeutique jusqu'à ce que le patient développe les anévrismes. Donc, je remercie le monsieur qui a présenté ce cas clinique parce qu'il englobe toute notre situation. Quand une fièvre ne baisse pas, il faut vraiment redresser le diagnostic. Et le bébé exprime le Kawasaki cliniquement, typiquement, atypiquement, complètement, etc. Une fièvre qui ne baisse pas, c'est un Kawasaki jusqu'à preuve de contraire. Démarrer l'antibiotique et attends. Les immunoglobulines, démarrer les immunoglobulines et attends. Avant 10 jours, idéalement. Et je vous remercie.
Merci beaucoup. Et vraiment, la seule façon d'avancer, c'est de le marteler régulièrement et dans tous les congrès de pédiatrie, que ce soit dans les pays arabes, mais aussi dans le monde entier, de répéter ça parce que c'est rare, mais il faut l'attraper tout de suite. Et ça, c'est la difficulté de la pédiatrie et la beauté de la pédiatrie, c'est qu'on doit être capable d'attraper les quelques cas qui sont difficiles dans une énorme casuistique. Et c'est loin d'être facile. Hein, c'est pour pas blâmer. On ne doit pas blâmer les pédiatres. Au contraire, il faut les aider en leur donnant les informations. Et Kawarabi est une excellente initiative pour ça. Are there other questions?
Thank you, Sulaiman, for this very nice case. But I think the definition is the Messi rather than Kawasaki. It's Messi and not Kawasaki. It is a spectrum of KD, but it's Messi as hypotension and shock and elevated acute phase reactant.
It can actually be KD shock syndrome because we haven't seen giant aneurysms in Messi. It's most likely, usually we see dysfunction more than aneurysms. I just wanted to summarize what Dr. Mabrouk said in English and add to it. So one of the things that this case highlights is the sequential appearance of symptoms. And it's very important to always have Kawasaki disease on your mind in a febrile child, especially if in a febrile child with shock and when the picture doesn't fit. Mycoplasma pneumonia should not be causing shock at such an age. The other thing it points is you can see this is a case from the UAE where someone had the luxury to go from one hospital to another. We have the same problem in New York City. All the hospitals are close by. You can go shop around from one hospital to another. You don't like what this hospital says, you go to the other. And so there's not a good follow-up. And it's very, very important to take a good history from the parents and to ask them, what did the other hospital say? What did they find? If you have access to the records, go there. The other thing that it points out is that the first echo was normal. And so don't rely on your echo to make the diagnosis. And you saw that the echo was abnormal by day 23, and by that time we had giant aneurysms. And we know that these aneurysms are less likely to resolve and more likely to remodel and to stenose or to thrombose. And I think I summarized what Dr. Mabrouk said and also added a little bit of my own. Any?
So, if you did not believe me that Kawasaki disease is a relapsing fever, one, second, third course, the one after the other, this was the perfect case. This was the natural history, the nasty natural history of Kawasaki disease. These are the worst cases. My last point on this subject is that every textbook and almost every presentation starts with Kawasaki disease is a rare disease. Wrong. It's not rare at all. It's very common. Now in Montreal, we see almost every month, almost every week, especially after the COVID-19 pandemic. So I think it's a revolution not to say any longer that KD is a rare disease, okay? It's orphan disease because it has little resources. It's between common and uncommon disease, but it's not rare disease. What is rare is pointing at the diagnosis. What is rare, unfortunately, is treating the right patient at the right time, and this is where we need to work.
Thank you very much. We will move to the next case, but I see that the cases are raising a lot of comments, very important, so it's a very good session. Thank you very much. And so we move on to the last case presented by Dr. Badr from Morocco, and it's resistant Kawasaki disease. Thank you very much.
Thank you. So hello everyone. I'm Dr. Fadwa Badr. I'm a pediatric resident at El Harouchi University Hospital of Casablanca. And I'm going to be presenting the last challenging clinical case of this session. So we report the case of the little Malek, 9 months old, with no significant past medical history, that was admitted in for a persistent 8-day fever at 40 degrees that was resistant to antibiotics and antipyretics. At examination, Malek had a perineal rash, as we can see on this photo. She has a bilateral non-purulent conjunctivitis, red cracked lips, and the right cervical adenopathy measuring 2 centimeters. For the lab test, they showed a normochromic microcytic anemia, a hyperleukocytosis with hyperneutrophilia, a major inflammatory syndrome with an elevated ESR at 122 mm per first hour, an increased CRP at 260. So with the help of the algorithm, the diagnosis of an incomplete Kawasaki disease was established. And Malek was treated with an IVIG infusion combined with aspirin on the 9th day of fever. She remained afeber for 72 hours before recurrence of a fever. This led to a second echocardiogram on day 16, which revealed a double aneurysm dilatation of the left coronary trunk, measuring 4.1 millimeter, and of the IVA measuring 3.4 millimeter. This justified the second IVIG infusion on the same day, allowing epirexia. A follow-up cardiac ultrasound was performed on day 24 and showed a worsening of the EC aneurysm at 6 millimeters and of the IAV aneurysm at 4 millimeters. The inflammatory screening showed a significant increase in platelets and a persistent inflammatory syndrome. Due to this, the treatment with Anakinra was started for a period of 3 months, combined with aspirin, leading to regression of the inflammatory syndrome. So subsequent cardiac ultrasound at months 2 and 3 showed decreasing dilatation of the aneurysm with complete normalization of cardiovascular findings at month 8. No changes on coronary artery size have been recorded over time with recurrent follow-up of more than 6 years. So why this refractory form of Kawasaki disease? Because it highlights how it's important to raise awareness about the Kawasaki disease even if in case of incomplete forms. It points the importance of the algorithm to help with the diagnosis. It reminds us, or it gives us an idea about how to manage a refractory form. So we have 3 options. Corticosteroids that were recommended in patients under 12 months in association with IVIG and aspirin since 2017. So our patient didn't get any because she was admitted in before 2017. Infliximab is also an alternative, as we can see on this paper published about the intensification of primary therapy of Kawasaki disease. Anakinra have shown a regression of coronary involvement in case reports and case series, as we're going to see this afternoon with the Anakinra experience. So this table summarizes some of the cases and the case series successfully treated with Anakinra. So before just opening the floor for discussion, this is our publication regarding this case if you want any further details or information about this case. Thank you.
Thank you very much for this very interesting case. I have a question to you about the retreatment of Kawasaki. What is the delay? How long can we wait after the first dose of IVIG with fever, still with fever, when we will start with the second treatment? 48 hours, more, less? What is your opinion?
So based on at least the American statement, we consider IVIG resistance when the fever persists or recurs 36 hours after the completion of IVIG. We watch these patients very carefully. We also monitor the inflammatory marker, mainly the CRP. We don't watch the ESR after the IVIG because it's going to be abnormally high. That is what we consider as resistance to IVIG. In terms of your second question about what is the best form of treatment, I don't think we have figured that out. We know for a fact that one, we understand that there are certain high-risk patients that need intensification of therapy from the beginning, along with IVIG. Those who are quite young, less than 6 months, the Japanese consider those less than 1 year. And those with aneurysms at baseline are definitely considered high risk, and we would intensify therapy. So we would give IVIG along with another medication, be it Infliximab, Anakinra, or corticosteroids. And then in terms of treatment of resistant forms, we know that the second dose of IVIG is less effective. Some centers give another dose of IVIG along with steroid tapered over 3 weeks based on Japanese or American data. They give Infliximab or they give Anakinra. And it differs between centers. And at that time, we would call you.
Yeah, just adding to this, what kind of treatment as secondary, at least to control the inflammation. Second dose IVIG is not superior to Infliximab. Should we use Infliximab as second line of therapy? It has to be 10 milligrams because the 5 milligrams failed. 10 milligrams control much better inflammation and reduction of time of fever. It does not control the aneurysm set, for instance. We only had one small series with etanercept. In selective cases, we did see a rather rapid regression of aneurysms as opposed to non-etanercept. I've also witnessed in my practice nice effect of Anakinra in patients with giant aneurysm, and they regressed surprisingly better. Also, in my experience, etanercept did work. So I don't know why Infliximab does not work on the aneurysms. Maybe we don't have enough, but these series are large series with Infliximab, and evidently it didn't help for the aneurysm. But at least if we can control inflammation, we certainly at least reduce the risk of recurrence and further inflammation or additional aneurysms.
Personally, I like very much Anakinra because we know from also pathogenesis that IL-1 is very active, and it's a very short half-life. So if there are any problems, then we can switch directly to another treatment. I don't know if there are questions, or you are...
Actually, yeah, I do have a question because at least in the Arab countries, it is somewhat endemic, or at least tuberculosis, it could be a problem. So the question, before starting these therapies, these modulators, would you check for PPD to make sure that the child does not have any underlying tuberculosis unrelated to Kawasaki disease prior to starting these therapies?
With a TNF blocker, we might have problem in case of tuberculosis. The problem is that you are in acute disease, so you need to treat directly. So you cannot do any tests before, or it's too short to do all these tests before you would give the treatment. That's one more additional reason why I like Anakinra, because the problem with tuberculosis were really typically related to TNF blockers. Are there any questions or comments?
S'il vous plaît, s'il vous plaît, j'ai une question à nos experts. Si jamais un patient qui a des anévrismes géants, plutôt des anévrismes petits ou moyens, et qui aggrave le diamètre de l'anévrisme quelques mois après l'épisode initial, est-ce qu'on le garde sous le même traitement ou bien on rajoute autre chose comme la biothérapie par exemple?
Maybe I will translate the question. So in patients where we have small or moderate aneurysm, if these aneurysms are increasing, are you changing the treatment?
Or adding something else. Not changing, but adding some.
Adding some new treatment on
Yes.
the first treatment.
Few months after the first episode.
Yeah. Yeah. So I think science says we don't know. Okay? If there is no active inflammatory markers ongoing, we don't know if it's going to help. So it's a matter of is it worth it or not? My inclination is when I see progressive coronary artery aneurysm, and typically you want to follow these patients by echo every 2 weeks initially. So I don't think we can afford to wait for 1 month or 2 months to see this growing fast. So my inclination is to use either Anakinra or Infliximab or etanercept in addition. Again, we don't know if it's going to be efficient, but my inclination is first to do echo much more frequent than in 2 or 3 months. So because we're wasting some time of acting on the subsequent inflammation, like underground inflammation. Because after 1, 2, 3 months, maybe there's no inflammation, and whatever we are giving, it typically, or at least I would say hypothetically, it should not work.
I just wanted to add one more thing regarding that question is we know for a fact that those with aneurysms at baseline are at high risk for progression as well. So that's why we intensify therapy, number one. But two, we also, in these particular patients that we call at risk for evolving aneurysms, we repeat the echo in 48 to 72 hours and the inflammatory markers to make sure that we have a control of the inflammation and that the echo, we don't see progression. And at least in the last American update, in the American scientific statement, we require 2 stable echoes. So 2 echoes where the aneurysms are stable within 48 to 72 hours before discharging a patient, if we see evidence of aneurysms. And also we follow these patients, as Dr. Dahtah mentioned, very closely. So we don't, we follow them within within the first week after discharge, and based on what we see on the echo, we follow them more regularly. We don't wait another 4 weeks for an echo. We probably might see them again in 2 weeks. So it might be that we're seeing something in a few months, but it happened even before that.
Very last comment, thank you. Yes, go ahead.
Okay, my last comment. You mentioned, Dada, that the Infliximab has very poor outcome on giant aneurysm. My last patient is 11 months, presenting with myopericarditis and giant aneurysm with the thrombus, and dramatically improved on Infliximab. Within just 10 days, regression, thrombosis resolved, and pericardial effusion resolved. So we haven't variable form of reaction according to this biological agent. I think Anakinra or Infliximab, if we test by interleukin-1, if it is elevated, I think the best solution is Anakinra rather than Infliximab.
So again, this is typical in rheumatology that we try different treatment with our patients, and some patients are responding to Infliximab, some to etanercept or to other drugs in various rheumatic diseases. So really, there is an individual response of the patient, and so we try to use cytokine measurement, but it's not so easy. And with IL-1, we should be careful. It's very difficult to measure because the levels are very low. So sometimes you can rely on IL-1 receptor antagonist also to help you, or IL-6 because IL-6 is related to IL-1. So, but it's still investigational. It's not in the practice. So, Kenza, you have a comment?
Maybe I have a comment about the tuberculosis. We used to screen for tuberculosis before initiating anti-TNF, but also Anakinra, because we are in endemic area. But we don't wait to have the response of the test. We start the biotherapy and then look at the results. It's what we do.
We also test for tuberculosis for all patient we put on biological, but I would be more scared about a problem with anti-TNFs and anti-IL-1, but we have to be careful, and your comment is very well taken. Thank you, Kenza. So I think it's time to close the session. I learned a lot from this session. And I think it was a great session because we were in a dialogue between cardiologists and rheumatologists. And I think it's the best way to give competence for Kawasaki. So thank you very much for all speakers. Thank you very much for the experts. And thank you very much to all of you for the questions and the good discussion, but I think now Kenza has some comments.
Please don't leave. Je voudrais simplement vous dire que sur le programme, le programme SMIRP Kawarabi ne figure pas. Donc il y a encore des sessions dans l'après-midi et demain matin et demain après-midi. On va essayer de vous envoyer ça sur un groupe. Cet après-midi, il y a un atelier d'échographie cardiaque pour les coronaires, pour la maladie de Kawasaki à 3 heures, et un atelier d'arthrite juvénile idiopathique. Et ensuite, il y a une session qui est complètement dédiée à la prise en charge thérapeutique de la maladie de Kawasaki avec tous les nouveaux traitements. Donc merci d'être parmi nous.
وإن رموني في بحور هواهم فإني فقير لا علي ولا معي ومن عجب أني أحن إليهم وأسأل شوقا عنهم وهم معي وإن طالبوني وإن طالبوني في بحور جفاهم دخلت عليهم بالشفيع المشفع
Oh, je peux parler maintenant. Ouais. Mais je Hello? Hello, hello. Allô, allô? OK, très bien. OK, très bien. On commence. Alors, bienvenue à l'atelier d'échocardiographie pour l'exploration des coronaires dans la maladie de Kawasaki disease. Je déclare n'avoir aucun lien d'intérêt pertinent avec le contenu de cette présentation, mais je vous dis aussi que c'est ma première fois de présenter quelque chose en français. Alors, bear with me. Les objectifs de cette présentation, c'est d'établir l'évaluation qualitative et quantitative des lésions des artères coronaires et les fenêtres échocardiographiques de base dans l'imagerie de ces artères. L'atelier va commencer avec cette présentation et puis on a 2 stations avec 2 volontaires qu'on remercie infiniment pour venir ici. Et la faculté où les enseignants, c'est Dr Fahad Al-Ahmadi de l'Arabie Saoudite, Dr Abdel Nasser Dreril, cardiopédiatre du Maroc, Dr Saïd Shreibi, aussi cardiopédiatre du Maroc, et moi-même des États-Unis. Alors, on commence, les anévrismes coronaires, on commence par une évaluation qualitative où la forme de l'artère, ça peut être, ou de l'anévrisme, ça peut être rond ou saculaire, ou fusiforme ou tubulaire. Le pronostic est pire avec ceux ou les formes saculaires. Pour l'évaluation quantitative, on obtient les dimensions lumineuses absolues et on mesure de bord interne jusqu'à bord interne. On mesure l'artère gauche et droite à 3 ou 5 mm de l'origine et on évite les points de bifurcation des artères coronaires. L'évaluation quantitative dépend des Z-scores, ce qui est la dimension interluminale normalisée à la surface corporelle. Il faut qu'on sache qu'une petite erreur de mesure, ça nous prend à une grande variation du Z-score. Et il faut très bien avoir une taille et poids précis, c'est très essentiel pour avoir une surface corporelle bien mesurée. Et la classification des anévrismes coronaires, et ça c'est des recommandations américaines, c'est à base de Z-score. Alors, aucune atteinte, c'est un Z-score moins que 2. Dilatation, c'est Z-score 2 à 2,5. Ou anévrisme de petite taille, c'est entre 2,5 et 5. Anévrisme de taille moyenne, entre 5 et 10, ou valeur absolue de moins de 8 mm. Ou anévrisme géant, c'est un Z-score plus que 10 ou plus qu'au ou égal à 10, ou valeur absolue plus qu'au ou égal à 8 mm. Pour les normes d'imagerie d'échocardiographie dans la maladie de Kawasaki disease, pour la sonde, on utilise la fréquence la plus élevée possible, 12, 9 ou 8, ça dépend de la machine. L'enregistrement ciné numérique, on peut être envisager une sédation dans ceux qui sont moins de 3 ans ou les enfants non coopératifs, agités ou irritables. Chez nous, à Mount Sinai, on obtient au moins une écho sous sédation lors de la phase aiguë ou sous-aiguë en utilisant du pentobarbital à 5 mg par kilo. Alors, on commence par, quand on obtient l'image, on commence par réduire le gain, suivi par la gamme dynamique, pour permettre une différenciation adéquate entre la paroi de l'artère coronaire en blanc et la cavité sanguine en noir. On règle la profondeur du foyer sur l'artère coronaire. On augmente le frame rate plus que 20 pour améliorer la résolution temporelle. L'orientation des faisceaux d'écho doit être perpendiculaire à la paroi artérielle, la persistance, faible ou désactivée, et le color Doppler, on diminue la limite de Nyquist jusqu'à ce que l'artère soit remplie et la couleur est suspendue, mais pas moins que 30 cm par seconde. On augmente le gain couleur pour bien remplir l'artère, mais on évite le débordement ou le saignement de couleur. On commence par les coupes d'écho pour les artères coronaires. La première, et celle qu'on utilise le plus, c'est la coupe parasternale petit axe. On voit la valve aortique en petit axe, avec une légère angulation supérieure, car les artères coronaires naissent de la racine. On peut voir le tronc commun de la coronaire gauche. On peut voir le circonflexe et l'IVA proximale. Une légère angulation, une rotation horaire, on peut obtenir cette image avec une rotation horaire pour visualiser ces trois coronaires. Une angulation bien plus supérieure supplémentaire, on voit ici la valve pulmonaire et on voit aussi l'IVA distale. Une rotation horaire plus marquée peut être nécessaire pour ouvrir cette artère, ainsi qu'un déplacement léger à gauche sur le thorax. On se dirige vers le côté droit de la valve aortique en petit axe et avec une légère angulation supérieure. On peut voir l'artère coronaire droite et avec aussi une rotation ou le CD1, une rotation anti-horaire pour visualiser la portion proximale de cette coronaire. On s'oriente et puis on passe vers la coupe parasternale à long axe et on oriente la sonde vers l'épaule gauche pour ouvrir le sillon interventriculaire ici et visualiser le trajet proximal de l'IVA derrière la valve pulmonaire. Avec une angulation postérieure, on peut visualiser l'oreillette gauche et l'artère circonflexe qui circule dans le sillon auricoventriculaire gauche. Et puis on se dirige, on oriente la sonde vers la hanche droite, au-delà de la valve tracuspide. On voit la CD2 dans le sillon AV droit et on le suit le long de la surface inférieure du cœur jusqu'à l'IVP. Il faut faire attention à l'interface voie-cœur qui peut être trompeuse et simuler l'artère interventriculaire postérieure. On se dirige vers la coupe apicale et avec une angulation postérieure, on peut visualiser la CD3 circulant dans le sillon AV droit. On voit ça ici. Et puis l'IVA est visualisé également parcourant le sillon interventriculaire. Une angulation, il faut faire attention à ne pas faire une angulation antérieure vers l'aorte ou obtenir la syncavité, parce que ça nous permet de visualiser la CD1 ou 2 et non pas la CD3. Si on porte l'attention sur les cavités cardiaques gauches, une angulation postérieure va nous permettre d'accéder au sillon AV gauche. Et on voit ici la circonflexe qui parcourt ce sillon-là. Ici, on voit en fait un patient avec 2 anévrismes géants dans l'IVA. Et aussi, on voit ce qu'on appelle une prolifération myo-antimale intraluminale. Et on voit par color Doppler le flux qui traverse l'artère en délimitant clairement la lumière. Ici à droite, ça c'est le même patient, 6 mois après, avec une masse, avec un thrombus dans l'IVA proximal qui est totalement obstruant de la lumière vasculaire. C'est une masse échogène, ici, qu'on voit dans l'IVA. Et ça, c'est le même patient. Et je voulais vous montrer ça comme un exemple des modifications pariétales des artères coronaires et comment on suit ces patients à long terme pour évaluer les thrombus. Merci beaucoup. Si vous avez des questions. Aucune question. Vous utilisez les mêmes coupes ici quand vous faites les échos?
Oui, on utilise un petit peu à peu près les mêmes coupes. Nous, la différence avec vous, c'est qu'on essaie d'inverser l'image. On a le sommet du cône qui est en haut et la base en bas. Et sinon, on essaie de reproduire un petit peu les mêmes coupes et les mêmes incidences. Petit axe, long axe, en apical. Parfois même un petit peu en sous-postal parfois, c'est un peu plus compliqué, un peu plus difficile, mais voilà, c'est un petit peu les différentes coupes et incidences qu'on utilise pour voir les...
Ok, très bien. Ça, c'est ce qu'on appelle aux États-Unis the adult way, comme les adultes. Et nous, on prend les images renversées par rapport à vous. C'était sur le coronaire. Les valves. Exactement. Et la fonction du cœur. Exactement. Alors, ce qu'on va faire maintenant, c'est qu'on va voir les patients sur les lits avec un enseignant qui nous montre comment on fait l'écho. Et cette machine-là va se projeter ici. Et alors, le Samsung, on a GE et Samsung. Cette machine-là, on va projeter l'image ici. Et il va y avoir un enseignant qui va faire l'écho. Et on va se diviser en deux groupes. Et l'autre enseignant va répondre aux questions des deux groupes. OK? Is that clear? Or do you want me to say it in English? OK. On commence par les deux patients. On va avoir un patient ici et un autre là. On va avoir Dr Driril et Dr Al-Ahmadi de ce côté. Et Dr Shraibi là. Et vous voulez les deux là? OK. Et Dr Al-Ahmadi et moi-même de ce côté. OK. Je voulais je voulais un médecin du Maroc et un autre pas du Maroc, mais ça va. Alors, qui est... on a le patient. OK, très bien. Alors, on a un patient ici et on a les autres.
Ça dépend un petit peu des opérateurs comment ils travaillent. Vous êtes tous des pédiatres. Il y a des cardiopédiatres parmi vous? Alors, moi je travaille avec en décubitus latéral gauche. سميت هذا الوليد هذا؟ جورمي. Moi, je commence toujours avec le long axe. Comme ça, là, on se met au deuxième, troisième espace intercostal du côté gauche, d'accord? Et le curseur, il est orienté vers l'épaule droite, d'accord? Et la règle en échographie, c'est qu'il n'y a pas de coupe ou d'incidence standardisée fixe. C'est-à-dire, le patient a dit, chez le deuxième espace, je vais tomber sur le cœur, sur le long axe. Non, ça n'existe pas. Il faut toujours multiplier, il faut glisser en haut, en bas, les espaces intercostaux. Elle a la coupe qu'on veut. Donc la coupe, il faut mieux qu'elle soit alignée comme ça, oreillette gauche, ventricule gauche, à la sortie de l'aorte, la valve mitrale, la valve aortique, le ventricule droit en antérieur. Ok. Alors ce qui nous intéresse aujourd'hui, ce sont les artères coronaires. Donc pour voir les artères coronaires, on utilise déjà une sonde qui est à haute fréquence, d'accord, 6, 8, 12 MHz dans la mesure du possible. Et puis, quand on mettra la couleur, on utilisera un indice de Nyquist qui soit ما تخافش بابا هذه ما كتقصحش هذه غير تلفزها انت شوف زوينه تخافوا الاول انت شجاع انت. D'accord. Donc la première coupe qu'on utilise pour rechercher et pour visualiser les artères coronaires, c'est le petit axe. Hein. C'est là où on se met au niveau des sinus de Valsalva, au niveau des ostias coronaires, et on essaie de voir les artères coronaires. Alors, on commence par l'artère coronaire du côté gauche, d'accord. Je mets le patient vraiment en décubitus latéral gauche. On diminue un petit peu les gains, d'accord. La focale, elle est bien orientée vers la coronaire gauche. Et j'essaie d'analyser, on va augmenter peut-être un petit peu, on va diminuer le depth, la profondeur, et
Là, on devine déjà la coronaire gauche qui sort à ce niveau-là, au niveau du sinus coronaire postérieur. Et on essaie de rechercher cette coronaire dans ces trois composantes au niveau de ce petit axe. Donc là, déjà, on a une première visibilité de la coronaire gauche. Donc on arrête, on utilise le ciné-loupe, d'accord? Et vous voyez ici qu'on voit très très bien la coronaire, le tronc commun de la coronaire gauche qui est là, d'accord? Si vous ne voyez pas quelque chose, si vous ne comprenez pas quelque chose, il faut nous arrêter, c'est important. Donc le tronc commun de la coronaire gauche, il est là, d'accord? Ça c'est l'aorte, ça c'est l'artère pulmonaire. Et quand je déroule un petit peu, regardez, je vois la bifurcation ici du tronc commun en une interventriculaire antérieure qui va vers le sillon interventriculaire, la partie antérieure du sillon interventriculaire, c'est celle-là, c'est l'IVA qui descend comme ça, et puis la CX normalement qui va dans le sillon interauriculo-ventriculaire du côté gauche. Donc on va la voir ici. Donc on n'est pas obligé, donc il y a des fois où on voit très très bien les trois axes de la coronaire gauche en une seule image, mais il ne faut pas s'attendre toujours à avoir cette image-là. D'accord? On peut, donc là, par exemple, sur cette image, on peut mesurer la coronaire gauche. Alors la mesure de la coronaire est un temps très très important. Il suffit de changer, déplacer le curseur d'1 millimètre et on va passer d'un Z-score de 1,5 par exemple à 3 ou la 4. D'accord, en fonction du poids et de la taille. Donc la mesure, elle se fait du bord interne vers le bord interne du tronc commun, comme là. Il faut essayer de s'éloigner de la zone de bifurcation, c'est important. Et là, par exemple, on a 3. Alors 3 mm pour un enfant de cet âge-là, ça ne veut absolument rien dire. Dans votre compte rendu, il faut absolument se référer au poids et à la taille du Z-score pour avoir une idée sur est-ce qu'on est dans la zone dilatation ou est-ce qu'on est dans la zone normale du tronc de l'aorte, oui. Donc il faut se mettre pratiquement. Juste, il faut savoir qu'il y a des variations anatomiques du tronc commun de l'artère coronaire gauche. Il y a des troncs communs qui sont courts, il y a des troncs communs qui sont longs, d'accord, qui sont très lents. Il y a même des troncs communs qui sont inexistants, d'accord. D'emblée, on va voir l'IVA et la CX qui bifurquent à partir du sinus coronaire. Ça existe aussi. Donc là, on a vu la coronaire gauche. Et puis, on va encore revenir en arrière. Et vous avez ici la coronaire, l'interventriculaire antérieure, qui est là, qu'on peut mesurer encore une fois, bord interne jusqu'au bord interne. D'accord, elle fait 2 mm. Alors, il n'y a pas de règle. On n'a pas toujours, par exemple, le tronc commun qui est supérieur, qui a des dimensions supérieures à l'IVA. Ça n'existe pas. Donc, c'est pas des... Donc, on peut avoir une IVA qui est beaucoup plus large que le tronc commun. C'est tout à fait possible. Donc là, on voit le départ. Pardon. On voit le départ ici. Pardon. On va voir le départ ici d'une diagonale. Vous la voyez ici, à partir de l'IVA. Elle est là. Donc c'est le départ de la première diagonale. Et parfois, on peut avoir un peu plus de chance, voir les septales qui divergent à partir de l'interventriculaire anterne. Donc là, on a vu une grande partie de l'IVA proximale. OK. Et puis, on va essayer de voir si on a la chance d'avoir une CR. Et il faut savoir que l'échographie des coronaires, c'est toujours dans la mesure du possible. Ça nous arrive des fois, on peut ne pas voir des troncs coronaires. C'est tout à fait possible. Il ne faut pas toujours s'attendre à avoir... Alors, plus les artères sont dilatées, plus elles sont anévrismales, plus c'est simple. Là, on est en train d'examiner, je pense, un enfant qui est tout à fait normal. Donc, c'est pour ça que... Alors, pour voir la circonférence, on la voit très bien ici. elle va dans le sillon interauriculoventriculaire gauche. Hein. C'est celle-là. Voilà. C'est celle-là, c'est cette artère, ça c'est l'IVA. On la voit un peu moins bien. Et là, c'est la circonflexe, c'est l'artère circonflexe. Donc on peut la mesurer elle aussi. Le plus souvent, elle est un peu plus petite que l'IVA, mais il n'y a pas de règle. Alors quand vous avez une artère comme ça qui est 1 mm, 2 mm, le plus souvent, c'est des artères qui sont normales. Donc elles ne sont pas dilatées. Alors quand on dépasse les 2 mm, il faut se référer aux Z-scores, c'est très important. Donc ça, c'est la coupe petit axe qui montre la coronaire gauche. On a vu un petit peu l'IVA proximal, on a vu la CX, on a vu le tronc coronaire gauche commun, et puis on se rabat sur la coronaire droite. Alors la coronaire droite, elle prend départ au niveau du sinus coronaire antérodroit. Et là, on voit le départ de cette coronaire droite. Elle est là. Donc, on voit le départ de cette coronaire droite. Donc ça, c'est l'aorte. Et ça, c'est la coronaire droite qu'on peut mesurer. Encore une fois, bord interne, d'accord. On est à 2 mm. Alors, voilà, encore une fois, on peut la voir. Voilà, on la voit très très bien, la sortie de la coronaire droite. Alors ensuite, alors la coupe qu'elle a montrée tout à l'heure de... Donc au niveau de on prend vous avez l'artère pulmonaire ici, vous avez l'aorte ici, et on peut longer. Donc on peut encore une fois longer l'IVA. On la voit là, ici, jusqu'à une partie très distale de l'IVA. On peut même la suivre encore plus en distalité. Alors je vais vous montrer, il est quelle heure d'abord? Il est 32. Alors normalement il faut être à l'aise, hein. Il faut avoir le plan il faut que vous soyez au-dessus du patient, hein. Pas comme ça. Là on n'a pas de tabouret, mais alors on se met en 4 cavités, d'accord. Oreillette gauche, ventricule gauche, oreillette droite, ventricule droit, pour les gens qui n'ont pas l'habitude de voir ça. Et là, je béquille un peu en antérieur. Et qu'est-ce qu'on voit ici? Je béquille en antérieur, comme ça. Et on voit très bien la circonflexe. Elle est là. Là, c'est le ventricule gauche, là, c'est l'oreillette gauche, et ça, c'est le sillon interauriculoventriculaire. On voit très bien la partie un petit peu moyenne et distale de la CX. On peut la mesurer ici. Parfois, on a du mal à la mesurer en petit axe. On peut se mettre comme ça en 4 cavités, et on peut la mesurer à ce niveau-là. Alors, je me rabats sur le sillon interauriculoventriculaire du côté droit, maintenant. Et vous voyez qu'on peut voir la portion, là, on voit très bien la coronaire droite. On l'a vu tout à l'heure dans sa partie proximale. On peut la voir en D2, en D3, au niveau de ce sillon interauriculoventriculaire droit. Le sillon interauriculoventriculaire droit, on peut la mesurer, vous la voyez très bien ici. Ok, on peut la mesurer à ce niveau-là. Alors il y a aussi... Alors, il y a des coupes qui sont un peu plus compliquées que les autres. On va essayer de les avoir puisqu'on a un enfant qui est relativement bien écogène. Donc on va diminuer un petit peu le gain. Et j'essaie de voir l'interventriculaire antérieur dans sa partie moyenne et distale au niveau du septum interauriculaire ici. Elle peut être tangente. Parfois, on a la chance de la voir et de la mesurer. Alors, ce qu'il faut savoir dans la maladie de Kawasaki, c'est que les atteintes coronaires sont souvent proximales. c'est essentiellement proximal. Les anévrismes et les dilatations intéressent essentiellement les segments proximaux et que les segments distaux sont rarement, exceptionnellement, qui sont touchés. Donc l'interventriculaire antérieur, alors je ne sais pas, peut-être qu'il est passé, mais c'est des coupes qui sont un peu plus difficiles à voir. On devine ici, mais ce n'est pas sûr que ce soit l'interventriculaire antérieur. Et puis, on peut aussi essayer de voir au niveau de la paroi postérieure le passage de la Ardaouldi Safi. انت ما كنقصحكش كنقدر دير كوال Alors j'essaie de voir si on peut choper. Ah, elle est là. Elle est là. Si on peut choper la coronaire droite, voilà, qui est là, et elle va jusqu'à se diviser en rétroventriculaire et en interventriculaire postérieur. C'est celle-là. D'accord? Elle longe la paroi inférieure du ventricule postérieur du ventricule droit jusqu'au niveau de l'apex, où elle se divise. Ok? Alors après, il y a des coupes un peu plus... Alors je reste dans le long axe. Avec le long axe, on peut aussi voir la partie proximale des coronaires. Hein. Donc ça, c'est la sortie de l'aorte. Ok? La sortie de l'aorte. Et vous avez ici, je ne sais pas si vous le voyez, il faut faire des rotations dans le sens horaire, dans le sens anti-horaire. Donc vous verrez en fonction de la facilité et des cas, vous pouvez voir, là on voit la partie proximale de la coronaire droite qui prend naissance au niveau du sinus coronaire. Elle est là. Elle est là. Elle est là. Au niveau du sinus coronaire antéro-droit. Et puis, on peut regarder au niveau, donc on fait une bascule et on peut regarder le départ, vous le voyez ici très bien, de la coronaire gauche à partir de son ostium. Là, on voit très bien là l'ostium de la coronaire gauche, du tronc commun, et puis le départ qui va suivre. Là. D'accord? Pour donner l'IVA et pour donner l'IVA qu'on a longé tout à l'heure, qu'on a vu au niveau de la paroi postérieure, et la CX. Alors après, la couleur, elle peut servir aussi, c'est très important. Et pour faire la couleur, ce que je vous conseille, c'est de diminuer l'indice de Nyquist au maximum, enfin jusqu'à 30 éventuellement. Alors on met la couleur et puis j'essaie de diminuer l'indice de Nyquist. Jusqu'à ce qu'on commence à voir le flux au niveau de la coronaire. On augmente un petit peu les gants aussi, dans la mesure du possible, sans trop baver. Pardon. On voit ici le remplissage, mais le plus souvent, on n'a pas besoin. Mais tout à l'heure, elle a montré, là, on voit très bien la coronaire qui se remplit. Mais comme elle a montré tout à l'heure cet anévrisme de l'IVA tout à l'heure, elle a montré qu'il y avait une prolifération intimale qui comble un petit peu cet anévrisme, tu as vu. Et il y avait le tunnel à l'intérieur de l'anévrisme qui est persisté. Et c'est peut-être à ça que ça peut servir une couleur. Voilà, je te laisse...
Juste une remarque, c'est qu'il faut vraiment s'entraîner à voir ce que sont les artères normales. Parce qu'il y a tellement d'images artificielles, on peut nous prendre comme de l'anévrisme. Il faut vraiment savoir ce que c'est une artère coronaire normale, où est-ce qu'il est. Remarquez ici, par exemple, on peut rapidement prendre quelque chose comme un anévrisme. je peux prendre une image, tu peux la montrer.
Laquelle?
Plein d'images qu'on peut construire.
Ah
Voilà,
ouais.
c'est ça. Tu as une dilatation, tu dis attention, ça l'anévrisme, alors que c'est pas une artère coronaire. C'est des images, il y a des superpositions de points, donc il faut vraiment être sûr.
Sinus coronaire.
C'est pour ça que le remplissage vasculaire par le Doppler est très important. Une image qui ne se remplit pas, c'est forcément pas vasculaire. Donc,
Et puis, comme a dit Siab Mounen, on peut se mettre en apical, on dégage le sinus coronaire, on peut le prendre s'il n'est pas très dilaté, s'il est tout petit, on peut le prendre parfois pour une artère coronaire droite, hein, tout à fait, une artère coronaire droite, alors que ce n'est pas une artère coronaire droite. D'accord? Donc là, on va essayer de dégager ce sinus coronaire qui est là, mais ça, c'est bon, là, il est un peu plus gros, hein, il est un gros, donc c'est flagrant.
vous allez me dire que c'est une dilatation de la sinus.
Alors que c'est pas ça.
Il y a plein de diagnostics différentiels, donc il faut faire attention, parce que le diagnostic, le pronostic va beaucoup aussi. Vous risquez également de poser un diagnostic de phase Kawasaki alors qu'il n'y a rien.
Alors l'échographie, on l'a fait au moment du diagnostic, c'est-à-dire au moment où le patient fait la fièvre, à 4 semaines et à 8 semaines éventuellement. Si tout va très bien, on ne refait plus. D'accord. Si maintenant il y a une atteinte coronaire, il va falloir peut-être revoir le patient un peu plus régulièrement et de façon un peu plus rapprochée. Je te laisse ça, Abdel Nasser. Oui, on va changer. Ok, ça marche. Après, c'est avec ça a marché. Si vous avez des questions, n'hésitez pas.
Bravo.
Alors normalement, à partir de la fin de la première semaine, 10 premiers après, à partir du 10e jour, on peut avoir les anévrismes. Et ce qui arrive le plus souvent, c'est qu'on n'a pas la date exacte. On peut avoir la date exacte de la fièvre, d'accord? Mais la date exacte de la maladie, on ne peut pas l'avoir. Mais ce qui est communément admis, c'est qu'on peut avoir des artères, des anévrismes de l'artère coronaire à partir du 10e jour, du 7e, 10e jour. Deuxièmement, chez les enfants qui sont tout petits, de moins d'1 an, chez les enfants qui ont de la fièvre, très important, chez les enfants qui ont une résistance au traitement, chez les enfants qui vont garder un syndrome fébrile un peu plus longtemps, chez les enfants qui ont un retard diagnostique, chez qui on les voit un petit peu en retard, ce sont les cas où on voit le plus souvent des
on doit attendre une semaine pour faire des coupures.
non, c'est pas le message, il faut absolument la faire immédiatement. Au moment du diagnostic. Au moment du diagnostic.
C'est rare que ça soit positif pour les 10 premiers jours. C'est extrêmement rare. Plus souvent, il est négatif au début. Il va se positif après. Éventuellement, tu peux en voir, mais il faut le faire systématiquement. Il faut systématiquement faire le.
Il faut faire en principe 3 échos. Même si le patient n'a rien du tout. Il faut la faire au moment du diagnostic, c'est-à-dire G1, G2, G3. Il faut la faire à la 4e semaine, 6e semaine. Et puis par la suite, il faut la faire à la 8e, 10e semaine. Bien sûr. Alors ça nous arrive de voir des artères qui sont complètement tortueuses, qui sont anévrismales, qui sont dilatées, par moments sténosées, par endroits sténosés, ou bien ils peuvent être dilatés de façon uniforme. Ils peuvent avoir une dilatation saculaire comme ça, ce sont les plus dangereux, qui risquent de se rompre, même si moi personnellement j'en ai jamais vu de rupture de.
Non, on ne va pas le voir parce qu'ils font des arrêts cardiaques.
Mais j'en ai jamais vu.
Pas d'autopsie malheureusement.
Et quoi d'autre? Et ce qu'il ne faut pas oublier aussi, c'est que quand on vous envoie quelqu'un pour faire une échographie au Kawasaki, il ne faut pas se focaliser seulement sur l'échographie. Ça nous arrive régulièrement de voir des échanges cardiaques. Il va falloir quantifier des insuffisances nitrates, il va falloir quantifier correctement, des fuites aortiques, il va falloir quantifier, des atteintes myocardiques, c'est très très important. Donc déjà de visu, vous allez voir que sur votre ventricule gauche, votre ventricule droit, ils sont malades, ils ne se contractent pas correctement, il faut faire un TM pour évaluer la fraction d'éjection. Il faut faire... c'est pas celui-là, non? Le suivant, là, texte.
باين
Et voilà, donc
اجي
il y a des cas qui sont exceptionnels.
باين هذاك
Sur Kawasaki.
on est habitué, hein. On est habitué aux enfants. جيبي لي سميت عمران ياش سملالي
Bon après-midi. Ah. Bienvenue. Très importante, très intéressante, pour le bénéfice de tout le monde, incluant moi-même. Il faut le dire qu'à chaque fois que j'assiste, j'apprends quelque chose de nouveau. Donc, merci encore aux organisateurs, très particulièrement à Dr. Kenza Boyed ici, qui a été une personne clé à inclure Kawarabi au pays et surtout dans cette conférence. On s'entend quand même qu'on veut bien être présent au possible et imaginaire parce que l'union fait la force. Donc, il me fait plaisir de présenter cette session particulièrement importante et intéressante avec mes co-modératrices, Dr. Sima Abou Saoud من فلسطين, عربنا معكم, Dr. Hala Agha من القاهرة, et moi-même Najib Dahtah, Lebanon and Montreal. So welcome everyone to this particular session, very important for the treatment and for the outcomes of Kawasaki disease patients. The topic is treatment of KD. What does the practitioner needs to know?
It is my pleasure to introduce my dear friend and Professor Dr. Kenza. She will present intravenous immunoglobulin and aspirin. The floor is for you.
Please, Oussama. Oui. Ça ne passe pas encore. Si. Ok. C'est bon. On fait marche arrière. Thank you for this kind introduction. Dear colleagues, good afternoon. It's my great pleasure to start this session about treatments of Kawasaki disease, and my topic will be in IVIG and aspirin. And all of you know that the gold standard first therapy of Kawasaki disease during the acute phase is the combination of IVIG and to use, and also the role of IVIG in preventing coronary artery lesion and the dose of aspirin. And we'll discuss all these questions all together. This is my timeline. After this brief introduction, I will move to the first part of my presentation, which is about IVIG. And we know that IVIG have been widely used in Kawasaki disease, and their efficacy has been proven to control inflammation and to prevent coronary artery lesion that constitute the fare of this disease. How aimed to identify the most appropriate dose to give to patients. They used a national Japanese database and could include patients treated with IVIG between 2010 and 2020. There was about 90,000 patients with Kawasaki disease, and they could demonstrate that there is a U-shaped association between IVIG dose with the bottom of the curve at 2 gram kilo and the proportion of coronary artery lesion. Also, with IVIG resistance, length of stay, and medical cost, meaning 2 gram kilo versus low dose of IVIG, meaning 1 gram kilo in patients weighing 25 kilo and more, knowing that high dose of IVIG can be associated with a lot of adverse effects, and that high dose has a really high burden, financial burden. And they could demonstrate that there was no significant difference of coronary artery aneurysm occurrence, IVIG resistance, and length of stay. But there was medical cost that was higher in the high-dose group. These findings allow to conclude that 2 gram kilo is the most appropriate dose, but maybe for older patients who weigh 25 kilo or more. And here, this study is a meta-analysis, a systematic review that compared the clinical outcome of early administration of IVIG, meaning before the 5th day, and conventional IVIG treatment after 5 days of fever. They included 27 studies and more than 40,000 patients, and they showed that the earlier IVIG treatment within 4 days had a higher IVIG resistance rate. Also, that IVIG given more than 7 onset had lower risk of coronary artery occurrence during the 2 first months of follow-up. All these findings, pooling data coming from multiple studies, allowed to conclude that the optimal therapeutic window to give IVIG is within 7 days. Concerning speed of IVIG administration, there is 2 regimens. The first one is the short regimen, 10 to 12 hours. It is recommended by the American Heart Association. And the second one, but this editorial could show that both regimens may be comparable in terms of efficacy and safety, but shorter infusion may facilitate to make a decision regarding the need of additional therapy in refractory forms, but also maybe to shorten the duration of the hospitalization. What about safety and vaccination? I advise you to read this article if you are interested about adverse effects of IVIG. Adverse effects also have been reported. And these authors could identify 2 groups of risk factors. The first group is related to the preparation, and a high concentration of IgA and high concentration of anti-Rh blood group D antigen are associated with very high occurrence of severe adverse effects. The second risk factor is related to the patient itself. For example, important for us as pediatricians. And the European and the American guidelines recommend to defer all live vaccines at least 11 months after IVIG, because IVIG may reduce the efficacy of live vaccines, except in one situation, for example, in epidemics. And currently, we are living in Morocco, an epidemic of measles. So we can advise to vaccinate our patients, and maybe to content part of this presentation, which is about aspirin. And you know that aspirin is a part of the standard therapy in Kawasaki disease. It has been used for many years. It is administered during the acute phase every 6 hours at a daily dose of 80 to 100 milligram kilo day in USA, which is very high doses, when it is administered at moderate dose in Europe and Japan, then decreased to low dose after apyrexia, and maintained 6, and been a great debate concerning the optimal dose of aspirin and the effectiveness of aspirin to prevent coronary aneurysms. On the other hand, there is no doubt in the effectiveness of aspirin to prevent aneurysm, coronary aneurysm thrombosis. This study aimed to compare high dose of aspirin with low dose. It is a meta-analysis during a very long period, and they could define high dose as dose of 30 milligram kilo day or more, and low dose at a dose of 3 to 5 milligram kilo day. They studied 5 parameters and could include 8 retrospective studies that you can see in the table below. And the results is that there is no differences concerning the incidence of coronary artery lesion, as well as the days of hospitalization and the IVIG resistance. But patients who were treated with high doses had shorter period of fever, And all we know that aspirin is an antipyretic molecule and more severe adverse effects. So they recommend to use a low dose of aspirin. This study is very interesting. This title caught my attention because here you see without aspirin. And these authors aim to compare patients treated with high dose of aspirin to patients who were treated without aspirin or with low dose of aspirin in case of cardiac involvement. It is a retrospective study, multi-center study, including 8 studies, Japanese hospitals. The authors fixed 2 objectives. The primary outcome was the presence of coronary lesion, and the secondary outcome was the response to initial IVIG. And they could demonstrate that the incidence of coronary artery lesion was no significantly higher in the high-dose group compared to the non-high-dose group, as well as for the percentage of non-responder to initial IVIG, with a percentage very similar and very close. All these findings allow these authors to suggest that we had to reconsider current guidelines that recommend to administrate aspirin during the acute phase. But despite all these controversies, the last update on diagnosis and management of Kawasaki disease from the American Heart Association, published in 2025, continue to recommend to use the association or the combination of IVIG with a moderate dose of aspirin, meaning 30 to 50 milligram kilo a day. To conclude, there is no real changes concerning IVIG administration. Concerning aspirin, it still has its place as a molecule anticoagulation in anticoagulation to prevent coronary aneurysms, but its use in the acute phase to prevent coronary aneurysms is highly controversial and may require more prospective studies to exclude it definitely from the therapeutic in the acute phase. And thank you for your attention.
Thank you, Kenza. Very elegant presentation and very informative for us. Any question from the floor? Yes, please.
So,
could you introduce yourself, please?
Oh, I'm sorry, I am Isabelle Conepo. I am pediatric rheumatologist in Paris. So I have a question to Kenza. It's not a question, but more a remark. So you have presented studies that conclude that the optimal time to use IVIG was 7 days.
Yes.
I would say that we have really to interpret this with caution because we know that those patients who have complete feature of Kawasaki disease very early, in general, they are very highly inflammatory.
Yes.
And in general, of course, they are not responsive to IVIG. It doesn't mean that we don't have to use it, but maybe we have to use it plus something else,
yes,
or something else we have still to define. So I think in Kawasaki disease, every second counts and increase the risk of developing coronary aneurysms. Don't miss time and use IVIG plus something else. So I am just
I
take
agree.
this with caution.
I agree completely with you, and I think that you are speaking about these patients who are who have high inflammation, and these patients are at a high risk of coronary aneurysm. So we have to behave with them differently. So we have to add something. Sure.
Any comment or? Please, your participation is very important to learn from each other, even different language, Arabic, French, English. Please, you are here for interaction and for us and for the patient. So, my question and my comment. Concerning the intravenous immunoglobulin for the timing and duration. For me, in my experience, if the patient has left ventricular dysfunction, I prefer a longer duration.
Yes.
And even I give a diuretic dose before our start, and even I extend from 24 up to 48 hours. I am afraid from this left ventricular dysfunction as a pulmonary edema.
Yes.
This is a point.
It is a recommendation. It is clear. If we have a cardiac failure or something like that, we have to select the longer infusion.
Okay.
As in MISI. And MISI, we learn a lot about
Yes.
MISI.
Yes.
During MISI, about Kawasaki. And if there is a myocarditis, of course, we have to choose the longer administration. So it depends.
Yeah.
But if you have a classical case, without maybe high-risk factors, this is the recommendation.
And what about in practice? If I have a patient in a private hospital, it's totally different from university hospital.
Yes.
So I am afraid from the complication. So the resident prefer to give DEXA before injection. What is your experience?
No, we don't give any steroids before the IVIG,
Okay.
Except in the case of we have the indication of corticoids, meaning very young infant or other recommendation.
And what is the most common complication you confronted by intravenous immunoglobulin?
I think the most common we met is fever.
Yes. What else? What else?
Chills, fever.
And what about bradycardia? I had patients with
Very
severe
rare.
bradycardia.
Very rare.
I had
Very
one
rare.
of my patients with a severe in a private hospital.
Very
so
rare.
This patient is syndromatic. That is why I am afraid from this bradycardia and holding this intravenous immunoglobulin and wait and see.
Maybe
then
he
return
has an underlying disease.
It could be.
Maybe.
But I didn't test before, but I had severe bradycardia before. Any comments?
Yeah, I see this question of rate of IVIG coming back and back and back here and there in different meetings. I have to face this with my cardiology expertise in Kawasaki disease in two aspects. First of all, we were probably among the first, not to say the first, to use anti-proBNP in research studies. My first concern was, is the rate of IVIG 10 to 12 hours, does it change the anti-proBNP if anti-proBNP was high? The answer, based on our experience in research, it does not change. So if you give it over 10 to 12 hours, anti-proBNP, let's say it's 1,200, it will stay about the same, or it drops because it is efficient. Only those who have really severe dysfunction, and it is rare occasion, but some dysfunction, I don't think we should worry about this. If it's a really severe dysfunction, I think it's acceptable to give over 20 hours or 24 hours with or without Lasix. But I would like people to be aware of not to stretch too much because it is dose dependent, it's also rate dependent. In other words, in the past, we used to give IVIG over 5 days or 4 days, 500 milligrams per kilo per day for 4 days. And it's half useful compared to one dose within 10 to 12 hours. So please stick with that, it's very important. Those are in real heart failure, it's a different story, and we can manage this differently with
Maybe we
diuretics.
have problems with patients who are older and who need a high dose of IVIG. But with the infant, I think that the shorter regimen is really recommended.
Some, and not pediatric cardiology, uses the 400 milligram per kg for 5 days. But for pediatric cardiology, they usually do the 2 gram per kg, provided extending duration or a shorter duration. Concerning the aspirin, I think it's time to change the low dose, high dose media to be antiplatelet dose to facilitate our life. Antiplatelet dose or anti-inflammatory dose. I think it is worse it is anti-inflammatory 30 to 50 or antiplatelet dose
Yes.
3 to 5 milligram.
Exactly.
What is your comment?
My comment is we used, since I can tell more than 8 years, the moderate dose of 30 to 50 milligram kilo day. But since these last months and maybe last year, we tried to use the new regimen, which is about 3 to 5 milligram kilo day, and it works.
And
It
what
works.
is the commonest or the side effect of aspirin during your Kawasaki?
It is hepatic liver cytolysis.
And what else?
No, nothing else, especially liver
For me, I
enzymes,
confronted with a
increase.
patient with a rash.
With a rash, okay.
Yes. It's confusing. It is
Yes.
like a relapse or recurrence or a complication, but it's from the aspirin.
Okay.
Thank you, Kenza.
You're welcome. Thank you very
Amazing.
much. Thank you.
Okay. So now we're moving to the second session, which will be about the use of glucocorticoids. This talk will be presented by Dr. Bushra Shkirat from Morocco. The floor is yours.
C'est la présentation d'il 15 ans. Voilà, c'est bon. On fait une mchi هكا صافي. لا ما كاينش. Pardon. Merci. Alors, à mon tour, et en tant que vice-présidente de la SMIRP, je tiens à souhaiter de nouveau la bienvenue à nos invités experts, aussi bien du Kawarabi et français, pour leur soutien et pour leur participation, et aussi à mes collègues et amis pédiatres ici présents de la SMP et de la PELIP. Donc, moi, je vais parler de la place des corticoïdes dans le traitement de la maladie de Kawasaki. Comme vous le savez, ce traitement, il a été exclu et banni pendant des années de l'arsenal thérapeutique de la maladie de Kawasaki. Et puis, il y a eu un regain d'intérêt ces dernières années. Alors, je vais passer rapidement, donc ça, on l'a vu depuis toute la journée. La maladie de Kawasaki, c'est la plus fréquente des vascularites pédiatriques après les vascularites IgA. C'est la première cause des cardiopathies acquises dans les pays développés, avec une forte prédilection pour l'atteinte des coronaires, et le diagnostic repose sur les critères de l'AHA révisés en 2017. Vous savez, il n'y a pas de test biologique spécifique qui permet de confirmer le diagnostic. 5 critères sur 6 parmi les critères cliniques avec une fièvre, même quand elle dure moins de 5 jours, sont suffisants pour porter le diagnostic. Et les objectifs thérapeutiques dans la maladie de Kawasaki étant une urgence diagnostique et thérapeutique, c'est de contrôler l'inflammation systémique et la fièvre, de réduire l'atteinte des coronaires et de prévenir la survenue du thrombose. Et pour répondre à la question pourquoi, quand et comment utiliser les corticoïdes dans la maladie de Kawasaki, j'ai fait appel à ces références bibliographiques toutes récentes de 2019 à 2025. Et pour répondre à la première question, le pourquoi des choses, comme vous le savez, la maladie de Kawasaki, il y a une forte inflammation, et donc les glucocorticoïdes sont utilisés pour leurs points d'impact multiples, et en premier pour leur action anti-inflammatoire puissante, et notamment l'inhibition de la sécrétion des médiateurs de l'inflammation, les leucotriènes, les prostaglandines, thromboxane et les facteurs d'agrégation plaquettaire via l'inhibition de la phospholipase A2, et donc une réduction de la perméabilité vasculaire, la synthèse des radicaux libres et de l'action des protéases. La maladie de Kawasaki étant une vascularite primitive, et donc il y a une activation anarchique et du système immunitaire inné et du système adaptatif, et donc les glucocorticoïdes sont utilisés pour leur action sur la réponse immune et donc sur l'expression de la cellule présentatrice de l'antigène. Il inhibe la prolifération et la différenciation lymphocytaire et l'activation et la maturation des lymphocytes B, et donc une réduction, une inhibition de la sécrétion des cytokines pro-inflammatoires. Et toujours pour le pourquoi des choses, il y a ces deux références. En fait, cette revue systématique qui est sortie dans le Pediatrics en 2023, où les auteurs ont comparé l'utilisation de corticoïdes ou non chez les patients à haut risque, et aussi cette étude d'actualité dans le diagnostic et la prise en charge de la maladie de Kawasaki. Eh bien, les conclusions, c'est que les auteurs concluent que, donné à la phase aiguë, chez les patients à haut risque, les corticoïdes permettent de réduire l'atteinte des coronaires, de réduire fortement les marqueurs de l'inflammation et de raccourcir et la durée des symptômes et de la durée d'hospitalisation. Maintenant, quand utiliser les corticoïdes? Nous, en tant que praticiens, on doit savoir quand est-ce qu'on doit utiliser les corticoïdes dans la maladie de Kawasaki, et donc, autrement dit, quels sont ces patients à haut risque? Et la première indication, c'est par rapport à l'âge. Chez les nourrissons de moins de 12 mois. Pourquoi? Parce qu'il s'avère que c'est des formes très inflammatoires, c'est des formes qui sont incomplètes ou atypiques et donc source de retard diagnostique et de complications, et avec une grande susceptibilité à l'atteinte coronarienne. La deuxième indication, c'est dans les formes résistantes. Et on a parlé de ça tout à l'heure. Les formes résistantes ou réfractaires se définissent, c'est des cas où la fièvre persiste 36 à 48 heures après la première perfusion d'immunoglobuline intraveineuse. Ça peut se voir dans 10 à 20% des maladies de Kawasaki, même bien traitées. Et c'est des situations à haut risque d'atteinte coronarienne. Ceci a été bien démontré dans des études observationnelles et dans des séries bien que courtes. Donc la corticothérapie a montré un effet bénéfique chez ces patients-là. Troisième indication, c'est les formes avec des signes biologiques de SAM. SAM étant une urgence diagnostique et thérapeutique, on l'a vu depuis tout à l'heure, on a parlé de ça, et donc l'existence de signes biologiques, pancytopénie, fibrinopénie, hypertriglycéridémie, cytolyse, hyperféritinémie, hyponatrémie, et même en absence d'hémophagocytose, il faut intensifier le traitement et associer la corticothérapie au traitement de première ligne. Autre indication, c'est le Kawasaki Shock Syndrome. Kawasaki Shock Syndrome, bien que rare, mais ça existe et ça se définit par une grande instabilité hémodynamique avec une hypotension, une hypoperfusion périphérique, avec des niveaux très élevés d'inflammation liés à une tempête cytokinique très importante. Et comme on le voit sur le schéma là, c'est une activation primitive et inappropriée du système immunitaire inné suite à la fixation des DAMS et des PAMS au PRR, et ça donne donc avec une grande infiltration par les monocytes et les macrophages et une sécrétion de médiateurs de l'inflammation. Il s'ensuit une activation secondaire de l'immunité adaptative avec une sécrétion très importante de cytokines pro-inflammatoires par les lymphocytes et les macrophages, et ça donne un orage cytokinique avec un état de choc et une dysfonction du myocarde. C'est des formes qui peuvent se voir à la phase aiguë et avec une fièvre qui reste prolongée, et c'est des formes qui résistent au traitement par les immunoglobulines intraveineuses. Ça se voit plus fréquemment chez les enfants ayant des formes atypiques ou des formes incomplètes de maladie de Kawasaki. Et bien sûr, là, les corticoïdes sont indiqués et pour leur action anti-inflammatoire et pour leur action immune. Aussi, quand utiliser les corticoïdes, vous savez que la gravité de la maladie elle peut être évaluée par un certain nombre de scores, qui ont montré une sensibilité, une spécificité qui reste variable quand même selon les populations. Il y a l'étude Kawanet qui a été faite en France chez 465 patients. Donc, bien, ils ont trouvé aussi une sensibilité en fait qui n'est pas satisfaisante pour la majorité de ces scores, et qui ont proposé proposer un nouveau score qui paraît plus sensible, mais qui nécessite d'être validé dans une large population. Toujours est-il, le score de Kobayashi avait une sensibilité satisfaisante dans la population japonaise et allemande, et donc qui est basé sur un certain nombre de variables et avec une cotation en points, et un score supérieur à 4 permet de définir des formes avec une grande résistance et une indication à intensifier. Le traitement est associé à la corticothérapie, à l'arsenal thérapeutique. Et puis, quand il y a les anévrismes, bon, là, quand les anévrismes sont là, c'est d'emblée des formes sévères qui peuvent menacer le pronostic vital. Et donc là, l'indication de corticothérapie donc, prend sa place. Maintenant, comment utiliser les corticoïdes? En combinaison des immunoglobulines intraveineux, certes, mais la dose en fait optimale, la durée d'utilisation et les modalités du sevrage, il n'y a pas vraiment de consensus là-dessus et il y a beaucoup de controverses. Donc les deux possibilités thérapeutiques qui ont été relevées dans la littérature, c'est soit en bolus de méthylprednisolone 800 mg par kilo en intraveineux 5 à 7 jours, puis relais par voie orale 2 mg kilo jour jusqu'à normalisation de la CRP et puis donc arrêt en 2-3 semaines. Ou alors de fortes doses de méthylprednisolone, 30 mg kilo jour, 3 jours de suite, avec relais par la prednisone 2 mg kilo jour pendant 4 jours jusqu'à normalisation de la CRP, et puis diminution progressive sur 2 à 3 semaines avant l'arrêt. Voilà, donc en conclusion, et en se basant sur des études récentes, il apparaît raisonnable donc de donner les corticoïdes en association avec les immunoglobulines intraveineux et l'aspirine chez les patients à haut risque. Et cependant, plusieurs imprécisions persistent encore quant à la dose optimale, la durée et les variations selon les différentes populations, les critères d'inclusion, la sévérité de la maladie qui peut donner une grande hétérogénéité clinique. Et puis, le fait que les études qui ont été réalisées sont des petites séries et pas vraiment randomisées, et donc ça peut biaiser un petit peu les résultats. Et puis, comme vous savez, les effets secondaires des corticoïdes, vous savez tous, on n'est pas à l'abri de...
Ok, merci beaucoup, Dr Bouchra, très informative. On peut prendre des questions.
I have the microphone, so maybe I can use it, but I can give it to somebody else, I don't know.
You can go ahead.
It's okay. So I think it's difficult, but for sure I think there is two aspects. The first one is using corticosteroids in addition to something else with the ambition of reducing the occurrence of coronary aneurysm. This is one thing we can think about. There is some evidence, but not so solid. And I have to say that in a subgroup of very young patients, even you give IVIG, corticosteroids, anti-TNF, or even Anakinra, they will be so difficult to treat. And when you have the diagnosis, they already have a lot of aneurysm and this kind of thing. So there is a problem of patient stratification. They are not all the same. And I think that, of course, it has a place somewhere, but I wouldn't be so, because I think it's really very complicated. The other issue is to give corticoids when the patient has not responded to IVIG. I think that in this case, you may find a number of products with anti-inflammatory effect. For sure, corticoids, cyclophosphamide, any type of thing that will end up with the abatement of fever. But any very few of them will have a real effect on the coronary dilation. And we have really to keep this in mind. So I am not saying that we don't have to use corticosteroid. Personally, I don't know how the dose, and you will tell us what is your scheme of administration, because at present it's very difficult to define. But I think we have still now to give or advise, but with a lot of caution, because I think it's still a very difficult subject. But I would like to have other advice, not only mine.
Certes, il y a beaucoup de choses à faire, il y a énormément de travaux à faire, il faut faire des études plus longues, il faut faire des études randomisées pour vraiment tirer de bonnes conclusions quant à l'utilisation de la corticothérapie dans la maladie Kawasaki. Mais elle nous résout beaucoup de problèmes dans les formes sévères et les patients aoriques, sincèrement, quand on donne les corticoïdes dans la série qu'a présentée Nadia, donc vraiment l'inflammation est jugulée rapidement. Oui, et...
Dr. Shkirat,
maybe Isabel wants to give a message that steroids alone, it's not a recommendation. I think that it is the real, I think that it is what she wants to tell us. But as Bushra showed, maybe corticoids in association with IVIG is a good alternative. And maybe IVIG with corticoid and Anakinra, the three therapy is more better than only, yes. Because finally, the only molecule that has been proven to prevent coronary aneurysm is IVIG. For sure. Maybe Anakinra, but for sure, only IVIG.
Dr. Shkirat, thank you for accepting to talk on behalf of corticosteroids. It's a tough thing. It's a difficult topic to defend because there is a lot of controversy, as you said, but also because there's no proof, no solid proof it works well and good enough like we have just heard. You mentioned histopathology and how lymphocytes are being suppressed by corticosteroids. If we go to histopathology of Kawasaki disease, it is not a lymphocyte vasculitis. It is typically a leukocyte vasculitis. And therefore, we need to suppress the inflammatory cascade that works on the leukocytes and all the subsequent elements or preceding elements, including interleukins. So I am personally not a person who will be easily convinced about corticosteroids. I think it masks, it's like a masquerade. It really masks the fever, it shuts down the CRP, but it doesn't really control the cascades that are involved in Kawasaki disease, vasculitis, and subsequent complications. And we don't know what happened in the endothelial cells. Exactly, yeah. But I think I truly enjoyed your presentation. I think it really brings about what is being used and the importance of glucocorticoids. And I think people will continue using it for multiple reasons. One of them is reducing the hospital stay. And probably it does reduce somewhat the cascade to some extent for relief, patient relief, and so forth. But we always have to keep in mind the coronary artery complications, whether or not we are helping much these patients.
Thank you, Naguib. Thank you, Bushra. I think if we realize that MIS-C is one of Kawasaki spectrum. No? Okay. This is my talk tomorrow. It's Kawasaki-like, and the MIS-C is the end of story, or it's the gray zone of Kawasaki. Okay. So, in our institute, if we have a MIS-C, our first choice is steroid. And especially during COVID era, during 20 to end of 20 to 21, the best is steroid once you diagnose MIS-C. And after 21 to 24, if we diagnose MIS-C, we go for steroid without intravenous immunoglobulin, as we know the story. And usually by my presentation, there is regression of coronary involvement and all myocardial involvement by steroid with or without intravenous immunoglobulin if we have a gray zone. So I think it is the best if we diagnose messy and if we diagnose the gray zone, intravenous immunoglobulin and steroid. Is it right? Okay, thank you.
You're always right. Dr. Bushra, it was really excellent. I always honor those who defend the difficult fronts in the battle. But thank you very much.
Thank you.
Merci à tout le monde. On va passer à la prochaine. Donc la prochaine présentation, the next presentation, will be on Anakinra, and the one and only, and no less than Professor Isabelle Cronepot de Paris.
Okay, so thank you very much. I hope that my slides will appear someday. So I would like to thank the organizing committee and Kenza Boyette for the invitation. And now we will talk about the use of Anakinra in Kawasaki disease. So I have to say that the role of IL-1 in Kawasaki disease is one of the topics that have been the most described in the literature by now. But for sure, targeting IL-1 and using Anakinra is not done worldwide. So there is some problems, and also it's very difficult. So what the literature says that, of course, IL-1 is a very important cytokine in Kawasaki disease, and more important, it is really involved in cardiac involvement and especially in the development of coronary aneurysm. In the serum of patients with Kawasaki disease, there are elevated IL-1 beta, but also IL-18, and their antagonist, the receptor antagonist of the IL-1, and also the IL-18 binding protein. And there are also been a number of experiments in mouse that have shown that both IL-1 alpha and IL-1 beta can induce aneurysm formation in those mice, and that these coronary aneurysms are successfully treated with Anakinra. So I would like to tell you, this is clinical rashes, kids with fever. Can you tell me which one has Kawasaki disease? None of these, but really it looks like. So it looks at, and all of these patients have IL-1 mediated diseases. Some are monogenic forms of autoinflammatory diseases, still disease, etc. So, as you know, our main problem in Kawasaki disease is to find a treatment that works in every patient, but also can treat efficiently those coronary aneurysms. And all kids are not equal. And as you know, there are parameters that have been identified that favor the development of coronary aneurysms. And for sure, the natural history of Kawasaki disease, as you know, the risk period for developing coronary aneurysms are the 45 first days of fever. Another important parameter is a delay to treatment, for sure, and also the age of the patients. And we know all that the patients that are less than 1 year have higher risk of developing coronary aneurysm. Another thing important is the level of inflammation. And in this study, if you have low albumin, so a high level of inflammation, you have higher risk of developing coronary aneurysms. Another thing which is really important, that all patients are not the same and there are gender differences. And for sure, male patients are more exposed to develop coronary aneurysms than female. And this is transcriptomic analysis that are shown here, and that you can see that all IL-1 beta related genes are upregulated in Kawasaki disease, but are even more regulated in male patients compared to female patients. And so the IL-1 signaling pathway is very important and is more enhanced. And also, in male patients, you have a greater macrophage polarization toward inflammatory phenotype compared to anti-inflammatory, and we know that macrophages play an important role for the development of endothelial lesions. So this is something very important to note. So Anakinra has been largely explored in systemic autoinflammatory disease, so it's a drug which is really well known from pediatric rheumatologists. So we know that, and for this reason, it's a drug that we can use maximum in the serum of patients. So in case you have any side effect, the drug is not longer in the blood of your patients. So this is really related to safety. But we know also that if we want to have good inflammatory effect, and we'll discuss this after, we need to have elevated doses and up to 10 milligrams per kilo, but in the literature and in some very inflammatory circumstances of cytokine storm, this drug has been used up to 40 milligrams per kilo. So the dose effect is something very important we have to consider. So we have started to explore experimentally the use of Anakinra in Kawasaki disease. We were not the first, because at the same time, the team of San Diego has led a trial which was named Anakid, which was a phase 1/2a dose escalation study of Anakinra. You can see the dose here, 2 to 11 milligrams per kilo per day. And patients targeted to enter this trial were those who had giant coronary aneurysms. So they used Anakinra up to 6 weeks, and at this time it was safe, well tolerated, and you can see that the age of the patient was very low. So even in young patients, it was that very good tolerability. Of course, it was difficult because those patients have giant aneurysms, so they received a number of treatments before Anakinra. So it's very difficult in this study to assess what Anakinra has done and what has done the other drug, and the addition of all of this. Another interesting point, I think, in this study is in some patients who had high dose of Anakinra, they used them intravenously. And I think it's something we have to think about, because the injection of Anakinra are painful, and it's very difficult to use large dose in older patients because it's really painful, and given subcutaneously, it's something really difficult, and I think that it is something important to consider. So this is a Anakinra trial that we have conducted a few years ago. So this trial was a 45-day multi-center open-label study. So we had only a single arm. It was a proof of concept study. So we wanted to assess the efficacy and safety of Anakinra in patients with Kawasaki disease who failed to respond to IVIG. At this time, we accepted that the patient had more than one course of IVIG. So the primary outcome was fever, and we consider the primary endpoint if fever was less than 38 degrees within 48 hours of Anakinra treatment after the last escalation dose, because we had the possibility to increase the dose if the patient was not afebrile. And no corticoids were allowed before attaining the primary endpoint, because we wanted to have the effect of Anakinra alone. So you can see here how the study was. And so the patients were included before 14 days of fever, because after it's very complicated and maybe the fever can resolve itself, so it's very difficult. So you can see that the mean dose of Anakinra that was used in this patient was 4 milligram per kilos. A number of patients had 6 milligram per kilos. We couldn't go to upper dose at this time. And you can see that the time to fever lower than 38 degrees after the less escalation dose was 48 hours. So I have to say that when you use Anakinra, you have to wait a little more for the fever to decrease than when you have a good response with IVIG. It's a little longer, but even there is something of the coronaries. So you can see here in this study, so there were 16 patients. I have to say that among these 16 patients, 15 were boys. So I don't know, it was not really a selection there because patients were more frequent resistant to IVIG. So you can see the decrease of the CRP, and also you can see the physician and parents' assessment of disease activity, and you can see that it decreased very well using this treatment. And also the effect of Anakinra on coronary Z-scores. And you can see that at the screening, a majority of patients had very high Z-score. They're resistant at that coronary dilation. And you can see that 14 days of fever, there was an increasing number of patients who had normal Z-score, and it was maintained at 45 days. So this is a study which has been done in parallel with this study with our colleagues from Germany. And just to show that during the acute phase of Kawasaki disease, there was an overexpression of innate immune mediator like IL-6, CXL10, S100A12, and IL-1RA. And when patients were treated with Anakinra, there was a decrease in both innate and adaptive immune function. And also, they could identify a protein, the LRG1, which is an acute phase protein that modulates the TGF-beta signaling, which is really important in endothelial activation and remodeling, and the LRG1 concentration associated with persistent inflammation and selectively in those patients in whom we had to increase the dose of Anakinra. So this study is finished, and now we are performing the Anakinra trial. So it's a 60-day randomized control open-label trial of superiority with 2 parallel groups, randomly assigned in 1:1 ratio, and matching for age, gender, and drug status. So 13 French units are active in this study, and we hypothesize that we are expecting 30% difference in the response rates between the experimental group that will receive second IVIG and the experimental groups that will receive Anakinra and the control group that will receive IVIG. So you can see here, so if a patient has no response to IVIG, and if has not received prior corticoid, is eligible to enter the Anakinra trial. And there is, of course, they are selected to have either Anakinra or a second IVIG. In the Anakinra arm, they can increase the dose every 12 hours with a maximum of 8 milligrams per kilo. So this study is ongoing. If you want to see all the problems we have, I can tell about that. It's very difficult, so we need really collaborations and okay. So in conclusion, body of experimental and biological data shows that Anakinra can find its place in the treatment of Kawasaki disease, particularly with regard to improving the progression of coronary lesions. Anakinra use appears safe. There are important questions. Which patients should benefit of Anakinra? When? Is there a window of opportunity? I'm sure that there are, and I'm comparing with a systemic GIA. I have to say that in France, Anakinra is widely used in Kawasaki disease. Unfortunately, not in my trial. So there is an ongoing retrospective study with Katerina and Perrine Dusser from my team, and they're analyzing the result retrospectively, but it's not the same thing. And I think we need really to collect a number of data on this. The scheme of treatment, is it better to use it intravenously and then to have in the future higher dose that can be used? So many questions, and we need collaboration, and we need more trials. So thank you for your attention.
Thank you, Isabel. Amazing experience with Anakinra. For me, Anakinra, I have a very limited experience with it. And I started the Anakinra after COVID. Could you highlight, did you started to use this drug before COVID or after COVID?
We started to use this drug before the COVID, and the Anakinra trial started in 2014.
14.
Yeah. I have to say that we have used Anakinra in COVID. We have published our experience, and I have to say it is very effective, very effective. So, and especially in those patients who were in intensive care unit. So, of course, they had all the inotrope.
Yes.
They had also corticoids, but Anakinra was really very effective. And at the end, we did like you. We used corticoids, and it worked very well. And in those in intensive care, we used Anakinra, and it was really fantastic.
And compared to the price, cost effective, compared to Infliximab, Anakinra is more expensive?
I don't know the price exactly of Infliximab. So I think Anakinra, it depends what we call expensive. Anakinra is not so expensive if we compare to
but it's
other
a very long
biologics.
duration. Infliximab, we give just a dose of 10 milligram.
Yeah.
So in our institute, I use Infliximab rather than Anakinra for the cost.
I am not saying that Anakinra is better than Infliximab, this kind of thing. We
Yes.
lack and we don't have comparison in this kind of thing. So I will not do this.
Yes.
I think that both TNF and IL-1 play a role in Kawasaki disease. But if we look at all research immunologic studies that have been done, we have a quantity of data on the role of IL-1 and quite less on the role on TNF. But I am not saying that blocking TNF is not good.
Yes,
So,
I know.
So what is interesting, I don't know, but IVI, if one day we think that we would have a treatment that is better than IVIG, that works in all patients because we have very good biomarkers, we know at day one that it is Kawasaki disease, and for sure, the day we know at day one it's Kawasaki, we will be quite more efficient. Anakinra is less expensive than IVIG. And the duration, it's completely, approximative.
Variable, yes.
I don't know how long we have to use it. In MIS-C, we used it 5 days.
Only 5 days.
In MIS-C.
Yes.
But in Kawasaki disease, we don't know what is the optimal duration. It's exploratory, and all these trials are trying, to approach the best dose.
It could be 15 days up to 3 months for
No. I never use Anakinra for 3 months.
For 15 days?
We use it for 14 days, 2
for
weeks.
2 weeks, just for 2 weeks.
Yeah.
And what is the common side effect of this drug?
The problem is pain at the injection site. And
Yes.
you may have also inflammation, so there are some way to try to diminish this. So, it's conserved in the fridge, so you have to let it out of the fridge for 1 hour, and also you can apply ice, and there are some things to improve, but it's the main side effect,
Okay.
I have to say.
Any questions?
Yeah, I just have a short question. I know we don't have answers to many questions regarding the perfect dose and for how long to give it. But in case of like severe or giant aneurysms, do you use it only up to 2 weeks?
Yes, yeah.
And what's like the starting dose?
So it depends in which context. If you have a giant aneurysm, you are in the initial phase of Kawasaki disease with a lot of fever and these kind of things. We increase the dose until the patient is afebrile and the CRP, frankly, decrease. It's almost personalized medicine. A clinical trial is something different than what you are doing every day. So
you keep the high dose.
yeah, so
for
you
the-
have not to consider that it is a recommendation because we have
Yeah, I
done this. So we have just show you our result using this regimen, you know, but after you know that you have to adapt, and not all patients are the same. So
Yeah, but once like you give the high dose, you keep it till the end of like for the whole duration, like for the 2 weeks.
I don't go over than 14 days,
Oh,
anyhow.
But you
Yeah.
keep the high dose.
But we keep the high dose,
Oh,
yes.
okay.
Yeah, yeah.
Merci beaucoup,
Je t'en prie.
Isabelle.
Merci à vous.
Très bien. So we're gonna do a matching against Anakinra now with Infliximab. We have the pleasure to have Dr. Sima Abu Saud من القدس from Palestine. Thank you very much.
This one, the first one. So I move the. Okay. Okay, so good afternoon, everyone. It gives me great pleasure to be able to participate in this meeting in beautiful Rabat. I'd like to take this chance to sincerely thank the organizing committee and Professor Kinzabou Ayad and the Kawarabi founders and steering committee, and to all of you for making this meeting a success. So, merci beaucoup. My talk today is about the potential use of Infliximab in Kawasaki disease, hoping to rescue the resistant and to protect the young hearts, hopefully. So we go over that during the whole day. We know that the current first-line therapy is IVIG and aspirin. However, still, even if this treatment is given early on and on time, which is 7 to 10 days from the onset of symptoms, 10 to 20% of patients will develop IVIG resistance. And we know that those patients are the ones who are at the higher risk to develop the cardiovascular complications, mainly the coronary artery aneurysms. So in this case, there is a need to escalate therapy. So when we are considering escalating therapy, we should look for a therapeutic agent that is both efficacious, safe, and has a rapid onset of action, all of which make Infliximab a potential therapeutic option. So we had an interesting and very informative talk about the IVIG. We still know that there are limitations and unmet needs. We know that the IVIG resistance will lead to more of a risk of coronary artery aneurysm, and any delay in therapy will lead to irreversible remodeling. But we still don't have standardized treatment in those cases of IVIG resistance. So we're more toward using a second dose of IVIG or steroids. We know that for the IVIG, it's very costly. We have shortages of IVIG, especially in our MENA region. In a study examining the socioeconomic aspects, it was shown that for 100 patients with IVIG resistance, given Infliximab instead could have saved around $825,000. Again, we have the safety issues with using a second dose of IVIG, mainly the hemolytic anemia with the non-blood type O. As for the steroids, again, there are no standardized protocols. There are the side effects. So maybe Infliximab is an appealing therapeutic option. As for the rationale for infliximab use in Kawasaki disease is a cytokine storm. There are lots of high cytokines, among which TNF-alpha is usually very elevated, especially higher levels are detected in those with IVIG resistance. And it's like the vasculitis will lead to endothelial activation and the coronary artery damage. So infliximab is a monoclonal antibody. It acts by neutralizing soluble and transmembrane tumor necrosis factor alpha. It can help in decreasing the levels of IL-6, IL-1 beta, and the inflammatory markers, and it directly blocks the key inflammatory driver in resistant KD. However, infliximab could not reduce the levels of vascular endothelial growth factor and myeloid-associated proteins, so it's not completely blocking the local vasculitis in Kawasaki. So let's move to some of the evidence behind the potential use of infliximab. This study by Tremoli et al. In 2014 about the use of infliximab as an intensification therapy for primary KD patients. It's a phase 3 double-blind randomized controlled trial. It included 196 primary KD patients. So in this study, infliximab 5 milligram per kg was given in addition to IVIG, and we have also the other group, the placebo, and lower levels of CRP at 24 hours in comparison to the placebo group. However, treatment resistance rate did not differ significantly, although the coronary LAD Z-score at 2 weeks was lower. However, it was thought that this study wasn't powered enough to examine the primary outcome in regards of the IVIG resistance between both groups. There were no Civita et al. In 2023 about the use of infliximab for intensification of primary therapy for patients with Kawasaki disease, but this time those with coronary artery aneurysms at diagnosis. So this was a single center retrospective observational study. It included 168 patients. They were acute KD with Z-scores of 2.5 and more at baseline. So infliximab at a dose of 5 to 10 milligram per kg was given within 48 hours of initiating IVIG at 2 grams per kg. So it was found in this study that the incidence of coronary artery aneurysm regression to a Z-score of less than infliximab, whether it is 5 or 10 milligram per kg, although it was the highest among the group with the high dose of infliximab. It was also shown that IVIG together with infliximab at a dose of 10 milligram per kg was significantly associated with a greater likelihood of coronary aneurysm regression compared with the IVIG alone. No significant difference between the IVIG with the infliximab and the IVIG alone groups. Moving to this study by Dion, it's a retrospective multi-center study that included 121 KD patients with coronary artery aneurysms. These scores 2.5 and above, but below 10. They compared 3 primary treatment groups: the IVIG alone, the IVIG with corticosteroids, and IVIG with infliximab. So both the corticosteroid and infliximab groups were found to be independent protective factors against coronary artery aneurysm progression in comparison to the progression versus the IVIG monotherapy. Now, as this study by Son al in 2011, infliximab versus IVIG, a retrospective study that included 106 IVIG-resistant KD patients in 2 centers. In a group, infliximab at a dose of 5 milligram per kg was given, and then another dose of hospitalization. However, treatment groups did not differ significantly in coronary artery outcomes and adverse events. So the Infliximab versus second IVIG for the treatment of resistant KD in the USA, the KidCare study, it's a randomized multi-center comparative effectiveness trial. It included 105 IVIG resistant KD patients in 30 US hospitals. And the primary outcome, there was more resolution of fever at 24 hours after initiation of Infliximab, with no recurrence of fever within 7 days post-discharge. And the mean hospital stay and duration of fever from enrollment were lower in the Infliximab group. However, there was no difference between treatment groups in terms of markers of inflammation or coronary artery outcomes. As for safety, hemolytic anemia was deemed definitely or probably association guidelines 2017. They gave evidence level C for the use of or the administration of Infliximab as an alternative to a second infusion of IVIG or steroids, where it was level B for the use of steroids at a second dose of IVIG. For the guidelines 2024, Infliximab may be considered for intensification of initial therapy for high-risk patients and IVIG resistant KD, and they recommended the higher dose, the 10 milligram per kg. For the American College of Rheumatology, so for the patients with acute KD who are at high risk of IVIG resistance or developing coronary artery aneurysms using IVIG with other non-glucocorticoid immunomodulatory immunosuppressive agents as initial therapy is conditionally recommended. So the level of evidence was very low. As for the Japanese guidelines, they approved Infliximab in 2015 for IVIG refractory KD and recommended its administration within 10th day. For the European consensus-based recommendations, the SHARE initiative, TNF-alpha blockers, including Infliximab, should be considered in KD patients with persistent inflammation despite IVIG, aspirin, and corticosteroid treatment after consultation with a specialist. So level of evidence was 2A. So for practical consideration, the high dose of Infliximab, the 10 milligram per kg is recommended. We give it as a single infusion over 2 hours. As pharmacokinetic studies have shown that when Infliximab is given after IVIG, there will be about 50% decrease in the volume of distribution of the medication in the peripheral compartments. So that's why it's recommended to give the high dose of Infliximab. And generally speaking, it was shown to be safe. Infusion reactions were reported. We know that using Infliximab as other immunosuppressive medications can increase the risk of infection, and they might increase the risk of malignancy. However, we are talking about a short-term and maybe single use of the medication, so no definitive association with malignancy, but we know that the use of TNF blockers can exacerbate heart failure, so probably this is something we should keep in mind when considering an intensification treatment. So in conclusion, using Infliximab as an intensification therapy with IVIG accelerate fever resolution, may reduce hospital stays, and may attenuate IVIG resistance. Current evidence does not demonstrate a significant reduction in coronary artery lesion incidence, but emerging study suggests that higher doses of Infliximab may enhance coronary artery lesion regression in patients with baseline aneurysms. As a rescue therapy for refractory KD, Infliximab has shown reductions in inflammation, fever, and hospitalization duration. Of course, further research is needed, especially prospective and more randomized control trials to establish the optimal dosing regimen, timing for Infliximab administration, predictors of treatment response, and to evaluate the long-term effects on coronary outcomes, particularly in high-risk patients. So thank you very much.
Thank you, Sima. Overview, and just you take many hours during your preparation of these amazing lectures.
Thank you.
This is a lecture. Yes. Any question from the floor? My question. If the patient is a late presenter without an elevated acute phase reactant, just coronary aneurysm, did you start Infliximab or no? If the patient came by accident, we are screening an echo, and we discover a coronary aneurysm with thrombus. And the acute phase reactant is normal, the patient is afebrile.
Yeah.
How we can deal?
Yeah, I think it's hard to answer.
Yes, very hard. I have this patient. I have this patient.
Yeah, it depends. I don't know if the fever resolved recently, for how long.
The patient came just...
Yeah, incidentally.
And he had previously the screening for the PDA. And we discovered this coronary aneurysm and thrombus and myopericardial involvement with normal CBC. The patient is afebrile and acute phase reactant are normal.
Yeah, I think I wouldn't give Infliximab.
I started this patient Infliximab with very good result. This is my story. This is a case-by-case definition.
Yeah.
What is your comment, Naguib? Yes? What is your interpretation?
Well, I cannot tell for sure. The thing is, it really depends on how far off are we from the acute phase, because yes, there is continuous inflammation, in situ inflammation in the coronary arteries. Whether or not in this case there was an acute, subacute inflammation, in situ inflammation, not the systemic inflammation, we ignore that, we don't know. And we don't have any markers. You did not do any imaging testing to prove or not to prove. Even this testing don't really exist. So I would say the hypothesis that this patient had ongoing subacute inflammation in the coronary tissue, and good enough, it helped apparently, why not? Does it mean that we should for every patient? Yeah. That's a yes, the answer, we don't know. Yeah, so good for her, lucky, good job. Thank you, Sima. Let's go to the next acute therapy before getting to the anticoagulation treatment with Dr. Zahra Fitouri from Tunis to cover cyclosporin treatment in Kawasaki disease, acute KD.
Ça ne ressort pas ici. Ah, c'est bon. Ça marche, c'est bon. Merci au groupe Kawarabi pour votre engagement. Merci pour Kenza pour nous avoir permis donc, ce meeting pour parler de tous ces aspects-là dans notre vécu. C'est important, toutes ces discussions. Donc, je vais parler de la cyclosporine dans la maladie de Kawasaki en dehors du syndrome d'activation macrophagique. Et je vais zapper l'introduction juste pour gagner du temps. C'est juste pour dire que à la fin de cette session, au fait, tout notre problème, c'est quel traitement, le traitement optimal pour la prévention des anévrismes, de la survenue des anévrismes coronaires, particulièrement dans les syndromes de Kawasaki résistants, à une cure, voire à 2 cures de vénoglobuline, et sinon les autres maladies de Kawasaki qui sont suspects d'être résistants donc, aux vénoglobulines. Donc, il y a eu bien sûr les recommandations de l'achat donc parues en décembre 2024 et tous les aspects donc ont été pratiquement entrés en revue. Et donc, les problèmes dans la littérature se posent encore plus avec la cyclosporine parce qu'il y a très peu de patients dans le monde traités par la cyclosporine. Et donc, il y a essentiellement des case reports et des séries de cas, souvent un nombre petit d'enfants traités. Et les protocoles thérapeutiques sont variables, donc ça rend peu comparable et les conclusions un peu plus difficiles que pour les autres molécules. Alors pourquoi la cyclosporine dans la maladie de Kawasaki? Ça se justifie par la pathogénie. Dans l'étude de la génétique des populations, on a pu confirmer qu'il y a un polymorphisme génétique qui prédispose à la fois à la maladie de Kawasaki, à la résistance aux vénoglobulines et à la formation donc des anévrismes coronaires. Au fait, le polymorphisme intéresse deux molécules essentiellement dans la maladie de Kawasaki, l'inosole triphosphate kinase et la caspase 3. Au fait, le variant pathogène de l'inosole triphosphate kinase va diminuer l'activité de celle-ci, qui est normalement inhibitrice de la voie de signalisation du NFAT, qui va, lui, s'il est activé, va activer, donc il y aura une activation lymphocytaire. La diminution, donc le variant pathogène de la caspase va diminuer l'action de celle-ci, donc diminution de l'apoptose, augmentation donc des phénomènes pro-inflammatoires et leur pérennisation, et toutes donc ces anomalies inflammatoires donc vont activer davantage ces cellules lymphocytaires. Et d'ailleurs, sur des études autopsiques des artères d'enfants décédés par Kawasaki, on trouve qu'elles sont infiltrées par des cellules, donc des lymphocytes, aussi bien T que B. Et donc, il paraît tout à fait raisonnable que si on inhibe la voie donc, du NFAT par un inhibiteur de la calcinurine, ce serait une bonne option pour le traitement de la maladie de Kawasaki. Alors, la cyclosporine dans la maladie de Kawasaki résistante, c'est déjà, on en parle depuis 2011, même si les séries sont petites. Dans une étude pilote japonaise, donc, il confirme que elle entraîne la pyrexie dans les 3/4 des cas, donc, et diminue l'inflammation biologique. Par contre, ils ne peuvent pas confirmer que ça diminue la survenue des anévrismes coronaires. Et donc, ils concluent quand même que c'est un traitement qui est sécurisant, malgré qu'ils ont eu quelques cas d'hyperkaliémie, mais qui n'ont pas justifié l'arrêt du traitement. Dans les séries nord-américaines, les cas sont encore peu nombreux, mais les protocoles sont un petit peu différents. Et depuis 2017, dans les recommandations de l'achat, la cyclosporine peut être donc un traitement de la maladie de Kawasaki résistante, mais en troisième intention, après avoir essayé l'infliximab ou les corticoïdes. 8 ans après, cette même donc, équipe japonaise va publier un essai, l'essai Kaika, qui est l'étude pratiquement qui a porté sur le plus grand nombre de malades. C'est un essai qui est randomisé, contrôlé et ouvert. Et il a comparé deux groupes, le groupe traité par un traitement conventionnel par rapport au groupe qui a traité par le traitement conventionnel plus la cyclosporine. Et il a évalué au jour 3, la semaine 1, 2, 3, 4 et à la semaine 12, à la fois cliniquement, biologiquement et bien évidemment sur les données de l'échographie cardiaque. Il a reposé bien évidemment sur les critères japonais, donc essentiellement à la semaine 12, c'est-à-dire sur le diamètre intraluminal. Par contre, après, il a calculé les Z-scores, comme prévu par les dernières recommandations de l'achat. Les résultats de cet essai ont montré que déjà, il y a une incidence qui est plus basse de la survenue des anévrismes coronaires dans le groupe qui est traité par cyclosporine par rapport au groupe traité donc par le traitement standard. Et c'est une diminution avec donc une différence qui est significative. Par contre, quand il prend chaque date d'évaluation, il ne trouve qu'il y a une différence significative que pour la semaine 2. Par contre, pour les Z-scores, le Z-score moyen dans chaque groupe, le Z-score pour chaque artère coronaire et les Z-scores entre 2,5 et 5, donc la présence d'anévrisme, il trouve qu'ils sont analogues dans les deux groupes. Par contre, dans le groupe du traitement conventionnel, il y a survenu d'un anévrisme donc avec un Z-score supérieur à 5, donc de moyenne, donc taille moyenne, et les enfants qui ont un Z-score supérieur à 3, il est plus important dans le groupe du traitement conventionnel. Les autres résultats de l'étude KAIKA, c'est une durée de la fièvre qui est moins importante dans le groupe cyclosporine, une réduction plus importante donc, de l'inflammation dans ce même groupe. Par contre, la résistance au traitement était plus importante dans le groupe traité uniquement par les vénoglobulines. Cependant, le taux de rechute était plus élevé dans le groupe cyclosporine. C'est parce qu'ils ont été traités pendant uniquement 5 jours, alors que les autres protocoles recommandent une durée plus prolongée. Et d'ailleurs, il y a eu une durée d'hospitalisation plus longue liée à ces rechutes, mais pour autant sans avoir plus d'anévrisme coronaire malgré ce nombre de rechutes plus important. Le recours à un traitement de 3e ligne après était le même dans les deux groupes, avec des effets indésirables qui étaient comparables dans les deux groupes. Donc, il conclut que c'est un traitement qui est efficace pour la prévention des anévrismes coronaires puisqu'il diminue leur incidence, donc ce traitement par cyclosporine plus vénoglobuline, et que la cyclo est bien tolérée. Dans la discussion, il conclut que les résultats sont presque les mêmes que ceux obtenus avec les corticoïdes, donc ils diminuent de 17%, alors que pour les corticoïdes, ça diminue de 20%. Et d'ailleurs, dans d'autres séries de cas, et dans une méta-analyse de 5 études, il parle d'un effet presque le même, donc analogue comparable entre prédnisolone et cyclosporine, surtout chez les enfants traités d'emblée par ce traitement-là. Il y a même une étude qui a démontré que la durée d'hospitalisation et le coût étaient plus élevés avec la prédnisolone qu'avec la cyclosporine. Là, c'est juste une étude donc récente publiée en 2025 donc d'un hôpital californien qui a inclus des malades qui ont des anévrismes coronaires. C'est une étude rétrospective, mais donc il a inclus des malades soit qui sont résistants aux vénoglobulines, soit parce que ils ont des anévrismes coronaires. C'est juste pour dire que dans les séries nord-américaines, la durée, elle est beaucoup plus prolongée. Vous voyez qu'elle est de 28 jours pratiquement pour ceux qui sont traités pour des anévrismes et de 41 jours pour l'autre groupe. Et dans cette étude rétrospective, il trouve que le Z-score diminue de façon significative aussi bien à la 2e semaine qu'à la 6e semaine, et le résultat se maintient et s'améliore même avec 1 an de recul. Le protocole préconisé par l'AHA et rappelé dans cet article, c'est qu'on utilise le nez oral et pas une autre forme parce que le nez oral est plus stable que les formes génériques qui existent sur le marché international. On donne la dose de 5 mg par kilo par jour, divisé toutes les 12 heures, et cette dose-là permet au fait d'avoir une cyclosporinémie maximale, donc 2 heures après la 3e dose, entre 300 et 600 nanogrammes par millilitre, associer systématiquement le magnésium pour prévenir l'hypomagnésémie tout le long du traitement, et bien sûr la surveillance de tous les effets indésirables et des paramètres de l'inflammation, bien évidemment, et on commence à dégraisser quand l'enfant devient apéritique, en bon état général, et que la CRP est inférieure à 1 mg par décilitre, ce qui prend en moyenne entre 10 et 15 jours. Et on diminue de 10% la dose tous les 3 jours jusqu'à ce qu'on arrive à 1 mg/kg, et on peut arrêter à ce moment-là. Là, c'est juste une méta-analyse, une network méta-analyse avec de 56 essais randomisés. 6000 enfants sont traités par corticoïdes. On les a comparés à 179 enfants traités par cyclosporine et il conclut que la combinaison du traitement par des doses élevées donc de vénoglobuline, donc les 2 grammes kilo, avec les bolides de corticoïdes, ou donc l'association vénoglobuline plus cyclosporine pourrait avoir un effet additionnel en améliorant à la fois le taux d'apérixie, donc la bonne réponse thérapeutique sur le plan clinique, sur le plan fièvre, et aussi pour diminuer le taux d'incidence des anévrismes coronaires. Donc ceci pour conclure que la cyclosporine semble un traitement raisonnable parce qu'il vise un mécanisme pathogénique défendable, que les indications, c'est essentiellement la maladie de Kawasaki résistante, où on peut le donner, donc associé, on doit la donner associée à 2 grammes kilo de vénoglobuline, que aussi c'est indiqué chez les enfants qui ont un haut risque donc de résistance, comme l'a démontré donc dans l'étude KAIKA et dans d'autres études. Aussi, pour ceux qui ont des anévrismes coronaires, on a pu les stabiliser, voire les voir régresser. Donc, pour les traitements associés aux autres molécules, les études sont préliminaires, on n'a pas assez d'arguments. Peut-être on parle d'association corticoïde et cyclosporine, mais pourtant, c'est une action immunosuppressive importante et donc on préfère ne pas associer les deux à la fois. Le protocole est mieux codifié qu'auparavant et bien évidemment, les perspectives, c'est peut-être des biomarqueurs d'efficacité pour ce traitement et éventuellement combiner les différentes molécules ciblées, donc de ces différents thérapeutiques, pour pouvoir avoir un effet éventuellement synergique sur la prévention des anévrismes coronaires. Et merci.
J'ai une question quand même, s'il faut préconiser, s'il faut considérer ce traitement, est-ce que vous direz que 5 jours serait le traitement à donner, ou plus étant donné le risque de relapse?
Non, 5 jours, franchement. Pratiquement, il n'y a aucune pathologie pédiatrique qu'on traite par 5 jours de cyclosporine jusque-là. Et il y a un taux de rechute qui est important. C'est évident, c'est l'étude la plus argumentée scientifiquement, c'est l'étude KAIKA. Et là, il y a un taux élevé donc, je serais plutôt pour des durées prolongées. Et j'ai trouvé des case reports qui ont été traités pendant 8 mois. Ils étaient réfractaires à toutes les autres molécules. Et il a reçu 8 mois de traitement.
Wow, c'est sûr que quand on parle de quelqu'un qui est récalcitrant à plusieurs traitements, et après ça, c'est une autre approche. Ouais. Mais quelqu'un qu'on va continuer, vous direz comme so someone who's not resistant to multiple therapies. You said to multiple therapies, you've seen cases or read about cases who've been treated for 8 months. How about those? What's your opinion in those who had not shown any actual resistance to multiple therapies? Would you give it for, I don't know, 2 weeks, 1 month, anything over 5 days? What's your opinion?
I think on devrait avoir la durée du moins de la phase de convalescence, toute cette durée de la maladie où on peut avoir de l'inflammation. Je pense que 15 jours, 3 semaines, c'est une bonne durée, comme préconisé par la plupart des séries nord-américaines.
Any other questions?
Non, je crois qu'il y a très peu.
To have some experience. Yeah.
Mm.
Yeah.
Il y a beaucoup d'effets indésirables, bien évidemment, l'insuffisance rénale. Et là, il faut juste contrôler donc, les taux de la créatinine avant de démarrer le traitement. Hépatique éventuellement, une hyperkaliémie, une hypomagnésémie, Mais c'est des effets indésirables qui n'ont pas amené à arrêter le traitement uniquement, peut-être dans la série nord-américaine. Ils ont arrêté le traitement à cause d'un pré-syndrome chez un enfant. Et chez un deuxième, il a présenté un syndrome lymphoprolifératif EBV et dépendant. Donc, ils ont dû arrêter le traitement pour 2 malades. Yes.
Okay, thank you very much. So we're moving to the final talk about anticoagulation. It will be presented by Dr. Fahad Al-Ahmadi from Saudi Arabia.
Yes. Parfait. Merci. Comme ça? Ok, c'est bon. Bonsoir à tout le monde. Merci beaucoup pour l'invitation. C'est mon première fois ici à Maroc. Ça fait longtemps que je n'ai pas parlé en français. Et c'est quelque chose d'important pour moi. Je vais parler de le traitement antithrombotique dans la maladie de Kawasaki. Il y a plusieurs diaporamas que je vais passer parce qu'elle était déjà visitée par des autres collègues. L'épidémiologie, la pathophysiologie, on le connaît bien. Pourquoi l'antithrombotique thérapie dans la maladie de Kawasaki? Parce qu'on sait que le mécanisme de thrombose dans la maladie de Kawasaki, il est le stase anévrismal, dysfonctionnement endothélial et hypercoagulabilité dans la maladie aiguë. Et la stratification de risque dans la maladie de Kawasaki, le critère principal, il est par utiliser le score Z. Mais après, il y a des autres critères de haut risque qui doivent être respectés dans les patients de Kawasaki. Le traitement de la phase aiguë, il était déjà visité. Et après, on va mettre le patient dans des catégories différentes, dépendant en le Z-score de coronaire. Sur les patients qui n'ont pas d'attente coronaire, c'est les patients qui ont un Z-score moins de 2. La prise en charge, il n'y a pas de traitement antithrombotique, c'est juste l'aspirine qu'on peut arrêter entre 4 à 6 semaines. Pas de suivi à longue durée par des cardiologies et juste un conseiller général de santé cardiovasculaire comme tout le monde. Les patients qui ont une dilatation seulement, c'est les patients qui ont un Z-score du coronaire entre 2 et moins de 2,5. La prise en charge, c'est pareil, comme les patients qui n'ont pas d'attente coronarienne. On peut arrêter l'aspirine 4 à 6 semaines. Mais par contre, ces patients doivent avoir une surveillance annuelle jusqu'à la normalisation de coronaire. Le petit anéurysme, c'est les patients qui ont un anévrisme entre 2,5 et moins de 5 de Z-score. Le traitement, c'est pareil, aspirine, à vie, c'est résistance, et en alternative, c'est le clopidogrel en cas d'intolérance. Les patients qui ont un anévrisme de taille moyenne, c'est les patients qui ont un Z-score de 5 jusqu'au moins 10, avec un taille absolue qui doit être moins de 8 mm. Le traitement, c'est traitement antiplaquettaire, aspirine. On peut ajouter clopidogrel comme un deuxième. Il y a des autres traitements qui étaient montrés en effet sur les parois endothéliales, c'est comme le statine et les vitamines A et I. Les patients qui ont un anévrisme géant, c'est les patients qui ont un Z-score plus de 10 et en taille absolue plus de 8, plus ou égal 8. Le traitement, c'est aspirine et anticoagulation. L'anticoagulation peut être par warfarine, enoxaparine, et le nouveau traitement, c'est l'anticoagulation orale directe. C'est le futur de traitement. Le choix entre warfarine et enoxaparine, ça dépend de la pratique et ça dépend de la médecin et son préférence. Il n'y a pas de choix à 100%, mais d'habitude, on utilise warfarine plus que enoxaparine. Le scénario à haut risque, c'est les triples thérapies. Parfois, on va avoir besoin de triple thérapie, aspirine, clopidogrel et anticoagulation. En cas de thrombose récente, risque hémorragique, le prophylaxie gastro-intestinal, l'EPP, il est important. On doit éviter le sport de contact, et dans la grossesse, le choix de l'anticoagulation doit être changé par l'enoxaparine. Le nouveau thérapie, l'anticoagulation orale directe, dans la maladie de Kawasaki, il n'y a pas d'études qui montraient, il n'y a pas assez d'études sur l'utilisation en maladie de Kawasaki, mais la majorité des publications, c'est sur les thrombose profonde et l'approche posologique, elle est quand même limitée parce qu'on n'a pas de posologie standard pour tout le monde, et la posologie, elle est dépendante sur la taille et le poids du patient. Il y a des différents agents qu'on peut utiliser, mais honnêtement, le seul problématique, c'est qu'il n'y a pas de posologie qui était décrite seulement pour le Kawasaki. Of course. So, direct oral anticoagulation. In Kawasaki, the use of oral direct anticoagulation is not yet standardized in Kawasaki disease. It have been used for deep venous thrombosis, and the dosing approach is based on that. For example, the rivaroxaban, the posology is from 0.8 milligram kilo to 1.2, and other agents does not have similar posology. And there is no evidence of their use and their doses in Kawasaki disease. So we have to educate the patients and their caregivers about recognizing the MI symptoms, especially in patients with large aneurysms. And we have to remember that patient can change category by the follow-up. So patient with giant aneurysms can be treated as if there is regression as large or medium or even no dilatation depending on the follow-up. So risk stratification using the Z-scores and high-risk features. Aspirin is a backbone for the treatment. Anticoagulation based mainly on the Z-score of coronaries, and we need to monitor bleeding. Special population in patients that are pregnant, we use low molecular weight heparin, and future treatment is direct oral anticoagulation, and statins may redefine the care in the future. Merci pour votre attention.
Thank you very much for your informative talk. So I have a question. So in patients who have coronary artery aneurysms that...
I will respond in French. Okay? It's okay. No, it's okay, it's okay.
OK. So pour
Pour
les patients
OK, parfait.
qui ont des anéurysmes
Géant.
géants, non,
Oui.
qui régressent.
Qui régresse, ça dépend de la régression.
Oui. Est-ce qu'il faut continuer à donner l'aspirine?
Moi, pour moi, personnellement, oui. Je le laisse, oui. Yes. But by definition, if the regression is to normal, there is no indication. But there is no.
They say there will be like ongoing
I don't think.
inflammation, and this might lead to damage in the future. So
I think the most important is the cardiovascular, le santé cardiovasculaire. Come on. Now I cannot say it in English. The lifestyle habits that are important more than the treatment by itself, because I think in the future we will look at more things than the dilatation and disease score of the coronaries.
Nadine? Come here, Nadine, please.
But they should be followed by cardiology. Yeah, it's resolved completely, but not.
Yes.
I think I will be having trouble stopping the aspirin.
So I think the main thing here,
because I'm attached to my patient. So a patient with Kawasaki, I'm not.
The main
with dilatation, I'm not going to send him home.
The main issue here is what is an aneurysm. If anything with a Z-score more than 2.5 is called aneurysm, it's misleading, no matter what we know about this. So if we have these patients with saccular aneurysm or large fusiform aneurysm, there is most definitely an injury to the vascular layer. We've seen this in OCT imaging, and we have seen that these patients who regress the anatomical size, they maintain huge destruction of the coronary artery walls, and they develop calcification, they develop fibrosis, they have macrophage inclusions and so forth. So this anatomical regression is not safe. This regression in size is not healthy. There is continuous scarring, subacute chronic inflammation. I will not stop aspirin. I would very likely stop anticoagulation anytime the Z-score becomes less than 10 or 8, so I give it some time to make sure it's much less than 10, Z-score, for the anticoagulation. But antiplatelets, I would continue using antiplatelets in these cases. Now, I think Dr. Schweiter was referring to those who would have the so-called aneurysm by Z-score definition only, where the coronary arteries have increased in size acutely and then regressed within a few weeks or several weeks to a few months. These, we don't have any solid evidence that there is an actual severe or less severe injury to the vessel walls. And I'll feel very comfortable stopping aspirin like it is recommended by HA.
Thank you, Fahad. Concerning what Naguib tell, what is the definition of aneurysm? I think the gray zone is here between 2 and 2.5. It's brightness and ectasia. The brightness and ectasia, I think we should do something. Aneurysm, we should do whatever small or moderate or large aneurysm by antiplatelets and anticoagulant. So the ectasia, for how long we are following this ectatic or brightness of this coronary, for just 8 weeks, or for 1 year, or for 2 years. For me, ectasia, I am following till 2 years. What is the opinion from the attendees for the ectasia? Okay. The point is the WAC. Did you use DWAC in infant or not?
Use what?
DWAC.
No.
No? But is the guideline?
There is doses that
Yes.
are for small prematures and
no infant and not premature.
Even for prematures. The issue with the direct oral anticoagulation is that we have to discuss every case with the hematology
Yes.
team and also the pharmacology, clinical pharmacist. So it has to be multidisciplinary because it has a lot of modification and a lot of changes in the regimen. So I think just for safety and for medical legal aspect, because it's not, there is no evidence of using it in Kawasaki disease, I think it should be done in a multidisciplinary team.
My last comment, what about the MI and the complication of Kawasaki? Did you have a mortality in your series, in your cohort, for the Kawasaki disease, mortality?
I don't have a cohort. Which cohort you are referring to?
For KD, for the KD patient. Did
No,
you have any mortality?
No, zero mortality. I haven't seen any mortality during my fellowship, my residency, and no, because we have the godfather of Kawasaki disease with us in Montreal.
So, MI mortality, stay tuned for the next meeting of Kawarabi. Be there, book your tickets. Okay, we love you all. Isabel.
I believe in personalized medicine. So there is guidelines. So I have to present guidelines, but without any specific patients. Every patient should be treated differently if there is a need to treat or to go outside of the recommendations. I wouldn't have any problem adding anticoagulation for patients that are at risk.
I want to make two comments. The first one is, one of the common questions that we used to get is, what do you do when a child who's having evolving enlarging aneurysm, and do you treat with what agent, anti-inflammatory or anticoagulation? So the newest guidelines, 2024, adapted our pathway. So now we have an actual pathway there, as you see the aneurysm going, what to do. And then for the question about MI and anticoagulation, we don't have long-term data on direct oral anticoagulants because it's new, so we don't have tons of data on that. But we do have from IKDR data on heparin versus Coumadin. And what the data showed over the 10-year follow-up, there is no difference in major adverse cardiac events, whether you start the child on Coumadin or heparin. But if you don't put the child on Coumadin or heparin for those with giant aneurysm, you do see a higher rate of adverse events. So the choice is between you and the family to decide. Do you want to have INR monitoring versus low molecular weight heparin? And nowadays, many centers have started direct oral anticoagulants, and we have given it to infants as well, but with the hematologist.
Are the dose of a direct anticoagulant defined, especially in very small infants and this kind of things? Which dose do you use?
So I'm I'm going to be very honest with you. So it has to be FDA approved for a certain age, and I don't really prescribe it. I ask my hematologist, and as a matter of fact, we do have our own cardiology INR team that does not manage direct oral anticoagulants. So we have to get hematology.
Just a small research that I did for the presentation for the direct oral anticoagulation, because it's interesting for me also. It's very hard to find specific dosing for newborns or children dependent on their age. So that's why I said it should be discussed in multiple teams.
Je vous remercie pour votre excellente présentation.
Merci.
Ma question est, quand un patient a un anévrisme géant, et puis il développe un thrombus au sein de l'anévrisme, sachant que le patient est déjà au préalable sous deux antiagrégants plaquettaires. Est-ce qu'il faut le remettre sous anticoagulants, traxiparine, héparine de bas poids moléculaire, et voir comment ce thrombus-là va évoluer par la suite, et reprendre les antiagrégants plaquettaires, ou bien il faut le remettre sous AVK et stabiliser la situation tout en espérant.
Votre question, s'il y a un thrombose qui se
Au
forme.
début, il n'y avait pas de thrombus.
Il n'y a pas de thrombus.
Géant, il n'y avait pas de thrombus. Par la suite,
Oui.
il fait un thrombus. Donc, on remet le patient sous anticoagulant,
Oui.
et puis les antiagrégants,
Oui.
ou bien on maintient juste les antiagrégants.
Les deux.
On traite. Voilà.
So the question, if a patient had aneurysm, giant or less giant, but did not have a clot, and then suddenly at some point we see a clot. I think you should consider two things always in this condition, the circumstances. One, did the clot form because there is stagnation and therefore there is aneurysm and stagnation and the clot has developed? And second, did the patient have stenosis? Without necessarily giant aneurysm, whenever you have stenosis, you can give the heparin of the hell, you can give all the anticoagulation, there will be a clot.
Just dilatation.
It doesn't matter. It doesn't matter, okay? So you have a patient today you have not seen for 2-3 years. He's not on medication, and there is a clot. You need to rule out two things. How big is the aneurysm, and is there a stenosis? So you need a scan, coronary scan, or you need to do selective angiography. Obviously not when the clot is there and active, but you certainly have to make sure that there is no stenosis. Okay, because stenosis will create a cause to have a clot. Now, let's say you start RTPA, which is thrombolysis, and you dissolve the clot. Again, you need to make sure there is no stenosis distal to this lesion, because you need to relieve the stenosis. You need to operate or put a stent or whatever you need to do. And therefore, if there is absolutely no stenosis, certainly you need to put the patient on anticoagulation. If there is stenosis, you need to treat stenosis first and then assess for the risk of stagnation. I mean, cardiologists, we are simple. Our life is simple, our science is simple. Either it flows or doesn't flow. We're not that intellectual like Anakinra, IL-6, IL-1. Yeah, so I'm an interventionalist, and they ask me, what do you do? I say, if there is a hole, I shut it down, I fix it. If there's no hole, I open it. So that's what we do, right?
The point, I am interventionist. I didn't do any intervention for KD patient, even with huge aneurysm and even with stenosis. When you are referring the patient for a cath lab.
When what?
You refer the patient for a cath lab.
Well, I used to do a lot of cath for coronary arteries, and it used to be the method of choice for to assess and follow for stenosis, development of stenosis or not. So I'm very familiar, very at ease in putting catheters, injecting dyes, and so forth. But things have changed. Imaging, non-invasive imaging has greatly improved. So when do I do cath nowadays is when there is indication to treat. and not necessarily when there's indication to see whether or not there is stenosis. Now, if there is stenosis not clear on non-invasive imaging, I will go very easily and put a catheter and inject and see what's going on. Okay, so the question, if there's a clot and MI, do you use local in situ inside the coronary artery, the thrombokinase, or do you use peripherally? I think, well, our hematologists at Registry in Montreal, they are scared of automatic bleeding, intracranial bleeding, so they prefer not to give peripheral. Although so many series, so many people use systemic thrombolysis and it works perfectly well. The risk of bleeding is always there, of course. The advantage of in situ or intracoronary RTPA is that you use lower dose, but you have to wait for 1, 2, 3 hours, and also partially obstructing the flow with the catheter. So you have to convince your hematology team. My preference is to give systemic rather than in situ. Remember that if you put your catheter inside a coronary artery and there is a clot, while injecting, there's a risk that you cause swirling and you bring the clot or part of the clot proximal and it goes in the circumflex, for instance, so you worsen the situation sometimes. So my inclination is to give RTPA as a systemic IV. I think everyone has asked all the questions for Kawasaki disease. Would like to thank everyone. Merci beaucoup, mon ami.
Merci beaucoup.
We come to a close. I think either Nadine or Kenza would have to tell us what's going on for tomorrow, please.
So thank you all. Do you want to speak, Kenza? Or okay, fine. Okay. So thank you all for coming today. I also want to thank our IT team right there in the back. And so tomorrow we're going to start at 9 o'clock with the EKG workshop. And then after that, we have another session on the skin manifestations in Kawasaki disease with very interesting cases and great speakers. And then after that, for the steering committee members of Kawarabi, we're having a meeting at 2:30. And tonight, we're going to have dinner here. But before we have dinner, we were hoping we can get a picture of all of us in Kawarabi at the stairs. What? Yes, everybody here is invited to take a picture on the stairs. And I think we have a photographer there who can help us with that photo. Okay, thank you.
And there is another workshop tomorrow morning about ultrasound, joint ultrasound at 9 o'clock. So join us, please, if you are interested. And between 8:30 and 9, there will be the selected oral communications. Thank you. For pediatrics.